Greetings, everyone. Good morning or good afternoon, wherever you are around this world. Welcome to the first IJMS International Journal of Medical Students World Conference of Medical Student Research. We have received over 100 submissions from different 30 countries from all over the world, and we have selected the best 40 abstracts to be with us here in this big special event for us at the IJMS. IJMS has started its effort to build this platform to represent young researchers and scientists in the field of medicine since 2009. And now, I will be your host for this event, Dr. Duha Shilla. Let's start our event and hear Dr. Francisco Pinella Escobar, our editor-in-chief.
Good morning, everybody. Thank you, Dr. Shella, for the introduction. For us, it's a great pleasure to count and have you all together in this first International Journal of Medical Students, IJMS World Conference of Medical Student Research. The IJMS was a dream of 3 medical students back in 2009 in their clinical and preclinical years of med school. Their dream was to create a platform for scientific publications for early career scientists and medical students across the globe. They found that there was a gap in opportunities for medical students publication, and that's how they come together to create this opportunity and this platform for all. I have been editor-in-chief for 8 years in the International Journal of Medical Students, and it's my pleasure to see and to tell you how the journal has grown in the past 10 years. So far, we have reached an online presence of almost 20,000 followers and fans across YouTube, Facebook, LinkedIn, Instagram, and Facebook. Not only that, but the journal has reached also more than 100,000 views of the articles that we publish. We are now indexed in several different platforms, and we are aiming to be indexed in PubMed and Web of Science in this and the following year. The journal is publishing now 4 issues per year, which is also an amazing accomplishment for a medical student journal. Our rejection rate or acceptance rate have increased also, increasing the quality of the work that we publish. And right now we are around 19% acceptance rate, which means that the quality of the work that we're publishing is higher and higher. Humble but proud of the work that we have done with more than 100 medical students around the world, we can tell you today that the IJMS is the most important and biggest medical students platform for publication. The dream that these 3 medical students had back in 2008, we can say today that this has been materialized and the journal is growing strong and bigger every year. After these 10 years of continuous publication, we are celebrating this historic moment with the creation of the IJMS World Conference of Medical Student Research. This is the first event of its kind, as there are other conferences for medical students, but none of them has this background or this supporting platform as the IJMS. For us, it's a pleasure to share with you this conference. We hope that you can enjoy it as we did creating it. This first World Conference won't be possible without the work of medical students and early career scientists around the globe that had participated and committed their time and efforts for making this possible. Special thanks to Dr. Cesare Mercalli and Dr. Purva Shah, who have taken an extra step for making this conference possible. Thank you all for joining us. For them, our deepest thanks and congratulations for such a wonderful organization. There are so many names that we should mention. They will be acknowledged. Our abstract book is going to be published, including the winners, the people that is participating in the conference. It is a pleasure for us to have you all here. We hope that you can enjoy the conference as they did preparing it. This is going to grow bigger and bigger with time, and we expect that our founders' aim of promoting medical student research will be reached with this new organization, with this new initiative from the journal. Thank you, everybody, for joining us today, and we hope that this conference can give you opportunities for growing in research, for learning, but why not to create collaboration bonds between medical students that are presenting their research, that are participating and joining us together today. We will have people presenting from more than 30 countries, which is a very exciting starting point for a world conference. We hope to see you also next year, and we hope that you enjoy the conference. Thank you very much for being here today.
Thank you, Dr. Francisco. I would say something you already said, humble but proud. We all, maybe you can see me only on this screen, but I know there's a lot of people who devoted their time to make this happen, to make this real. From idea to reality, we are here today. And now, let's start our celebration and to introduce our first session judges. Our judges for this session will be Dr. Vlad Dionys, Assistant Professor at Carol Davila University of Medicine and Pharmacy, Bucharest, Romania, and Dr. Jose Adrian Yamamoto, Hospital General Regional Institute Mexican del Seguro Social at Mexico City. Welcome. Our first presenter will be Dr. Harshita Choudhary, MPPS intern at Maulana Azhar Medical College, New Delhi, India. And the title of her presentation will be Macrophage Activation Syndrome in Adult-Onset Still's Disease, a Life-Threatening Complication. You can start.
Thank you so much. I hope my presentation is visible. So just to introduce myself, I'm Harshita Choudhary, an MBBS intern, and I'll be the presenting author. My case history: a 39-year-old female housewife resident of Delhi, India, came to the OPD with chief complaints of fever on and off for 6 months, along with multiple joint pains on and off for the past 6 months. The fever, she had 2 to 3 episodes of fever per day, high grade, associated with chills, and they were only relieved minimally by medications. This was associated with multiple joint pains, symmetrically involving the proximal shoulder and the knees and the distal joints, the metacarpopharyngeal, proximal interpharyngeal, and distal interpharyngeal joints of the hand. It was associated with swelling. Early morning stiffness was present, which was only relieved on activity. There was no history of rash or any other skin lesion, oral ulcers or alopecia, no history of diarrhea, burning micturition, urethral discharge, no history of dryness of eyes or mouth, and no history suggestive of any other organ involvement. There was no history of close contact with any animal or foreign travel in the recent past. The past history: the patient is a known case of diabetes mellitus type 2 on medication and an old treated pulmonary cox. There's no significant personal or menstrual or obstetric history present in the patient. On examination, significantly, pallor was present, along with the vitals of the patient was stable. On systemic examination, on per abdomen, we found that the liver was felt 2 centimeters below the right costal margin, suggesting hepatomegaly, along with joint swelling present in the proximal joints like the shoulder, knees, and the distal joints like PIP, DIP, and MCP, as confirmed after the history. So right now we have a patient with fever, high grade for 6 months, along with polyarthritis. So after we started working up this patient, we ordered some preliminary investigations, and we found out that the hemoglobin was drastically low, about 5.2. The total leukocyte count was 24,000, and it suggested neutrophilic leukocytosis. The platelets were 5.9 lakh, and the ESR was 141. We further went on to confirm our examination findings, and we found that hepatomegaly was present. The blood cultures, urine culture was sterile. The chest X-ray did not show anything significant. Importantly, the ANA and RA factor were negative. Even anti-CCP antibodies were negative, and the ultrasound of bilateral knee showed non-tappable effusion. In infective markers, like for malaria, PSMP, for dengue, NS1, and Montauk's test for TB were negative. Because we had an ESR of 141, we went on to perform further inflammatory markers and found the CRP to be raised, 521, IL-6 and procal, all three were raised, suggesting an inflammatory process. We carried out the serum protein electrophoresis, and the findings were suggestive of an acute inflammatory response and a chronic inflammatory state. So the initial impression of the patient was a 39-year-old female with prolonged febrile illness, polyarthritis, severe anemia, with neutrophilic leukocytosis, raised inflammatory markers with hepatomegaly. So my first differential was sepsis, and we wanted to find the source of sepsis. Secondly, an autoimmune disease. And thirdly, still we could not have ruled out malignancy yet, though unlikely. So in view of the persistent fever spikes and elevated counts, we started the antibiotics, and then we later upgraded them to piperacillin, tazobactam, and clindamycin. But the fever did not respond to such broad-spectrum antibiotics, neither to the antimalarials or the anti-tubercular drugs, which was started empirically. The atypical infections like leishmania, chikungunya, brucella were negative. Fundoscopy, cryoglobulinemia, the FDG PET, transthoracic echo, CT neck abdothorax, all were within the normal limits, and we could not find a clue to the diagnosis yet. While investigating the severe anemia, we found that it was a microcytic hypochromic type of anemia, suggestive of an inflammatory anemia, but surprisingly, the ferritin levels were much more markedly elevated than expected. It was about more than 2,000, which was surprising for us. And incidentally, while carrying out the other tests, we saw that the triglycerides were elevated, the fibrinogen was reduced, and in view of the persistent fever spikes and the sepsis-like picture, we thought of going for a bone marrow aspirated biopsy to find out the source of inflammation in the body. Our findings were that there were increased histiocytes, and evidence of hemophagocytosis. So this led us to figuring out that it could be a case of lymphohistiocytic syndrome, HLH, and we wanted to fulfill the 2004 criteria for HLH. So we carried out the flow cytometry, where we saw that there was decreased NK cell activity that was present, and hence our diagnosis was made for HLH. Now, primary HLH is rare in such a scenario at such an age group, so we wanted to find out the secondary causes of HLH, and we had ruled out most of the infections and malignancy too after going for a bone marrow biopsy. So we went on to search for a rheumatological cause. And we saw that the Yamaguchi criteria for adult onset Still's disease was getting fulfilled. And the criteria is as follows. So 3 in the major and 2 in the minor criteria were fulfilled. So the final diagnosis was adult onset Still's disease with macrophage activation syndrome, which is basically a subtype of secondary HLH. The treatment, patient was started on steroids and improved dramatically, and fever episodes and her joint pain settled after that. So why this case? Why adult onset Still's disease? It's a multisystemic inflammatory disorder, rare disorder, but certainly an important differential to be considered in patients of pyrexia of unknown origin. Macrophage activation syndrome, which is a subset of secondary HLH, is considered as the most life-threatening complication in such patients, and about 15% patients develop such complication, that too around the onset of the disease. Hence, it is very important to recognize this disease, especially in our case, where it was a previously undiagnosed case of adult onset Still's disease. Hence, firstly, recognizing a complication and finding a cause for it so that we can save the life of the patient and improve patient survival and prognosis. And in our case, serum ferritin levels proved to be a great marker, as increased levels than expected showed a hyperinflammatory state like MAS, which was confirmed by bone marrow biopsy.
Doctor, you have 1 minute.
Thank you.
Thank you, Dr. Choudhary, for your presentation. I want to tell our audience, please vote using the code you can see on the screen. Yes, here it is. Can you see it in the screen? Please just scan it and vote. And now let's go to our judges. Do we have questions?
I have one question. What was the biggest challenge in the workup and management of this patient, and what do you think we can learn from this case to guide further clinical practice or even policies in hospitals?
Thank you for the question, sir. So in a developing country like India, mainly we have infective causes putting at the topmost for the pyrexia of unknown origin. But here we had ruled out the infections because mostly we are not starting steroids in a patient with pyrexia of unknown origin in my area. threatening the life of the patient because infections could flare up. But if infections are ruled out, we should always look at rheumatological causes, which form the second most common cause, especially if there's a hint, especially in the clinical presentation like polyarthritis. So an extensive workup should be done. And in such scenarios, if the cause is found out, we can easily start steroids and hence save the life of the patient.
Okay, I have a question.
Go ahead.
So how much time did it pass from the initial presentation to the final diagnosis? And if you can tell me the importance of time management in such cases.
So this was an extremely challenging case for us because it was not a very common diagnosis, and it took about a week to carry out all the investigation and get the reports. And that is why I thought to present this case, as this should be a learning, as if the investigations are speeded up, steroids maybe could have been started earlier, hence the morbidity of the patient could have been reduced. And hence this is a learning I wanted to put forth, that starting early steroids in such cases would be helpful. We were thankfully able to save the life of this patient, but had the inflammatory response been even more severe, we could have lost the patient. Hence it should be a learning for future clinicians.
Is there any other questions? Dr. Adrian, Dr. Vlad? Okay. Thank you so much. Thank you so much, Dr. Choudhary, for your presentation. Thank you, Dr. Adrian. Thank you, Dr. Vlad, for being with us here today. And now let's move to our next presenter, Radu Marian Marinescu, who is a fifth-year medical student at University of Medicine and Pharmacy, Carol Davila, Bucharest, Romania. And his presentation is titled PMA-treatment of human monocytes induces M1 phenotype in adherent macrophages. You can start.
Okay, hello. I think that the presentation can be seen. Today I will present to you my last work on the inflammatory models, which includes treatments of human normal circulating monocytes with different types of molecules and dosages of pro- and anti-inflammatory cytokines secreted by them. First of all, I would like to discuss some general information about the monocytes and their role in research. Nowadays, there are a lot of studies which use monocytes and macrophages to notice the effects of different compounds or particles on their behavior and how different conditions. We know that monocytes are leukocytes and they have an important role in the immune system because they have the capacity to phagocytose antigens or other particles. They have an important role in these processes, and they are also very used as inflammatory models in vitro. Generally, there are two cell lines used, THP1 and U937, but they have a malignant background. Unfortunately, there is not very much information about the normal cell line, and this is why I chose to study them. A very important property of monocytic cell lines is their ability to transform into macrophages. The most common protocols involve 4-bol, 12-mystrate-13 acetate, or PMA. But there is no consensus on the protocol for PMA regarding the concentrations which should be used or the periods of incubation. Most of the authors use PMA, but there are also other molecules which can be used, such as vitamin D. The main aim of the study was to test a lower concentration of PMA, a concentration which is lower than those reported in literature. Also, we wanted to determine the phenotype of adherent macrophages obtained from the normal human line of monocytes. We made decreasing dilutions of the PMA solution with which the cells were incubated, 200 nanograms per milliliter, which is the most widely reported concentration in literature, 100 nanograms per milliliter, an intermediate concentration, and the lowest one, 25 nanograms per milliliter. In order to follow the effects induced by PMA, we used a video microscopy technique. After the treatment with PMA, we treated the cells with lipopolysaccharide using two concentrations, 50 nanograms per milliliter for mimicking chronic inflammation and 1 microgram per milliliter for mimicking acute inflammation. The supernatant was collected twice, after 4, respectively after 18 hours of treatment with LPS. To quantify the molecules secreted by the cells after the stimulation with PMA and LPS, we performed the screening of pro- and anti-inflammatory cytokines using the multiplexing platform. To validate these results obtained by using this platform, some ELISA tests were performed to check the cytokines secretion for the interleukins 6, 8, 10, 23, and tumor necrosis factor. Real-time impedance readings were performed to demonstrate of 25 nanograms per milliliter PMA is the optimum concentration. This graph shows us that the cells treated with 200 nanograms per milliliter entered the plateau around 24 hours, which lasted for at least another 24 hours, then resumed proliferation at slow rate. The appearance of this proliferation plateau decreased with decreased concentration. The lowest concentration allowed proliferation of other cells up to 90 hours. As expected, untreated cells recorded a very low index. So 25 nanograms per milliliter is the optimum concentration which can be used to adhere these cells. About multiplex screening, it should be noted that an entire Luminex kit was worked and it included several molecules such these interleukins, 1 beta 6, 8, 10, 12, 13, 17, tumor necrosis factor, and vascular endothelial growth factor. It was observed in the collected supernatant that only 4 cytokines were significantly secreted. So, interleukin 6, 4, 10, and tumor necrosis factor. This graph represents an overview of the secretory profile of adherent monocytes and macrophages under various conditions. From this graph, we observed the time dependence of the molecules secreted by the cells. The best response for each cytokine is obtained with 100 nanograms per milliliter PMA treatment. This thing is common for the 3 pro-inflammatory cytokines compared on this slide. We can also notice that a concentration of 25 nanograms per milliliter PMA induces the higher secretion of interleukin 6, but it does not have the same effect on the last 2 molecules, where it was not obtained a statistical significance. Also, we can notice the time-dependent effect on each type of cytokine, an effect also seen on the slide above. Regarding the anti-inflammatory molecule interleukin 10, a higher concentration can be noticed in the collected supernatant after 18 hours of treatment compared with the one collected after 4 hours of treatment. ELISA tests were performed to validate the results obtained from the Luminex platform. As we expected, the values from ELISA are superimposed on the values from Luminex. In the future, a next step can be to test the phagocytic abilities of the cell adhered by using a 25 nanograms per milliliter concentration of PMA to compare that with the currently tested models in literature. After this study, we conclude that a PMA concentration of 25 nanograms per milliliter is optimum to treat macrophages while preserving cell viability and proliferation. And also, the macrophages obtained after the treatment with PMA are M1 phenotype. Thank you for listening.
Thank you so much, Rado, for your presentation. And now I would invite our judges. And before we hear the judges' questions, I would ask our audience again to scan the code and to vote and to be engaged with us on the presentations that we have today. Your voting is really important. It's important for our presenters because, as you know, at the ending of this event, we will have a winner. So yes, please scan and vote for our presenters. And now let's move to our judges. Maybe we start with you, Dr. Adrian.
I have one question. Why do you think there was no anti-inflammatory response in the circulating cells compared to the in vitro results that show an expression of interleukin-10?
I didn't hear very well, but you asked me something about the anti-inflammatory response on
What do you think were the factors that influence that you only observe pro-inflammatory response in the circulating cells compared to the in vitro that show an expression of interleukin-10?
I think that we had a higher response, but a pro-inflammatory response because of the stimulation with the lipopolysaccharide and also with this molecule PMA. Firstly, when the cells are stimulated, such as monocytes, they start to secrete mostly pro-inflammatory cytokines. And maybe this is why a lot or a higher concentration of these type of cytokines. The anti-inflammatory cytokines start to secrete after a longer period of time. And maybe this is an explication why we had this response.
Okay. Thank you.
Dr. Vlad, do you have any questions? No. I would ask our audience if they have any questions. Please don't hesitate to ask questions to our presenter today. Team, do we have any questions? So, okay, as long as we don't have any questions, I would love to thank you all. Rado, Dr. Vlad, Dr. Adrian, thank you so much. Best of luck, Rado. And now let's move to our next presenter, Mr. Hydra Bohsas, Faculty of Medicine, Aleppo University, Aleppo, Syria. And in their presentation would be assessment awareness of breast cancer signs, risk factors, and barriers, an online cross-sectional study in Syria. Dr. Hydra, welcome. Please start. Maybe we have some technical issues, but in less than a moment, we will starting the presentation. Mr. Hydra, can you hear us? So it looks like we are having a technical problem here. We will be waiting till it will be figured out. Welcome back. And let's continue with Mr. Haidara Bohsas from Aleppo University, Syria. Are you able to hear us? Can you speak, Cesar? Are you able to hear us? No. Okay, so we still have and facing this technical issue with Dr. Hydra. Let's move to our next presenter, Fayo Hnin Htet, who's a fifth-year medical student from University of Medicine, Yangon from Myanmar. And her presentation will be unilateral lower limb amputations from traumatic events, a systematic review and meta-analysis. Welcome, Dr. Fayo. You can start.
Hello, everyone. My name is Hnin Htet, and I'm presenting the title Unilateral Traumatic Events, a Systematic Review and Meta-Analysis. My co-authors are Dr. Labna Mohammed and Dr. Khushbu Patel. And let's move on to the next slide. So, next slide, please. Traumatic amputation is defined as an injury to an extremity and that result in loss of the limb and due to accident or injury. Lower limb amputations are caused by motor vehicle accidents and farming injuries and landmine injuries. The injuries are contaminated and they are prone to infection. Next slide, please. According to the characteristics of the people who suffer traumatic leg amputations, these kind of people depend on physical ability, so that the limb loss often cause a traumatic and large damage to their occupation and social distributions. Next slide, please. So this is the process of rehabilitation of post-amputation and prosthetic training. And the reintegration phase is where we can amputation patients train their prosthesis. Next slide, please. So we did this meta-analysis to determine the outcomes of people who had unilateral transtibial and transfemoral amputations in terms of mobility of physical activity and prosthesis usage, any kind of pain and associated factors that influence them. Next slide, please. So the eligibility criteria is we choose adults above age 18 and the exclusion criteria are systematic review, meta-analysis, case report series, letter editorials, and the inclusion criteria are observational studies, randomized control trials, and comparative studies. The keywords are lower limb amputation and prosthetic leg, and the database are PubMed and Science Direct. So we screen the studies according to Newcastle, Ottawa scale. Next slide, please. This is the chart of Prisma flow diagram. And the final studies included 4 observational studies. And next slide, please. So the number of patients are 563 patients who had transtibial and transfemoral amputations, and the risk ratio was calculated by review manager. Next slide, please. So these are the table of study characteristics and the number of transtibial and transfemoral amputations. Next slide, please. So the meta-analysis showed that there were no statistical difference between mobility between the two groups. It showed mobility in terms of favoring transtibial patients. And next slide, please. In terms of prosthesis usage, there's a significant, statistically significant difference favoring transtibial patients. As for pain, there were no difference. The pain was similar between the both groups. Next slide, please. So this is the discussion session. As for mobility, community ambulation is an important factor, and community often play a great role so that people who had less negative experience had more outdoor activities. As for prosthesis usage, transfemoral patients often have more discomfort using prosthesis, and this might contribute to the lesser usage of prosthesis. And as for pain, we can see that stump pain and residual pain are prevalent in both groups. Next slide, please. So the long-term complications are stump pain, pattern limb pain, and back pain. These are often due to gait abnormalities and asymmetrical muscle usage. Next slide, please. Yeah, this is the pictures I chose from Physiopedia. So we can see the how the prosthesis vanish. Next slide, please. So this is the limitations of the study because of the small number of included patients, and the mobility and community ambulation are varying between the groups, so that it is hard to compare the rehabilitation programs. And as for suggestions, long-term studies will be more insightful to
Dr. Fayro, do we have you? Can you hear us? Okay, so it looks like we have an internet connection problem. Doctor, can you hear us now?
Yeah, sorry for the connection.
You have less than 50 seconds to finish your presentation.
Okay. Yeah. So conclusion, next slide, please. As for conclusion, pain is a prevalent and persistent health problem, and the communities have a heavy influence on rehabilitation. And the transfemoral amputation would have more discomfort, so that if we can improve it, these patients will also have a higher quality of life. So next slide, please. Yeah, this is the reference list. And yeah, thank you for listening. Yeah, can I complete my presentation? Yeah, there were a few difficulties.
Dr. Fayro. Before we move to our judges again, I would ask our audience to vote. All you have to do is to scan the code and to vote, because it's matters for our presenters today to have you voting for their presentations. So let's move to our judges now. Do we have questions? Yes, please, Dr. Vlad.
I have a question. You mentioned in the introduction of your study psychosocial complications or psychosocial problems that can be involved in
physical activity.
Sorry?
You mean the psychosocial complications that might affect the physical activity?
So I am asking you a question. If from your systematic review, if you have identified long-term psychological long-term complications, either psychological disorders or complications regarding quality of life.
Or during this meta-analysis, we try to find the common factors that are mostly used, and they often record the mobility and pain and prosthesis usage. The psychological complications they are often mentioned in discussion session. They don't have proper measurements, but they are often discussed a lot. So it is hard to extract data about psychological complications and the effect of community. I mean, they are just discussed a lot. The data are not easily available to extract.
Oh, okay, thank you.
Thank you, Dr. Vlad. Dr. Adrian?
I have some questions. You talk about traumatic amputations during your introduction. Did you include patients with other causes for amputations, for example, vascular pathologies or infections, diseases that led to the amputation, or it was only a trauma patient?
The patients, the population is traumatic cause. I mean, I've already excluded stroke patients, diabetes mellitus, or non-trauma causes.
Okay, and the other question is, how was mobility defined and how did you evaluate it?
Mobility was measured in vital exercise scale that are self-reported in one study, and then 6-minute walking test in one study, and the other study described measuring like accelerometer in prosthesis. So they have different scales, but when they try to group it, they differentiate it into two categories. So we use that terms to differentiate it into the one having more physical activity and the one having less activity.
Thank you.
Thank you so much. Do you have any other questions, our judges? All good? Okay, and I think we don't... Do we have questions from our audience team? So I would say no, there's no other questions. Thank you, Fayo. Thank you, Dr. Adrian. Thank you, Dr. Vlad, for this amazing questions and absolutely amazing presentation from you, Dr. Fayo. And now let's move again to Dr. Hadra Bohsas from Syria. I hope that the internet connection is better now. Yes, we can see the screen. Doctor, can you hear us? Doctor, can you please turn off your camera? Maybe we would be able to hear you better.
Yes, can you hear me now?
Yes, I can hear you. Yes, please. You can start.
Hello?
Yes, I can hear you.
Yes.
But before, maybe you turn off your camera before starting.
Okay.
So things would be better,
Can we
unfortunately.
start now?
Yes,
Thanks,
please.
everybody.
Start.
Hopefully you are doing well. Okay. Yeah.
Go ahead.
Let's start with the first abstract, assessment awareness of breast cancer, signs and risk factors and barriers, an online cross-sectional study in Syria. The background of this research, according to the WHO or the World Health Organization, breast cancer is the most common type of cancer. But in low and middle income countries, breast cancer incidence is low, but there is a high rates of mortality. That would be explained by the cause of there's a lack of adequate screening programs in these countries and lack of information about breast cancer symptoms. So this lack of information can potentially result in the disease progression.
Another issue with internet. maybe we wait some time till Dr. Hydra is with us again, as he is today presenting 2 papers. And for sure, our team in the background are working on that. As you can see, only me on the screen, but absolutely, there's a lot of people working. Can you hear us, Hydra? Yes?
Yes, can we continue now?
Yes. Please, Risu. Yes, please.
Yes. Okay. As the methods of this research from 3rd to 27th of September 2022, Syrian females participated in an online cross-sectional survey to measure their knowledge about breast cancer risk factors and symptoms. This survey was derived from previous research that included a comprehensive and validated scale. The inclusion criteria was all Syrian females aged 18 years or older, but Syrian females having breast cancer or their relatives or working in healthcare sectors were excluded from the study because they already have knowledge about the breast cancer. The questionnaire was divided into 2 sections. First one included socio-demographic characteristic questions such as age, occupation level, economic level. And the second section assesses the participants' knowledge of breast cancer symptoms, risk factors, and PARIS, which is based on the BCAM scale, Breast Cancer Awareness Measure Scale. Now, the data was analyzed using the IBM SPSS version 28 software, and a descriptive and multivariate logistic regression analysis was performed. Now, for the results of our study, 1,305 females were participated in the study, and the average age for participants were 30.7 with a standard deviation of 11.2. Now, university students have constituted almost 3/4 of the study respondents. Now, participants with chronic disease have shown a higher knowledge score than participants with no chronic disease, and that could be explained by when females have chronic disease, they start seeking their health more, and they start pay attention for their health more than people who don't have chronic disease. As we can see, unemployed participants have higher average level of awareness regarding breast cancer barriers than other subgroups. In addition to single women have scored higher on the status. As we can see, the mean is 3.3 and standard deviation of 2.3. Only 2 variables were including age and education level were statistically significant in predicting an acceptable degree of knowledge of the risk factor of breast cancer, as participants with the PhD education level have higher probability of breast cancer awareness of risk factor than participants having a primary education level. Odds ratio was 6.1, and females having chronic disease were projected to have higher level of breast cancer awareness, barriers of breast cancer awareness, 1.8 times more than participants without chronic disease, as we explained it before, because when they have chronic disease, they start seeking their health more than others. Can you hear me well, or there's any problem for? Okay.
Now we can hear you.
In the conclusion, we can say our findings indicate that Syrian females have a poor to moderate knowledge of breast cancer symptoms, risk factors, and barriers. It's proposed that more breast cancer awareness campaigns to be conducted and the yearly screening programs to be improved to combat this, the late detection of this disease. Social media, specifically authorized social media platforms and television might be effective means of raising awareness of breast cancer early detection and as well as breast self examination. That's the first one.
Okay, thank you so much, Dr. Hydra. We will take the questions of the judges and from the
Is there
public,
any
and then, yes,
Sure.
now we will hear the questions from the judges. But before we hear the questions, I
Yes.
want to remind our audience to vote for Hydra as well by using the code you can see on the screen right now. Just scan the code and you can do the vote. And now let's have the questions from our judges. Dr. Vlad.
Yes, I have two questions. First of one, the first one is if you could tell us more about the second part of the questionnaire. I saw that it was based on a previous scale, but if you could give us more information about what kind of questions did it contain and what specific knowledge it assesses. And also, my second question is, how do you explain that married women or women have more knowledge about cancer, breast cancer, than single women? Because I saw that this is one of your results.
Hydra.
I can't hear you.
Now I can hear you now.
Yes.
Did you hear the questions?
Hydra, did you hear my questions, or should I repeat them?
Hydra, are you able to hear us? Yeah. Are you able to hear us, Hydra? I think, again, it's the internet connection. Maybe we can send Hydra by text.
I didn't hear the first question. Can you please
Perfect.
repeat the question?
So, should I repeat only the first or also the second?
He said the first one.
First? Okay. So it was actually a request to present us more information about the second part of the questionnaire, which is from what I saw on your poster, derived from a previous scale, if that's correct. So if you can tell us more about what kind of questions did it contain, and what does the what kind of knowledge does it assess? So have you heard me?
Hydra, are you with us?
I can't hear you very well.
Let's see. Maybe we tried to send them by text to Hydra to be able to answer the questions. Team, can we do this? Okay, I don't know if you can hear us now, Hydra.
Yes.
Yes. Can you hear me?
The questionnaire was derived from.
Yeah.
The questionnaire was derived from developed by the Cancer Research in United Kingdom, King's College.
Hydra, we lost you, I think. Okay, we have you again. So, due to the internet connection, I don't know if Hydra can hear us now or no. We need to move to the next speaker. Okay, so I would say now, as Hydra is not able to hear us now, and he will have another presentation, we will see what we will do about it. Thank you, Dr. Vlad, and thank you, Dr. Adrian, for this. And now we are moving to our next presenter, Ahmed Soliman, Dr. Ahmed Soliman, Faculty of Medicine, Mansoura University, Mansoura, Egypt, and his presentation, Efficacy of rectal misoprostol versus oxytocin on reducing blood loss during cesarean section, a meta-analysis of randomized clinical trials. Dr. Ahmed, welcome. And you can start now.
Welcome, Dawn, and thank you. First of all, I'd like to thank the editorial and executive board and the organization conference team for their exceptional efforts for the Ijms first conference. I am Ahmed Soliman, a final year medical student at Mansoura University at Mansoura, Egypt. And my presentation today about the efficacy of rectal misoprostol versus oxytocin on reducing blood loss during cesarean deliveries. I will start by an introduction about postpartum hemorrhage. I see if there is a technical problem in my slides, or you can clearly see my slides. Can you see my slide clear?
Yes, we can see it. We can see it. Continue.
Okay. I'd like to start with an introduction about postpartum hemorrhage and postpartum hemorrhage and cesarean deliveries. Postpartum hemorrhage is, according to the recent WHO statistics, is the first leading cause of maternal mortality worldwide. And this accounts for about 60% of maternal death in developing countries. And this is the double incidence in vaginal deliveries, and this accounts for about guess the number 100,000 of maternal deaths per year, according to the WHO recent statistics about the maternal mortality and postpartum hemorrhage. Misoprostol is a prostaglandin E1 analog, which requires no specific storage or transportation requirements. It's a low-cost uterotonic agent with multiple routes for administration: rectal, sublingual, oral, even intrauterine. and there is no reported severe adverse effect regarding its administration. Our aim and objective was to detect a potential preference regarding the efficacy and safety of rectal misoprostol over oxytocin as a diuretonic agent. IT. The result was sorry for this miscoordination, but I think it's now good. There's some miscoordination in the slide ordinary, but I think this due to I share my slides via the platform, not via the PowerPoint software. So sorry for this coordinations. We started according to the Cochrane and the Prisma guidelines. We registered a protocol in Prespero, and then we searched the most relevant databases, PubMed, Scopus, Web of Science, and other clinical registries in order to see if there is any coming clinical trial that registered on clinicaltrials.gov or other registries. Using the present keywords, then the article selection process and eligibility criteria were done according to steps: title and abstract, then full text screening. Regarding the eligibility criteria, we included the trials that enrolled women undergoing cesarean section, rectal misoprostol was an intervention, and parenteral oxytocin, either IV or IM oxytocin. All efficacy and safety outcomes were included, and we limited our search for randomized controlled trials. Our result was we have divided the result in 4 sections: search results and study characteristics, efficacy, outcome, safety, and clinical practice impact. You can see here we have finally included the 9 RCTs, and you can see the study characteristics table. 2 of them have investigated the IM misoprostol, and the rest 7 used the IV oxytocin. The dosage of rectal misoprostol was varying from 400 microgram up to 800 microgram. Regarding the significant efficacy outcomes, out of the 7 efficacy outcomes we found that 2 of them, post-operative blood loss and hemoglobin drop, only were significant. Post-operative blood loss was significant by 27 milliliter. Have reduced the post-operative blood loss by 27 milliliters than oxytocin, and reduced the amount of hemoglobin drop by 0.11 milligram per deciliter. None of the rest of the outcomes, intraoperative blood loss, average operative time, the need for additional diuretonic agent, and the need for blood transfusions were significant for each of the groups. Regarding the significant reported complication, only the incidence for shivering was significant in the misoprostol group. You can note that misoprostol, the group of misoprostol was significant in having a post-operative shivering, which is reported in nearly all of the studies. But we have a comment in the clinical practice about that. You also see the finding summary. 2 efficacy outcomes were significant, and only shivering outcome were significant for misoprostol group, not for oxytocin. Regarding the clinical practice impact, you can see a comparison between oxytocin and rectal misoprostol. Regarding
Dr. Ahmed, time is over. Yeah,
Okay.
you finished your time. So sorry for that. But maybe we move to our judges.
Okay.
And before we listen to our judges, I want to remind our audience to vote for Ahmed just by scanning the code you can see on the screen. Let's go back to our judges. Any questions?
I have two questions. The first is, did you use any tools to evaluate the quality of the individual works included in your systematic review? And the other one is, what is meant by preference in the objective of your study?
Regarding the first question, yes, we have investigated the quality of each randomized clinical trial via Cochrane risk of bias assessment tool 2. But we didn't mention that in the abstract. We put it in the section in the methodology, and the result was there is no high risk of bias in any of the studies. But I couldn't hear the second question. The second question. Can you repeat the second question?
What was meant by preference in the objective of your article or your study?
The preference. You know, oxytocin is a very costly substance and required a cold chain and specific requirements for transport and storage. It's also expensive, and it's not always available in healthcare facilities with limited resources. And this make oxytocin, rectal misoprostol, even with little efficacy or non-inferiority efficacy, could be a comparative or comparable to oxytocin, which is standard in the WHO guidelines and FEGO guidelines also.
Thank you.
Dr. Vlad, do you have any questions?
No, I have. My questions were responded already, so received the response. So thank you.
Thank you. And I would thank you, all of you. Thank you, Dr. Ahmed, for being here with us today. Thank you, Dr. Adrian. Thank you, Dr. Valid. And now let's move to our next presenter, Jihad Samhouri, who is a fifth-year medical student, Faculty of Medicine, University of Jordan, Amman, Jordan. And his presentation will be Prepectoral versus Subpectoral direct-to-implant-based breast reconstruction, a meta-analysis of 3,851 patients. And you can start, Dr. Jihad, now.
Hello, everyone. Is my slide shown?
Yes, we can see it.
Great. So good evening, everyone. I'm Jihad Samhouri, fifth-year medical student from University of Jordan. So today I'm going to present our teamwork about the prepectoral versus subpectoral direct implant-based breast reconstruction, a meta-analysis of 3,851 patients. So our team members is our leader Ahmed Jabali, Muhammad Attal, Yasmin Abdullah, Abdurrahman Al-Khayyati, and Khalid Al-Bakri, and finally Jihad Samhouri, the presenter. So through this presentation, we can move through subtitles. First, the introduction, method, results, and finally with the conclusion. First of all, with the introduction. The subpectoral direct-to-implant CBDTI surgical technique is the standard and the most common for breast reconstruction, which could reduce the implant visibility and palpability. It manipulates the pectoral's major muscle with some post-operative complications such as muscle spasm, animation, deformities, pain. While the prepectoral direct-to-implant PBDTI approach leaves the muscle intact. Therefore, we conducted this meta-analysis to assess the efficacy and safety of the PBDTI procedure after mastectomies compared to the standard breast reconstruction. Second, with the methods. We performed a comprehensive search for the following database: PubMed, Cochrane, Web of Science, Scopus. All studies published in English till Feb 2022 were included. These included randomized and non-randomized clinical trial comparing operation time, duration of hospitalization, breast animation deformity, implant loss, wound infection and dyshyance, seroma, and postoperative pain. The study quality will be acid according to the Cochrane risk of bias tool for randomized trial, and risk of bias INS1 risk for bias tool to assess non-randomized studies of interventions. Third, results. There were 28 comparative studies, including 3,851 patients carried out breast reconstructive surgeries. Postoperative complications were comparable between the two groups as follow: implant loss with odds ratio of 1.17, wound adherence with odds ratio 0.76, wound infection with odds ratio 1.09, seroma with odds ratio 0.78. Yes. The PBDTI group was significantly less likely to develop bad compared to subpectoral DTI group with the odds ratio of 0.002 and confidence interval from 0.00 till 0.12. Patients undergoing PBTDI reconstruction had a significantly reduced postoperative pain with SMD 0.55 and confidence interval between negative 0.78 till negative 0.732. Operation time and DOH were significantly lower among PBDTI group with SMD negative 0.35 with a confidence interval from negative 0.61 till negative 0.08. And SMD with a negative 0.89 and confidence interval negative 1.48 till negative 0.30, respectively. So through this graph, we can see the first plot, as we said previously in the results part, regarding the significant and non-significant things. And finally, with the conclusion, following mastectomy, BBDTI breast reconstruction significantly reduced postoperative pain, PAD, DOH, intraoperative time compared with subpectoral DTI reconstruction, although there was no significant difference in complication rate. A BBDTI is a simple and safe alternative to subpectoral technique, allowing early discharge and improving patients' quality of life. Future will design multi-center randomized control trial that compare two approaches and discuss the cost effectiveness are needed. Thank you.
Thank you so much, Dr. Jihad, for your presentation and your hard work with your team. And before we move to our judges, I want to remind our audience to vote for Jihad just using the code you can see on the screen. Just scan it and vote. And let's hear the questions from our judges. Dr. Vlad.
I have two questions.
Yes.
First, it's just something I'm not very clear with. What type of studies did you include in the analysis?
Yes.
Okay. I saw that RCTs, but it wasn't very clear. So if you could shed some light on this, and also my second question is how was breast animation deformity assessed in the studies that you included in the analysis?
Yes. Regarding the first question, first of all, thank you for your effort, Doctor. Regarding the first question, we used all the comparative studies, either in randomized and non-randomized studies, that focus in the comparison between the two methods for the first question. Regarding the second question, it used a scale that was used in the studies that studied the deformity. I can't remember its name for this time, but yes, it was mentioned in the methodology of that study that they used a certain scale to evaluate the animation deformity.
Thank you.
You're welcome.
I have one question. On the individual level of these studies, there was a difference in results with the randomized control trial versus the non-randomized one?
Sorry, Doctor, I didn't hear your question clearly.
If there was a trend of results with the randomized control trial versus the non-randomized trial?
Yes, I think.
Okay, thank you.
Welcome.
Okay, thank you, judges. I don't know if we have any questions from the audience. Don't hesitate to ask any questions. Team, do we have any questions? Okay, as long as we don't have any questions, I would like to thank you, Dr. Jihad, Dr. Vlad, and Dr. Adrian for being with us in this session. And now we will take a break. Thank you so much for being with us for this session. See you all after the break. Don't go away. Welcome back, everyone. And now let's move to our next presenter, Kimanthi, who is a fourth-year medical student
Department of Human Anatomy, University of Nairobi, Kenya, and his presentation will be correlation between placental histomorphology and umbilical cord coiling index in pre-eclampsia. Sirs, welcome.
Thank
Can you
you.
hear us?
Yeah, I can hear you. Can you hear me? Can you hear me?
Can you hear us?
Yes, I can.
Okay, great. You can start now.
Okay, my name is Cyrus Kimanthi, and I'll be presenting on the correlation between placental histomorphology and umbilical cord coiling index in preeclampsia. My supervisors for the study were Professor Moses Obimbo and Dr. Christine Awori. So, let me just move. I'm not sure if my slides are moving.
They are moving. They are moving. Maybe you can make it full screen so we can see it better. Can you press the icon below?
I've pressed the icon. I don't know. Okay, let me just put it on full screen like that.
Yeah. Good. And try to make it a full screen, please, if it's possible.
Is that better?
It's better.
Okay, so
Just resume.
okay, so can I start?
Yes.
Okay, thank you. So once again, my name is Cyrus Kimanthi, and I'll be presenting on the correlation between placental histomorphology and umbilical cord coiling index in preeclampsia. My supervisors for the study were Professor Moses Obimbo and Dr. Christine Awori. As a background, umbilical cord coiling index is calculated as the number of vascular coils divided by the length of the cord. In preeclampsia, this cord coiling has been correlated to it in other studies. So preeclampsia is a common hypertensive disorder of pregnancy, and both preeclampsia and abnormal umbilical coiling index can alter the placental structure on their own. Then studies have noted that there are variations in the type of abnormal coiling index that is associated with preeclampsia, but no study has been able to identify whether it's hypercoiling or hypocoiling which is associated with preeclampsia, which of them alters the placenta more. So a study justification is that we carry this study out because preeclampsia is a common disorder that affects a lot of mothers. It's been rated to cause about 500,000 deaths per year since 2009, with 99% of these deaths occurring in developing countries. Our country, Kenya, in our country itself, preeclampsia is the third leading cause of maternal mortality, accounting for 20% of maternal deaths. And premature delivery in preeclampsia further complicates these pregnancies, yet it's the most advocated management plan. Then the antenatal and postnatal umbilical coiling index have been correlated by ultrasonography. So nowadays you can tell whether the cord is coiled or how much is it coiled, like is it hypocoiled or is it hypercoiled using ultrasound way before the around 24 weeks. So this study hopes to shed light on the severity of preeclampsia when it's coupled with abnormal umbilical coiling. Our objectives were broadly to determine the correlation between the postnatal umbilical coiling index and the histomorphological changes of the placenta in preeclampsia, specifically to determine and compare the following in mothers diagnosed with preeclampsia who are in this study the cases, and mothers without complicated pregnancy who are the controls. We were to compare the postnatal umbilical coiling index, the gross placental features, and light microscopic features amongst the cases and the controls. We carried out an unmatched case control study at the Kenyatta National Hospital in Nairobi, Kenya. We sought ethical approval, and our reference number is shown. The sample size was calculated, and we got 70 participants, 35 cases, and 35 controls. The selection criteria involved, we selected mothers, included mothers who are aged between 20 to 35 years, because placenta that are from mothers who are aged below 20 years are different, are usually underdeveloped, yet those with above 35 years are likely to have other comorbidities such as diabetes and hypertension that can alter the placenta itself. Then we excluded multiple pregnancies and established conditions because these ones can also alter the placenta. So we picked mothers aged between 20 to 35 years who had no multiple pregnancies and who were not with any established conditions. The gross data collection was collected as follows. We picked the postnatal umbilical coiling index as the number of coils divided by the length. We also measured the placenta diameter along the longest axis. We also described whether the umbilical cord was inserted on the central aspect or the peripheral aspect of the placenta. We also described the shape of the placenta as to discoid, diffusal, cotyledonary. We also described whether there was presence or absence of gross infarction, which are white patches on the fetal surface of the placenta. We also did a volume displacement method so that we could use serology as part of this study. We carried out histology and serology, and hematoxylin and digoxin were used to stain for general histoarchitecture. Mason strichrome was used to stain for connective
Dr.
tissue.
Cyrus, 1 minute left. 1 minute left. Please move to the conclusions.
Okay. So after conducting the study, we found out that hypocholine was associated with more alteration of the structure of the placenta in preeclampsia than hypercholine, and early detection of hypocholine using ultrasound could reduce adverse perinatal outcomes in pregnancies that are complicated with preeclampsia, and that further immunohistochemical and placental microbiome studies can be carried out to identify the factors that actually are involved in these preeclampsia and hypocholine. Then in our current setting, we are currently carrying out a larger cross-sectional study to determine which of the two choline indices, whether it's hypocholine or hypercholine, that is more common in our local setting. Thank you.
Thank you, Cyrus. And now let's move to our judges. And before we move to our judges, we ask our audience to vote for Cyrus for his presidency. All you have to do is to scan the code and to vote. So, Dr. Vlad, Dr. Adrian, who has a question?
I have one question. What were the characteristics of the placenta that correlated with preeclampsia, or what was matched with hypocholine in this case?
Okay, the placenta that were found to be hypocoiled and also preeclamptic, we found that they all had gross infarcts and they were also had meconium staining compared to the ones that were normocoiled and hypercoiled. Then under the histology, we found that they had a lot of fibrin deposition too when we carried out the Mason strichrome stain.
Okay. And did you have several pathologists to compare the same sample of placentas, or it was just one person doing all the analysis?
Oh yeah, we had two of my colleagues were helping me. So I had Mohammed, will be presenting next, and also Talha. So I had three people who were carrying out, who were like during the sectioning of the placental samples and also the taking of the photographs. So I didn't take the photographs and I didn't analyze because I was the one who was carrying out the study mainly. So they carried out, other researchers carried out that for me to blind the study. Thank you.
Thank you.
Okay.
Dr. Vlad, do you have any questions? No? So, okay, do we have questions from the audience? Let's remind our audience that you always allowed to ask questions. Just put them on the comments and we just will share them with the presenter. And as long as we don't have any questions, I would love to thank you, Dr. Cyrus, for your presentation. Thank you, Dr. Adrian. Thank you, Dr. Vlad, for your insightful questions. And now Let's move to our next speaker, Dr. Muhammad Onyango, Human Anatomy, PS from Kenya, and his presentation will be morphometry of a placenta of anemia and non-anemic pre-eclamptic patients. Dr.
Thank you very
Muhammad.
much for that. Please do confirm you can hear me, and I'd like to begin. So tell me when the time starts as well.
You can start.
All right. So the title of the study is Morphometry of Placenta of Anemic and Non-Anemic Preeclamptic Patients. My name is Mohammed Onyango. These are my co-authors, and this study was done in Nairobi, Kenya. As a background, preeclampsia is categorized into early and late onset based on the time of appearance of clinical manifestations. Now, early onset preeclampsia has been linked to defective implantation of the conceptus. Now, this then leads to defective spiral artery remodeling, and this causes hypoperfusion and an increase in anti-angiogenic factors. Now, anemia has been established to be a risk factor, and it also alters the morphometry of placenta, so a risk factor for preeclampsia. Now, patients with coexisting preeclampsia and anemia have been postulated to have uteroplacental insufficiency. However, few studies have described the placental morphometry when these two diseases coexist. So as a study justification, preeclampsia is one of the major causes of maternal and neonatal morbidity. The prevalence in Kenya for preeclampsia or for anemia is about 55.1%, which is quite high. And there's an increased maternal and neonatal morbidity when these two conditions coexist. As a study significance, we aim to elucidate the structural basis of the amplified uteroplacental insufficiency observed when preeclampsia and anemia coexist. Our broad objective was to determine the morphometric differences in the placenta of anemic and non-anemic preeclamptic patients, specifically to compare the gross morphologic, gross morphometric, and histomorphometric features. The study design was an unmatched case control study carried out at a level 5 facility, which is a national referral facility in University in Nairobi, Kenya. This was the ethical approval number, and we included 42 mothers. The controls were basically preeclamptic mothers who had normal hemoglobin levels throughout pregnancy, while the cases were preeclamptic women who had anemia throughout pregnancy. So one group had preeclampsia with normal HB, the other group had preeclampsia now with anemia. So included mothers between the ages of 20 to 35, a history of anemia during pregnancy, that's according to WHO, 11 grams per deciliter, equal or less to that. And this was confirmed in both the first and third trimesters of pregnancy. And we excluded eclamptic patients because the pathology is slightly altered in eclampsia, and those with concurrent established obstetric complications. So for gross methodology, we basically assess the fetal membranes based on meconium staining. So without meconium staining and with meconium staining. And we also assess gross infarction as being either present or absent. We also establish the volume of the density via volume displacement and the placental diameter as the longest axis. So for the cord insertion, it was classified as being central or peripheral as shown. We then did biopsies, 6 biopsies, which produced 5 tissue blocks and 10 sections, then 3 photographs. We stained this using hematoxylin and eosin for the general histoarchitecture and Mason trichrome for the connective tissue. We also did serologic analysis in terms of volumetric densities and surface area densities as shown. And we also did histomorphometric analysis to basically characterize how thick is this interhemal membrane, and it was measured at 4 different points to now estimate the morphometric diffusive capacity of the villus membrane in the two groups. This is how our data was managed using SPSS version 25. The data was non-parametric according to Shapiro-Wilk test, and a p-value of less than or equal to 0.05 was considered statistically significant. So when it comes to gross morphometry, the color of the fetal membranes and gross infarction was really not different across the two groups. So you can see this is an image of a normal placenta, and this is that is meconium staining. Gross infarction was noted in both groups because of preeclampsia, and the difference was noted in terms of peripheral insertion, where it was higher in the case group. We also noted under histology, there's massive intervillous fibrinoid deposition in the case group when compared to the control group. And the syncytial knotting, which is basically these clumps of cells, was high in the case group when compared to the control group. We also noted perivillous fibrin deposition around the villi, and this was slightly higher in the case group when compared to the control group. And this thickness of the membrane thus increases, so the morphometric diffusive capacity was higher in the cases when compared to the control group. So to discussion, the extensive central gross infarcts noted, probably due to strangulation due to the perivillous fibrin deposition that we've seen. And this causes hypoxia, as well as the anemia also contributes to this preplacental hypoxia. The peripheral umbilical cord insertion, which is slightly higher in the case group when compared to the control group, is in line with the decreased chorionic vessel branching theory, which states that if we have defective vasculogenesis in the first trimester, you expect to find an increase in peripheral umbilical cord insertion. And this is also compounded by the uteroplacental insufficiency in anemia. So the less weights and volumes are in conformity with previous studies of preeclampsia, and it's contrary to some reports where compensatory hypertrophy occurs in anemia, while other studies on anemia do hypertrophy due to malnutrition also occur, but this was not in line with that. Now, chronic hypoxia leads to placental growth restriction and a small hypotrophic placenta.
Then 1 minute, Muhammad.
Right.
Move to the
Okay, so the massive
conclusions.
intervillous fibrin noted was due in preeclampsia due to inflammation and reduced intervillous perfusion, and anemia also causes thrombosis in the intervillous spaces. The intervillous space then gets obliterated, and this leads to infarction, and the increased incisional knotting is due to placental insufficiency. The marked periverinous fibrin that we saw is due to the procoagulant and the antifibrinolytic capacity in preeclamptic patients, and venous stasis due to anemia, and the thicker interhumeral membrane in the cases is due to the marked periverinous fibrin and incisional knotting. So in conclusion, the coexisting preeclampsia and anemia increases the frequency of gross and histopathologic lesions, and anemia may exacerbate the pathology caused by preeclampsia, and this may be the basis for what we see as severe uteroplacental insufficiency. As a limitation, we expected tissue shrinkage to occur, but this was carried out through all measurements. We recommend the inclusion of severely anemic patients to illustrate the effect of severity, and also the application of immunohistochemical methods to identify the specific angiogenic factors involved. These are my key references. Thank you very much.
Thank you, Muhammad. And now I would invite our judges again. And before, just let's remind our audience to scan the code and vote for Muhammad. And let's take the questions.
I will have a question.
Yes, please.
What was the etiology of anemia in your group? Because you included patients with anemia, but in pregnancy, anemia can have a lot of etiologies, from dilutional to thalassemia. So, what were the etiologies of anemia in your group? And I didn't see the mean of the hemoglobin, or how was your group? You told us at the end that future studies, including severe anemia, are recommended. So I understand that in your study, moderate to mild to moderate patients with mild to moderate anemia were included. So, thank you.
Thank you very much for your questions. They're very essential questions, and they are in the main write-up. I forgot to mention, but the anemia in this particular case, especially in low and middle income countries, is due to iron deficiency anemia. So you confirm this using the blood work, the full hemogram, where the transferrin levels were low, where microcytic hypochromic anemia was also noted on the film. Now, the study was basically preeclampsia without anemia and preeclampsia with anemia. Now, what you're suggesting is to stratify based on the severity of the anemia. Now, what we did, we included this, especially where our pool was coming from, most of the patients were mild to moderate anemia. So the aim was to basically characterize the effect of anemia when it's mild to moderate. But I do agree we have studies underway to include those with severe anemia. Now, the problem with severely anemic patients also have underlying comorbidities, so those ones were slightly excluded. But in future studies, as we continue with this study, we'll stratify based on the severity of anemia, which is very important. Thank you.
Okay, thank you.
Dr. Adrian, do you have any questions?
I have no questions.
Do we have any questions from the audience? So as long as we don't have any questions, I would love to thank you, Dr. Muhammad. Thank you for your presentation. Thank you, Dr. Adrian. Thank you, Dr. Vlad. And now we can say this is the end of our first session for today conference. I would love to thank all the presenter in this session. I know we had dealt with some issues in the internet, and I'm so sorry that we couldn't have some of them. It looks like we have another presenter now, who's Manuel. Welcome, Manuel Leandro, who is a fourth-year medical student from Colombia, and his presentation will be prenatal diagnosis of a fetus with partial duplication and deletion of a chromosome 18 due to maternal precentric inversion 18. You're welcome.
Thank you. Greetings, everyone. So this is a short presentation about a case report titled Prenatal Diagnosis of a Fetus with Partial Duplication and Deletion of Chromosome 18 due to Maternal Pericentric Inversion 18. I'm Manuel Vasquez, a fourth-year medical student from the Universidad del Valle from Cali, Colombia. So as introduction and background, I'd like to give a quick recap about key concepts of genetics. We have here chromosomal variations that can be numerical or structural. In numerical, we have polyploidies that can be, for instance, Down syndrome, or aneuploidies that can be Klinefelter syndrome. And the other big group of chromosomal variations can be structural. These chromosomal variations do not affect the total number of chromosomes in one individual, but affect each chromosome. So, for instance, we have deletion in this deletion. The one that I'm showing here is Cri-du-Chat syndrome. Also, we have duplications and we have inversions. These inversions can be balanced or not if the genetic material is lost or maybe it's duplicated. These are the structural chromosomal variations are the one that we're gonna take into account for this case. So what's the pathophysiology or genetics of these variations? And for structural variations, we have this during the crossing over in anaphase of meiosis. Maybe we have some errors of the pairing between homologous chromosomes. Some genetic material can be lost or can be duplicated, or also can be translocated. And for numerical, this is a more familiar, I guess, physiology. We have non-disjunction in meiosis 1, or maybe non-disjunction in meiosis 2. And we end up in oogenesis or spermatogenesis with a number of chromosomes that is not 46 exact chromosomes, but we have more or even less chromosomes, and that is gonna when the fetus is forming, I guess it will have some alterations in the total number of chromosomes. So this is a timeline that is very important to take into account for this case presentation. 10 weeks and 6 days. The first day, it is first ultrasound evidence, nuchal translucency of greater than 95 percentile. Then there was a follow-up ultrasound at 12 weeks and 5 days. An amniocentesis was performed. Then a detailed anatomical ultrasound was performed also. And then at weeks 29 and 2 days of gestation, there was a voluntary interruption of pregnancy. So I like to take into account this specific timeline to carry throughout the presentation. So 10 weeks and 6 days, we got a nuchal translucency of 3.9 millimeters. I'm not gonna stop or I guess detail every ultrasound, but here we have it. Also have 12 weeks and 5 days, 6 millimeter nuchal translucency. And at 18 weeks of gestational age, there was a amniocentesis was performed, but the samples were not analyzed until week 24. We have a karyotype of 756 G banding that showed chromosomal structural aberration in the chromosome 18. This is the karyotype of the fetus. And also we have the karyotype of the parents. There seems that it's normal, but we have here in the maternal 18 chromosome, we also have an alteration that I'm gonna talk into it. So the first when the patient first was at our hospital was a 20 an otherwise healthy female from Cali, Colombia, gravida 2 para 2, 27 years old, gestational age of 24 weeks, and she had a chief complaint of there's something wrong with my baby. She was phenotypically normal, nor nothing remarkable on physical exam. And an ultrasound, anatomical detailed ultrasound was performed 24 weeks and 1 day, showing multiple congenital anomalies such as long bones growing in percentiles not according to the gestational age, the fibula and tibia here. Also, we have the humerus here, and we also have dextrocardia and diaphragmatic hernia, and also a multicystic dysplasia kidney. So let's go back. What happened here? As I was talking earlier.
Less than 1 minute, Dr.
Okay.
Manuel. Go
Okay.
to the conclusions, please.
Okay. Okay, so this is like a schematic representation of what happened here. There was a deletion of this part of the chromosome. Also, this was a duplication, partial duplication of this part of the chromosome, and also a deletion of this distal part of the short arm of the 18th chromosome. This is what's happening here is pathophysiology. And at 29 weeks and 2 days, there was a voluntary interruption of pregnancy discussed with OB/GYN, psychologists, and social workers. So it's impact on current literature and conclusions. This is the first case report of this affected lossy. There's not have been to date another case report with this affected lossy, and we got some overlapping features with Edwards syndrome. And for the conclusion, we got this is I was talking the first case with this specific affected lossy, highlighting the importance of prenatal diagnosis and also the genetic and reproductive counseling for this patient was very important in this case. So thank you.
Thank you so much, Manuel. And now let's move to the questions from the judges. Before that, we would love to remind our audience to vote for Manuel. All you have to do is to scan the code and to vote. So let's take the questions. Dr. Vlad?
I have no questions.
Okay, Dr. Adrian.
What caught your attention about this case?
I guess it was the ultrasound follow-up that the case had been having till date. I personally found ultrasound pretty interesting. So then there was the amniocentesis and the karyotype that was showing those alterations, and I thought with my professor that was an interesting case to publish on the literature.
Do you find like any correlation or any important relationship between the ethical considerations of the case and all the tools or the diagnostic tools that you use to work out the case? Or
well, yeah, there's obviously an ethical I guess background to every case report. That's why you need an informed consent for every case or anything, really anything you want to publish on. Obviously, we talked to the patient, was prenatal and reproductive counseling. The risk of a new pregnancy were discussed with the patient thoroughly, and yeah, I guess that's it.
Thank you.
And I think we have a question from the audience. Can we have the question? So the question is from Dr. Francisco. He's saying, great presentation. Can you go back to the pathophysiology of this disease? Was it a trisomy like Edwards syndrome?
It was not a whole trisomy. It was a partial trisomy, because if we got this diagram here, it shows that this distal part of the long arm of the chromosome is duplicated, so it causes a phenotype with overlapping features with Edwards syndrome. So it's a partial monosomy because there's a deletion here of this part of the short arm. There's also a partial trisomy, and there's as a result we got an isochromosome of 2 long arms.
Okay, thank you so much, Manuel. Thank you for this presentation, and so sorry for the interruption that happened earlier. I would love also to thank you, Dr. Adrian. Thank you, Dr. Vlad, for being with us the whole session and acting as our judges. Do you want to say anything?
I would like to congratulate all the presenters and, of course, their teams behind all their presentations for the hard work, for the implications, for this decision to participate, to get involved in such a great experience. And I want to congratulate them all for the presentation and for the hard work and for being involved in research since medical school.
Thank you, Doctor. Dr. Adrian?
I want to congratulate all of the team at the IGMS for this event, for this first World Conference, and also encourage all young scientists to keep participating in these kinds of projects and not giving up on their dream of becoming a researcher or an investigator, a scientist.
Thank you so much, Doctor. And by the end of this session, I would love to thank you all, the presenters, the judges, the team. Thank you so much, everybody, and our audience, of course, for being with us and voting for the presenters. And now we will be moving to a break, which will be an 8-minute break. And you can have your coffee, take a rest, do whatever you want to do, refresh yourself. And we are coming back after 8 minutes. See you soon. Welcome back again, everyone. I hope you enjoyed your little break. And now let's start our next session. Let's introduce our two new judges, Dr. Mohammed Fahmi Duhaim, who is a MPPCH candidate at Alexandria Faculty of Medicine, Alexandria University, Egypt, and Dr. Menia Alexandro Jamin, MD, PhD, Carlo De Vella, University of Medicine and Pharmacy, Bucharest, Romania, Department of Hematology, Center of Hematology and Bone Marrow Transplantation, Fondini Clinical Institute, Bucharest, Romania. Welcome, Dr. Mohammed. Welcome, Dr. Menia. Now let's start with our first presenter, Sylvia Kong, Foundation Doctor, Adenoprox Hospital, Cambridge University Hospitals, NHS Foundation, Trust Cambridge, UK, and her presentation will be Student Perspectives E-Learning in Malaysian Medical College 1 year into the COVID-19 pandemic, a cross-sectional study. Welcome, and you can start.
Can everyone hear me?
Yes, we are able to hear you.
Okay. Okay, cool. Hi, good morning, everyone. Today I'm going to present to you my study entitled Student Perspective on E-Learning in a Malaysian Medical College 1 year into the COVID-19 pandemic. It's a cross-sectional studies. Before I start, let me just introduce myself. I'm Sylvia, a foundation doctor's equivalent to resident doctor in the US, currently in the second year of the training in Edinburgh Hospital in the Cambridge University Foundation Trust in the UK. My team member consists of Jade, medical students in Newcastle University, Dr. Sabrina, currently foundation trainee in Nottingham, the UK, and my professor, Professor Edmund Ong in Newcastle University as my supervisor of the research. This is the content of my presentations today. So why are we doing this research? Because since the start of the COVID-19 pandemic in March 2020, e-learning has been implemented across all the teaching program in Newcastle University, Medicine, Malaysia, and in short, NUMED, which I will use throughout these presentations later. So the frequent disruptions to the delivery of the educations and the migrations to online learning may have negatively impacted the students' academic performance. Although e-learning has been shown to be as effective as face-to-face education, but yet there are still many challenges surrounding its delivery. So the aim of our study is to identify the perceived effectiveness, benefit, and the challenges of the e-learning among NUMED students. So moving on to the research method. So this is a cross-sectional study that was conducted using a self-administered online questionnaire sent via email to all the students in NUMED for a month between 12 July and 12 August 2021. 285 of our university students participated in the online survey, which our study populations consists of the medical students, biomedical science, and the foundation students. The questionnaires comprise of the social, demographic, academic performance satisfactions, and the perceptions of e-learning questionnaires. So the data were analyzed using the descriptive analysis and also the Spearman correlations. So what's our result shows in demographic of the student use of the technology. So the most popular electronic devices that we see that were used were laptops for e-learning, which is not surprising. And also most of the students own at least 2 or more of the electronic devices for e-learning, such like laptop, smartphones, or even tablet like iPad. So we can see that most of the students perceive that their IT proficiency levels as good to proficient, and also describe that the quality of the internet from acceptable to excellent, which is quite surprising in view of the internet, which is quite unreliable in Malaysia. So how our students perceive the experience in e-learning, that we can see that about 73 face difficulty studying online, and more than half that actually were not satisfied with their academic performance. So the changes to the academic performance after the transitions to e-learning, we can see here that about 52, that most of the students reported that their theoretical knowledge will remain unchanged after transitions to online platform. But majority, about 3/4, that we can see that the performance in the practical skills have are negatively affected by the online platform. So the mode of the exam that we can see that most students still prefer the traditional based paper exam and then objectively formatted exam. What's the benefit? What's the perceived benefits of online of the e-learning? That we can see that the main benefit during the pandemic were the safety due to the lower risk of contracting COVID-19, and also the convenience and also the flexibility of the online setting. And how about the constraint that we see from e-learning? The most common constraint that we can see is the lack of the interactions that we can see between the patients and also the fellows, lecturers and peers, and also the technical issues like unreliable internet and the problems with the computer or the technology using for online, and also individual circumstances like lack of discipline, social isolations, and also poor learning environment for the online learning. So this is quite a big table, but in summary that we want to tell you that the student experiences with e-learning were associated with the learners and also educator and environmental factors, which I will break down further in my presentation. So here we can see the learner factor that we
1 minute left.
Okay, right. So individual circumstances and then also the lecturers circumstances and also the environmental factors that we can see here. So this is just to summarize. Student practical skills were mostly affected, benefit and also the constraints of the e-learning and also factor associated with the learner educations and educator and environmental factors associated with the poor e-learning experiences. So in a nutshell, saying that e-learning during the COVID-19 pandemic has impacted students' education negatively, in particular practical skills and performance satisfactions. And moving forward, the university can use this available information to modify and enhance academic support and teaching via e-learning. So these are the references that I use. Thank you very much for listening. Happy to take any questions.
Thank you, Dr. Sylvia. And let's remind our audience to vote for Sylvia by just scanning the code, and you can do the voting. And let's take the questions from our judges. Dr. Minia, would you like to start? Can you hear us?
Yeah, I can hear you. I hope you can hear me as well. So thank you for inviting me. So very interesting presentation. So hybrid learning in medicine, did you evaluate the factors that were associated with difficulties in online? Can you hear me?
It's breaking up.
Did you hear my question?
I couldn't hear very clearly. Can you repeat the question?
Dr. Minia, can you repeat your question, please? Or could you write it?
I think he is just asking about the associated factors, the factor associated with, this, online learning thing, and how
Can you hear me now?
Yeah, I miss his bad.
Thank you, Dr. Muhammad. Yes, Dr. Minia, we can hear you.
I think he's muted.
Yes, he is. Maybe we move to Dr. Muhammad's question and then we go back.
Dr. Sylvia, so nice presentation. I congratulate you on this impressive work. And I'd like to ask you some sort of question related to methodology, just to, confirm on the, I'd say, internal validity of this research work. And my question particularly is about the validation and reliability you used to, for your questionnaire before using it. How you like confirm it that this questionnaire it should be like the question should be the questions that should be asked to get into, the right answers relevant to e-learning. So it's all about validation and reliability.
Okay, so this is not a validated questionnaire, but we actually compile the questionnaires from a few research studies that has been done over in like mostly in the Southeast Asia populations and in the Asian populations. So then we see that how's that fit into our research questions. So then that's how we modify to fit in our research questions. And also we have actually sent a pilot study. So we send it to like 10-20 pages of our students to view the questionnaires that make sure that it's clear to them and they understand the questions before we actually send it out to the whole university to get the students to participate in the studies.
Sounds wonderful. And you did like some sample size calculation for your study, or you didn't do that?
No, so we didn't. So because our university population is about like 700 to 800, so we just invite everyone to participate in the study. So those who responded to the questionnaires was 285, and that's all that we use for our study. We didn't do the sample calculations. So it's about 40% which actually responded to the questionnaires.
Sounds wonderful. And based on your results, what do you think is the method that we can integrate e-learning with, offline education, since we are, going through offline learning again, moving with the vaccination, everything relevant? How do you think that kind of integration should be done, as you recommended in your conclusion, to enhance, offline learning with some kind of e-learning? I'd like to listen about your insights regarding this.
So we obviously have the learner and educator and also the environmental factor. So the learner, obviously, it's depend on the individual circumstances, but on the technical issues and on the educator, we probably, if let's say like there is a technical issues, probably university can help with the technology. And then also maybe if let's say the educator have problems with the use of the technology or doing the online platform, so maybe they can teach them to better equip with the technology and can use them better in moving forward for the online learning in the future, and support in terms of technology also, and maybe on the stability of the network or the computer for the students.
Sounds wonderful. Thank you so much, Dr. Sylvia.
So as we are running of time, actually, I would read Dr. Mini a question for you. Do you think there is still a place for hybrid learning in middle school? Did you evaluate the factors associated with lower efficiency of online versus on-site learning? Make it very brief, please.
Okay, I think they will, in moving forward, the hybrid learning will be one of that because of the convenience and the flexibility of the online platform. I think that will still will be used widely in the future, especially if like online discussions and then on the online lectures or but unfortunately for medical school, especially on the practical aspect, we need to do like bedside teachings and all the clinical and examination skills, those unable to do online teaching. So for that, I think we can enhance on the online platform in the future to use it in the medical school. And did you? We haven't really evaluated the factors associated with the lower efficiency of online versus on-site teaching, but we actually look at most of the time how is it feasible to do online versus face-to-face teaching, especially for the practical skills for the medical students. Yeah.
Okay, thank you so much, Dr. Sylvia. And I would like to thank our judges, Dr. Muhammad and Dr. Minia. And now let's move to our next presenter, Pato Kintan Walandri from Udayana University, Bali, Indonesia. Guys, welcome, Pato.
Good morning.
And the presentation, yes, the presentation is titled Adverse Effects of Third Dose Moderna Vaccination for Healthcare Workers of Udayana University Hospital, Bali, Indonesia. You can start, Doctor.
Okay, thank you very much. Om Swastiastu. Good morning to all attendants. It's a great opportunity for me to present our research here. My name is Putu Kintam Landari. Along with my colleague is Dr. Cokorda Agung Wahyu Purnama Sidi, Richard Christian Steja, Hotra Diputra, Giovanka Ferencia, Jerry Purnawesnawa, Darren Junior, and Foni Premasanti from Udayana University Faculty of Medicine, Bali, Indonesia. And today I represent my college to present our research entitled Adverse Effects of Third Dose Moderna Vaccination for Healthcare Workers of Udayana University Hospital, Bali, Indonesia. To begin with,
Doctor, can you make it just, excuse me, can you make it full screen so we can see better?
Okay, wait a minute.
Don't worry.
Okay, it's good now?
Till now, no, it didn't appear.
Wait.
If it's not working, please resume. We don't have much time.
There is good now?
Till now, no, it did.
Okay, wait.
It's not presenting. But anyway, just continue, please.
Okay, let me start it, explain about the background. In late 2019, COVID-19 virus was found in Wuhan, China, and the COVID-19 had spread rapidly throughout the world, including Indonesia. In March 2020, World Health Organization officially declared COVID-19 as a pandemic situation. And COVID-19 causes severe symptoms, especially for those who have immunocompromised. And this is make it necessary to end the COVID-19 pandemic as soon as possible. And 1 year after COVID-19 was found, the world has successfully in developing COVID-19 vaccine, and the expert believe that vaccine may bring the world to the end of the pandemic. However, with the development of the COVID-19 vaccines, the vaccines is also carries risks of adverse effects for the recipients. Therefore, the purpose of the study was to report how the adverse effects of the third dose of mRNA 1273 or Moderna vaccines on health workers at Udayana University Hospital. And the methods is, our study is a descriptive study, and the data were collected from all health workers who received the mRNA 1273 or Moderna vaccines as the third dose of vaccines, and working at Udayana University Hospital by distributing an online questionnaires. And the data collection was carried out at the end of August on 2021, and this research was approved by the Ethical Committee of Udayana University. Okay, here's the result. From the data we collect, there were 86.9%, or about 553 from 636 respondents received the Moderna vaccines as the third dose of vaccine. As shown in the table, most of our respondents are women, or about 55.8%, with an age range of 20 to 29 years, or about 57.1%. And the interval from the first vaccine to the third dose of vaccines was in the range of 3 to up to 5th month, or about 53.4%. And most respondents had comorbid, such as hypertension, around 3.7%, And the least common comorbid was malignancy and renal disease, around 0.6%. And as much as 18.4% respondents had never experienced infection from COVID-19 before. And then from our study, it was found that perceived side effects were local pain is about 82.8%, and followed by vapors. It's about 56.4%, and then weakness or fatigue about 39.3%, excessive sleepiness about 32.5%, dizziness about 30.1%, and headache about 27.6%, and nausea, vomiting about 21.5%, and other symptoms about 11%, and the last is local eczema about 10.4%, and about 39.9% of respondents felt this
Less
effects.
than 1 minute, doctor.
Okay, about around 12 until 24 hours after vaccinations. Based on data above, it can be concluded that the after effects of mRNA-1273 vaccine or Moderna vaccines as the third dose vaccines in health worker in Diana University Hospital were local pain, fever, weakness or fatigue, excessive sleepiness, dizziness, headache, nausea and vomiting, excessive hungers, and local erythema. And most of these symptoms occur within the 24 hours post-vaccinations. Okay, that's all for me. Thank you for your attention. And Om Santi 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 Om.
Thank you, Dr. Pato. And I would love to remind our audience to vote for you, doctor, by scanning the code, and you just go and vote. And let's have the questions from our judges. Who want to start?
Okay, I'd like to start. Thank you, Doctor, for this.
Side effects in your study.
Dr. Mina, we have started with Dr. Muhammad.
If you'd like to continue, it's okay for me.
Oh, sorry.
It's fine. It's totally fine.
So back to the same question of each cross-section study, I'd like to always press into something relevant to validation and reliability, and to make sure that the questionnaire that was administered was the right questionnaire for people who filled it. Also, I'd like to ask about factors relevant to your questionnaire and any regression models that you have conducted. And I'd like to ask about the external validation of these results being conducted on some local level and the clinical implication of your study. That's all I have for this.
Dr. Muhammad, we only have one question.
Okay.
Maybe we take one of them.
I'd like it to be in such a case. I'd like it to be the external validity and the clinical implication of what they found, because I think this is the most important thing about every research that has been done. Anyway.
Thank you. Yes, Dr. Pato.
Okay, I'm sorry before. I don't really understand about the questions, but let me start to answer. And the validation, we use the questions not in the validation, but as the clinical implication is that the vaccine relatively safe to use. And about the validations or data, the validations in ethical commit of Diana University, and we before we wait a few minutes. Before we spread the questionnaires, we have validations to spread the questionnaires in the health worker before we get the data again.
Okay,
thank you. Dr. Mania, do you have any questions? Yes, we have the question in the comments. Were the side effects in your study self-reported by the vaccinated patients or evaluated by healthcare staff? Your answer, Dr. Patel.
Okay. The effect in my study is reported by vaccinated patients. There is a report by healthcare staff, whereas our study, the questionnaires in our study by participant itself. So we spread the questionnaires to health worker and the health worker participant by itself.
Any other questions from the judges? We have less than 20 seconds. Okay. We have a comment, a question. Thank you for such a great presentation. What was the response rate in the study compared with other studies? How was the prevalence of adverse effect in your study?
Okay, thank you for the questions. And if we compare to other study, there is no big significantly differential about the study with other study. We are research with or compare with the study from Rezika Anand Kalian from Lillington and North California, USA, and Sultan Ayub from Saudi Arabia. There is no significantly different about our research. For examples, in our study, weakness and fatigue, the percentage is 39.3%, but the opposite maybe it's about 65.7 until 75. There's the difference, but in the differential not significantly is in the nausea and vomiting. It's in our study it's about 21.5%, and the opposite or the other journal or research there is 23 until 26.6%. Maybe that's all I can say.
Thank you, Dr. Patel. Thank you so much. And I would love to thank our judges for being with us with asking questions about your presentation. And now let's move to our next presenter, Laureen Possigo, a third-year medical student from Sereni Kimmel Medical College. And her presentation will be Immigrant and Refugee COVID-19 Vaccination Attitudes in South Philadelphia. Welcome, Laureen.
Thank you. Thank you for having me.
You're welcome. Can start.
So I'm Lauren. I'm a third-year medical student, and I'm on Refugee Health Partners, which is an organization at Jefferson on campus. And I worked with my co-committee members on this project, as well as Dr. Morgan Hutchinson, who is an ED doc at Jefferson. And so we were looking at immigrant and refugee COVID-19 vaccination attitudes in South Philadelphia. So as a group, we were kind of reading and learning about how immigrants and refugees have been disproportionately affected by the COVID-19 pandemic, like higher infection rates, hospitalizations, death rates, as well as lower vaccination rates. And so we came up with this idea to determine the specific factors that were promoting and also prohibiting vaccination in the immigrant and refugee populations in our community. And so we did this study actually last year, almost exactly a year ago. And at that time, vaccines in the United States have been widely available for about 6 months. And then another thing going on at that time was that there was a proposed federal vaccine mandate that was announced for employees with 100 or more employees and workers in healthcare facilities. That was going to go into effect in January 4th. It has since been overturned, but at the time, this was something that we were really interested in looking at, whether this was actually motivating people to get vaccinated and how that played into people getting vaccinated in these communities. So we conducted this study at the Weiss Wellness Center in South Philadelphia. It's a newer clinic. It was newer at the time, about 7 to 8 months. And so it primarily serves the Southeast Asian and Hispanic immigrant and refugee populations of South Philadelphia. We didn't directly ask people demographic information because we got IRB exemption for this project. And so we weren't allowed to collect that information, but we looked at data from the clinic itself, which actually has like a primary care office, and looked at the demographics of people that were coming to this clinic. So we administered the survey over 6 days, about a year ago, and just asked people what made them decide to get vaccinated, if anything prevented them from being vaccinated, if they were required to be vaccinated, and how they felt about this proposed vaccine mandate. Our results, so we ended up getting 145 responses. The majority of people were getting their booster shot, but 26 people were getting their first or second shot. And when we asked people what made them decide to get vaccinated that day, people getting their first or second shot were motivated mostly by vaccine mandates at work or concern for health or the health of their family. And people receiving their booster shots were most likely motivated by health and traveling for the upcoming holidays. So when we look at the chart on the right, we asked both groups the percentage of like were they required to be vaccinated. And so both groups, the first and second dose and the booster dose groups, were required almost equally to be vaccinated by their workplace. But people getting their first or second dose were more likely to be motivated by work as the reason that they are getting vaccinated. Another interesting finding was that in total, most people did approve of the vaccine mandate. And we weren't sure if this is representative of people's actual opinions because we were in the position of being healthcare providers, and a lot of patients don't want to disappoint their doctors or healthcare providers. So we thought that that could have been a confounding variable for that number. And then also looking at people getting their first or second dose, we asked them what had prevented them from getting the vaccine before today. 34.6% said that they had been hesitant due to various reasons, such as concern for how quickly the vaccine was made, concerns about the efficacy or the side effects, the long-term side effects that we might not know yet. And then 60% said that nothing had prevented them. And so again, we might not have gotten the most honest answers from everyone. We did do this study in a public area after people got vaccinated. They kind of went to this public waiting area, which is where we asked them. And so everyone could kind of hear their responses to that question. The conclusions that we drew from this study was that vaccine mandates appear to be an effective method of motivating people to get their first and
1 minute is left.
As 34% of people getting their first or second dose cited vaccine mandates as the reason for getting their vaccine. And we also concluded that messaging should continue to demonstrate the safety and efficacy profiles, as this seemed to be an effective way of promoting booster vaccinations, but it wasn't as effective in promoting people to get their first or second dose. One of my sources, and thank you all for listening to my presentation.
Thank you so much, Doctor. And I would remind our audience to vote for Lorraine by scanning the code, and you just vote for her. And now let's take the questions from our judges. Dr. Muhammad.
Thank you, Dr. Lorraine, for this nice presentation. And I'd like to ask a question relevant to the comparison you are expecting for immigrant refugees compared to U.S. citizens regarding the vaccination from the results you got from your study?
Yeah, so we actually went in with kind of the expectation that access to vaccines would be more of an issue in these communities, but because this clinic had been so well established for at least half a year, we didn't get so many people saying that they hadn't had access before or were having trouble accessing, finding a free clinic. And so I think that this might be more similar to the US citizen population. I think that it would be interesting to compare those two, though.
Okay, thank you.
Okay, so let's take Dr. Armenia question. He's asking, did you also check for if the country area from where the refugees, immigrants were coming influenced their decision to get vaccinated? How about exposure to fake news?
Yeah, so we didn't ask demographic information because we got IRB exemption. And so we talked about that though afterwards, about how that would have been really interesting to see their perceptions based on like where they're coming from or stuff like that. And then we also did ask a question at the end about like where they got their information, and people who are hesitant, we asked like what made them hesitant or stuff like that. And I think a lot of people, they get their information from a lot of like friends and family. And so I don't think that they really see it as, or like fake news, you know. I think that we may label some things as fake news, but I'm not sure that everyone sees like that information in the same way.
Okay, thank you so much, Dr. Lori. Thank you, Dr. Muhammad, and thank you, Dr. Armenia. And now let's move to our next presenter, Dr. Manisha Kanumri, who's an intern at Medicity Institute of Medical Sciences in India. And her presentation is the impact of COVID-19 on people's access to healthcare and health behavior in a sample of Indian population, a cross-sectional study. Welcome, doctor. You can start.
Thank you, Dula. Is my screen visible to everyone?
Yes.
Yes, okay, thank you. Hello to our esteemed judges, presenters, and viewers in the audience. I am Dr. Manisha Kanumri, and it is an immense honor to present our paper, The Impact of COVID-19 on People's Access to Healthcare and Health Behavior in a Sample of Indian Population. This paper was co-authored by Dr. D. Shailendra, our mentor and professor, and our colleague, Dr. E. Arjun Kumar. We're from Medicity Institute of Medical Sciences in Hyderabad, India. So basically, the background of our paper, we have brought forth this paper with the main purpose of identifying the public's non-COVID healthcare needs in a time of complete lockdown and restrictions, trying to understand their behavioral influences and exploring different modes of treatment, why they chose different behavioral methods and why they chose different ways to, see their healthcare needs resolved, to plan for future emergencies. The COVID-19 pandemic's unrelenting nature has prompted radical restrictions in several nations to contain the spread. Such restrictions we know can go from curfews to complete lockdown. So as I mentioned, the exact nature of challenges faced by people, possible avenues they explored, and the means that they used to navigate these healthcare needs are largely unknown in India and likewise at the time globally. The study, therefore, aimed to characterize the challenges in accessing healthcare and the countermeasures that people adopted to mitigate such challenges in order to prepare for similar situations that may arise in the future. Methods. This was a cross-sectional survey conducted in a sampling frame of 600 individuals using a 26-item questionnaire on Google Forms. The questions that we had written were designed to capture the following variables: demographics, limitations to accessing healthcare, use of alternative or traditional systems of medicine as countermeasures against COVID-19, diet and lifestyle modifications as a prophylactic measure to COVID-19, as well as their opinion versus actual use of telemedicine consultations. This questionnaire was developed based on reports in the media, opinions of public health experts, peer groups, colleagues, and their families in social media, as well as professional networks. Individuals who chose to participate were allowed to choose multiple options, and only the first 3 questions regarding their age of participation, consent, and gender were mandatory. We had left the remaining questions as optional to allow for a more democratic approach. The participants were students, medical students at Medicity Institute of Medical Sciences, Hyderabad, and their family members, all aged 18 years or older. In the middle of a contagious pandemic where the only source of contact with these people was to reach out online, trusted medical students were used as our ambassadors to share our request for the online survey, this prompting our objective, which also promotes the fact of why we decided to do this as a democratic approach. Being as our only approach to people was online, we felt that if we had to force everyone to answer every question, we wouldn't get valid responses. So we left it more open. These students and their family members broadly represent an urban and rural cross-section of society at large. In most of the locations in India and similar settings in other low and middle income countries throughout the Indian subcontinent and South Asia. Results. We had a response rate of 41.7%. 67% of these participants expressed having experienced challenges during the lockdown. More than 63% of the participants said that they had defaulted on their regular follow-up visits if they had chronic illnesses such as hypertension, diabetes, chronic kidney disease, etc. Nearly 50% of the reported participants reported taking unprescribed medications such as vitamin C, multivitamins, D, vitamin B complex, zinc, calcium, and prophylactic antibiotics. Self-medication was higher among urban residents as opposed to the rural and semi-rural counterparts, to which we concluded that it could be due to the fact of the lack of resources or knowledge or availability to self-medicate oneself. Non-medical preventive measures like steam inhalation or diet modification were followed by more than 65% of the participants. Nearly 33% of them had reported to using alternative source of medicine such as Ayurveda or homeopathy. And about 50% reported that they were against online consultations and would never try it. So why did we do the study? What are the practical applications? So in view of the restricted mobility, impaired access to healthcare, and lack of organized information resources in the pandemic, understanding the challenges faced by people and their health behaviors can help devise efficient strategies for the future. Understanding the extent of interruption of continuity of care in chronic conditions such as hypertension or diabetes has relevance to foresee and mitigate consequences.
Left, doctor.
Okay, thank you. The inclination to self-medicate, follow non-medical preventive measures, and alternative systems of medicine was much higher due to reports from the mass media and their purported benefits. Identifying and mapping such sources of information can help in influencing people's behaviors. We can help to see how the stakeholders can engage the community. You know, if they find social media as a fine source of information, people in this industry could use it as a way to promote more effective use of information. Attention to creating awareness and availability of telemedicine services across variable geographic locations can help in ensuring equitable access to healthcare to all, promoting continuity of care to those with chronic conditions, even in remote and underserved locations. Exploring and understanding locally prevalent perspectives and behavioral changes Therefore, we can change and provide context-specific and culturally acceptable solutions of local relevance with implications in similar settings elsewhere.
Thank you, Dr. Manisha.
Thank you. Thank you.
Thank you. And now let's move to our judges and to hear their questions. But before, let's remind our audience to vote for Dr. Manisha by scanning the code and just you do the voting. And let's start with you, Dr. Muhammad.
Okay, thank you, Dr. Manisha. Really very insightful presentation, and the topic is really important in terms of understanding the behavior of patients or population regarding healthcare, which is an important topic in my point of view. I was curious about one point you raised during explaining your results, which is that 50% of the population of your study are getting unprescribed supplements. What do you think are the factors that's affecting that kind of unprescribed medications they are taking? Have you tried to explore the factors, underlying this unprescribed supplement, prescriptions?
Right. So at the time when we had done the study, which was prime COVID-19 hit, it was lockdown. People were in a panic because they didn't know what the virus was. They didn't know how it can be attacked, how it can be fought. So many people often, I believe, doctors or clinicians or anyone who thinks that, something might have helped, multivitamins could help with the immune system. Antibiotics could help, prevent any further infection. People have clinicians or people in the medical field try to think of their own methods, which is, again, this was a time when we didn't have any idea what was going on. So such ideas put forward by clinicians And this idea is perpetrated by the mass media, the news articles, or people learning online or on social media. This kind of helped them to think, okay, I'll try this. If this doesn't work, let me try this way. At one point, multivitamins became like candy. People used to take it just so that they felt safe, because at the end of the day, we all want to feel safe when we don't know anything about what's happening.
Okay, sounds great. Thank you.
I think we are not having Dr. Minia. Do we have his question?
I have some kind of question regarding the validation of the questionnaire you're using. You just explained that you used like a combination of methods to collect, the items for your 26 items for your questionnaire or something like that.
Yes.
I'm quite curious about the validation of your questionnaire.
Right, of course. So how I had mentioned that we had created the questionnaire was, again, based on demographics, limitations, stats in healthcare, and their modifications in diet, lifestyle. At the time when we did make this questionnaire, we had been seeing reports in the media, people were reporting Ayurveda is beneficial for their health, homeopathy. People were, as I mentioned, taking many kinds of vitamins, medications, and oftentimes they were not prescribed to themselves. It was they were not prescribed by a doctor, it was self-prescribed. So we were motivated to do the study in, seeing these reports and seeing how much actually is valid in this. What is the validity? How are people actually believing this? Is it valid to believe it? Are they following it, appropriately? This was essentially like a reflection of a larger scheme of things. Kind of, how, if in the social context of India, how necessary is it to follow the mass media in terms of, modifying their lifestyle, taking Ayurveda, homeopathy, or taking self-medication, and how we can apply it more cost-effectively, culturally sensitive locations throughout the world, which was the way we created the questionnaire.
Okay, thank you.
Thank you, Dr. Manisha. Thank you so much for your presentation and your answers.
Thank you for your time.
Muhammad. Thank you, Dr. Minia. And now let's move to our next presenter, Dr. Haider Al-Ibrahim, Faculty of Medicine, Aleppo University, Aleppo, Syria. And his presentation will be Healthcare Provider Burnout in Syria during COVID-19 pandemic's Omicron wave. Welcome, Haider. Can you hear us? Just unmute yourself, please. Welcome, and you can start. Haider, are you able to hear us? Okay. Haider, today, try to turn off your camera and to present. I can hear you now.
Unfortunately, the connection is bad, but I will try to explain.
Okay. Maybe you try to turn off your camera and maybe this will make things easier. Yes, please.
Can
go
you?
ahead. No, I can't. Yes, I can see your screen now.
Now I am hearing you. Can you see the slide?
Now, no. They are downloading now. Just wait a moment.
Can you see the slide?
Yes, yes. You can start. Haider?
Hopefully you are doing great. My name is Haider Ibrahim from
Continue. Guys, can we contact Haider so we can tell him that he is, we are able to see him?
My name is Haider Ibrahim. Today I'm going to introduce entitled Healthcare Providers Burnout in Syria During COVID-19 Pandemics, Omicron Wave, a cross-sectional study, a cross-sectional research dealt with a range of psychological problems during the COVID-19 epidemic, including sadness, mental discomfort, anxiety, and poor sleep. During the COVID-19 epidemic, including sadness, mental discomfort, anxiety, and poor sleep. Burnout is a state of prolonged work stress-related psychological, emotional, and how many healthcare workers burned out during the Omicron wave of the COVID-19 pandemic, and to find out what the factors put them at risk for this psychological effect. COVID-19 pandemic to evaluate the burnout experienced by Syrian physicians who treat COVID-19 patients. The inclusion criteria were all Syrian healthcare workers who treated COVID-19 patients in the current Omicron wave of COVID-19. The data was collected between 3 March to 20 April 2022. We investigated whether the questionnaire used was valid and understandable to the participants. Regarding the results of our study, a total of 729 healthcare providers involved in our study. However, 30 participants were disqualified because their answers were not fully completed. The overall age of the participants was 31 and standard deviation was 9, and the ratio of males to females was almost equal. The majority of the sample studies participants are residents counted 47.5% and 70 were much more emotional exhaustion. Also, the participants who cared for COVID-19 patients were much more likely to report experiencing a high degree of emotional exhaustion compared to others, which individuals who didn't care for. Finally, regarding the inclusion of our abstract, our research found among Syrian healthcare providers during the Omicron wave of COVID-19, with clinicians carrying of COVID-19 patients being considerably more likely to express high burnout than others. For this reason, it's imperative that we collaborate with international humanitarian organizations to provide a suitable and provide practical recommendation to address this important concept.
Thank you, Haider. Are you able to hear us? Okay, and I don't know if he is able to hear us actually.
Yes.
Oh, good. And now let's move to our judges. Dr. Muhammad.
For your
Let's start with you.
I'm ready
Dr.
for any
Muhammad.
question.
Okay, but before we hear Dr. Muhammad's question, I want to remind our audience to vote for Dr. Haider by scanning the code, and you vote for Haider. Go ahead, Dr. Muhammad.
Okay, thank you, Dr. Haider, for your presentation about burnout in healthcare providers in Syria. And I'd like to ask you regarding what kind of questionnaire you relied on. I know that maybe there's some kind of questionnaire called for healthcare or in general that's used for burnout. Did you relate on this questionnaire or any other questionnaire? Can you hear us, Heather?
It looks like the internet is somehow.
It's interrupt.
Please, can you repeat? I cannot. The connection is bad. Actually, I cannot do anything. Sorry, I am so sorry.
He can write in chat, right?
Can I reply about the question in comments?
Yeah, I can do that, of course.
Yes, Dr. Muhammad, please write your question, and also Dr. Minia, if you can write your question, so Haider can answer the questions either by the mic or just writing them down. And also we have a question from the public. Actually, maybe we present it so we can see it. So, okay, let's take first of all, Dr. Muhammad, a question. What kind of a questionnaire you relied on during this study? Yes, Haider. If you can just answer the question by writing it down or...
Yes.
Yes. Yes. Can you see the question?
The questionnaire was divided into two questions. The first section about socio-demographic variables and work-related characteristics such as age, gender, marital status, number of children.
Haider, continue. We are able to hear you. Okay, so we take maybe.
Okay, good. I was said the first section about the social demographic variables and work-related characteristics such as age, gender, marital status, number of children, job. Second section assists care providers burnout during the COVID-19 pandemics. The part is based on the March burnout inventory, published the data in the literature.
Yeah, I
Can you hear me?
Before, yeah,
yes.
I was asking for. Thank you.
Okay. And Dr. Mina has a question, which is based on your findings, can you propose any strategies to reduce burnout in healthcare workers where they offered psychological support? Haider, as we are running out of time.
Questionnaire.
No, Dr. Mina is asking about, can you propose any strategies to reduce burnout in healthcare workers where they offered psychological support also in your study? Okay, so as it looks like that the internet is not helping us that much. So thank you so much, Dr. Haider. Thank you, Dr. Muhammad, and thank you, Dr. Mina. And let's move to our next presenter, Osei-Junior from College Research and Innovation Hub, University of Ibadan, Nigeria. And the presentation is titled Epidemiological and Clinical Characteristics of COVID-19 Related Mortality in Oyo State, Nigeria. Welcome, doctor, and you can start. You are muted.
Let me sort that out.
Yeah, go ahead.
Can you hear me?
Yes.
Okay. So my name is Osei-Junior. I'm a medical student in the University of Ibadan in Nigeria. I'm taking this presentation on epidemiological and clinical characteristics of COVID-19 related mortality in Oyo State, Nigeria. Sorry. Sorry, can you see my screen?
We are able to hear you. Yes. It's not moving.
Yeah, I'm trying to figure that out.
Maybe you try to stop share and reshare, or guys, if we have the presentation of Dr. Emo. Can you reshare now?
Not exactly. I can't. It seemed to have hanged. Is it possible that the slides can be shared for me?
It's fine.
My laptop is not moving.
I think to save time, maybe you can start and then we follow you with the slides. Dr. Emo. It looks like that we also lost him. He's back. Okay, so
my slides are moving now. Sorry for that.
That's fine. It's fine.
Can you see my slides and can you hear me very well?
Can you hear me? Just yeah.
Yes, I can hear you. Right. These are my co-authors, and we're all biomedical students from.
Reshare the screen. Reshare the screen, please.
All right. So can you see my slides?
Okay.
My slide visible?
Yes, yes.
Sorry for that. So I'm taking a presentation on the epidemiological and clinical characteristics of COVID-19 related mortality in Oyo State, Nigeria. These are my co-authors. I'm a medical student from University of Ibadan. This is my outline. So on March 11, 2020, the World Health Organization declared COVID-19 a pandemic. Although the pandemic has abated, stable population around the world, and it is caused by severe acute respiratory coronavirus 2 secretions, direct contact, and aerosol. As of November, the 6th of November 2022, the world health cases 6.5 million deaths globally and over 3,000 deaths in Nigeria. There's, however, a paucity of published research from Africa describing the epidemiological and clinical characteristics of COVID-19 dissidents. So the aim of our study was to identify the epidemiological characteristics and comorbidities of COVID-19 mortality cases in Oyo State, Nigeria, and to understand the relationship between these epidemiological characteristics, comorbidities, and COVID-19 mortality. So this study is a retrospective cross-sectional study of COVID-19 mortality that occurred in Oyo was carried out with reverse transcriptase polymerase chain reaction testing of nasopharyngeal and oropharyngeal samples. Data collected included age, sex, occupation, local government area, duration of hospitalization, comorbidities, clinical diagnosis, place of death, antemortem and postmortem COVID-19 status. Now, we analyzed using the independent test and the Whitney U Kruskal Wallis H test, were used to evaluate continuous variables. Test of proportion and the chi-square test were used to investigate categorical variables. And statistical variables analysis was performed with the Stata/MP version 14.2. So from our study, most of the diseased patients were male and made up about 57% of the total cases, as compared to the female patients who made up just for about 47%. And the reduction in the number of deaths in the female population has been attributed to their strong immune response due to their sex hormones and other psychosocial and biological factors. Also, the fact that there's a downregulation of the ACE receptors, which is a form of entry for the SARS-CoV-2 virus. Majority of the patients were aged 40 years and above, with only 7.5% age below 40 years. We also found the mean age of disease to be 64 years. So from this table just summarizes the details of dead patients, age, sex, and comorbidity. The age range between 60 to 79 had an increased number of deaths, and there was presence of comorbidities with hypertension, diabetes, cancer, and end-stage renal failure being the most common. So hypertension and diabetes were the most common underlying conditions reported, with a percentage of 36.4% and 26.5% respectively. And significant associations were found between having a comorbidity and sex, with the male gender having more comorbidities compared to the female gender. Almost 1/3, that's 31.6% of the included cases, died within a day of hospitalization, and the median duration between hospital admission and death was 1 day. And this could be attributed to the late presentation of patients to the hospital, especially when they're severe, or the stigma around COVID-19, especially in that period between 2020 and 2021, and this could have led to the late presentation. And there was also a significant difference between duration of hospitalization and the status at death. Patients managed as suspected
Less
cases
than 1
had a
minute, doctor.
shorter duration of hospitalization before death compared to the confirmed cases. So in conclusion, the results of this study showed a high proportion of COVID-19 mortality cases were of age greater than 40 years, male gender, and had comorbidities. So knowledge of these associated characteristics can help physicians identify and effectively manage patients with increased risks of severe outcomes of COVID, and hence reduce morbidity and mortality. So it's important that people with an increased risk of severe outcomes observe preventive measures and be vaccinated against COVID-19. These are my references, and thank you for listening.
Thank you so much, doctor. And now let's move to the questions from our judges and remind our audience to vote for Dr. Imo by scanning the code and just to do the voting. And let's start with Dr. Mohammed.
Thank you, Dr. Lemo, for this nice presentation. And I'd like to ask about some statistical question. And I noticed that you used like non-parametric tests like Kruskal-Wallis and Mann-Whitney tests. What is the reason for that? Have you investigated normality before it, or is it just because you assumed the non-normal distribution of data?
While looking through the data, we realized that the data was quite skewed, and there was a lot of deaths recorded in during the duration of hospitalization in the first few days. The first day was recorded, so we assumed, we suspected and presumed that could be the case, and so that was the reason why we used that. That's why seeing the late presentation of patients and poor health-seeking poor seeking behavior of people around here in Nigeria.
Okay, thank you. Thank you.
Dr. Minian, do you have any questions?
Yes, hello. Did you perform any in-depth statistical analysis to check which cardiovascular comorbidity was associated with higher mortality rates in COVID-19 patients?
Well, from the data we collected, it was basically most reported comorbidity was hypertension, and there was really hardly any other one reported. But hypertension was known to be the most common amongst the patients, and as reported from our study, about 36.4% of patients had this.
Okay, I don't know if we have questions from the audience. Do we have any questions? If so, can we present them on the screen? And as long as we don't have any questions from our audience, I would love to thank you, Dr. Imo. Thank you, Dr. Mohammed. Thank you, Dr. Mina. And now let's move to our next presenter, Isthar Binel Gozman, a fifth-year medical student, School of Medicine in Honduras. And her presentation will be Harlequin color change in a neonate positive to COVID-19, a case report. Welcome, Dr. Penel. You can start.
Good morning. My name is Esther Pinel. I am a fifth-year medical student in Honduras, and today I will be presenting a very unique and rare case of harlequin color change in a neonate positive to COVID-19. Many newborns infected with COVID-19 have been identified worldwide. Therefore, there is still a need to characterize the clinical manifestations and their management in this age group. To this day, there is no published case of SARS-CoV-2 infected newborn with harlequin color change in the world literature. Harlequin color change is a rare, benign, and self-limited phenomenon that occurs in healthy neonates in the first few days, and there are few reported cases of this harlequin phenomenon. We present a case of a newborn with severe symptomatic COVID-19 presenting with the harlequin phenomenon. Given the low incidence of both entities in isolation, since they were found in the same patient, we postulate the strong possibility of SARS-CoV-2 as the cause of the harlequin phenomenon in this particular case. We also suggest considering the harlequin phenomenon as an indicator of severe COVID in newborns. This is a newborn of a 34-year-old woman with type 2 obesity, complicated by gestational diabetes and mild preeclampsia, uncomplicated spontaneous vaginal birth at 37 weeks on June 6, 2020, with normal amniotic fluid and weighing 3,785 grams and Apgar score 6 and 8. At 4 hours, he experienced progressive respiratory distress with expiratory grunt and cyanosis with a Silverman-Anderson score of 4, which led to his admission to the intermediate care unit. The baby was started on IV fluid, antibiotic coverage with amikacin and ampicillin at standard dose and given oxygen. At 20 hours, exacerbation of the respiratory distress occurred with a Silverman-Anderson of 6, signs of low output and vasomotor changes that consisted of unilateral hyperemia and simultaneous contralateral pallor with a sharp line that divided the left and the right sides of the body that affected the trunk, the extremities, and the face. This condition is known as the harlequin color change that we can appreciate on figure 1. This remained for 10 minutes and began to fade on its own until it disappeared completely, and only one episode was reported. At 22 hours, he began to progressively deteriorate, hypoactive with a capillary refill time greater than 3 seconds, peripheral cyanosis, and Silverman-Anderson of 6, for which he was admitted to the pediatric intensive care unit. He underwent endotracheal intubation and was placed on mechanical ventilation. On admission, he presented metabolic acidosis with blood count appeared within normal ranges and negative blood cultures. The patient progressively evolved to respiratory deterioration that required mechanical ventilation, intensive care, and developing multi-organ failure on the 6th day. The chest X-ray that reported pneumonia-like basal opacities brought on by asymmetric ground glass atelectasis. At 17 days, the patient received a positive RT-PCR result for COVID-19, and despite a proper respiratory support, PIP and high PIP, high-dose steroids and third-line antibiotics, antifungals, kinesiotherapy, and continuous nebulizations, he evolved to respiratory failure. And due to the poor neurological prognosis, only supporting measures were provided and passed away at 22 days due to respiratory failure. The mother tested negative for SARS-CoV-2 IgG and IgM antibodies on many occasions. Literature that describes the epidemiology, clinical presentations, and prognosis of SARS-CoV-2 in neonates is scarce. The findings of studies from high-income countries and low-income countries show a significant heterogeneity in the incidence of pregnancy complications, meaning the adverse outcomes were much higher in low-income countries. Congenital and intrapartum SARS-CoV-2 infections in the fetus and newborns is possible, but it is rare. Neonates born to SARS-CoV-2 seronegative mothers could be vulnerable to severe manifestations because of the lack of protection usually provided through transplacental IgG transfer. The likely source of SARS-CoV-2 infection for this newborn was the labor and delivery room where 3 nurses tested positive for SARS-CoV-2. 4 births with COVID-19 have been reported in recent studies, and patients with COVID-19 can rapidly progress to an acute respiratory distress syndrome. A systematic review done by Pache et al. Reported 1,965 newborns, which 118 tested positive and 13 died. Several clinical symptoms such as fever, disseminated intravascular coagulation, feeding intolerance, bleeding, cyanosis, dyspnea, and pneumonia have been reported in neonates infected with COVID-19. Fever and respiratory tract symptoms such as cough, dyspnea were the most common symptoms in neonates, but one of the most important and noticeable findings were the cardiovascular problems, such as tachycardia and hypotension. Neonatal pulmonary changes in the chest CT scans were most like unilateral or bilateral ground glass opacities, and pneumonia was also one of the most common neonatal complications of COVID-19 disease reported in other reviews. In regards to the harlequin color change, under close observation, its true frequency in newborns is reported to be close to 10%, and it is described in the text.
Dr. Panel, less than 1 minute to go.
Is described in textbooks as a rare phenomenon. However, there is much incoherence in the literature concerning the actual incidence of harlequin color change, since many physicians claim to never have seen one in their many years of practice. So it is stated that it can affect up to 10% of full-term babies. Its etiology is unknown, but it has been associated with a hypothalamic functional immaturity, and neonates with harlequin color change are in good general condition. It occurs in healthy newborns and in the context of drugs, hypoxia, prematurity, and congenital heart disease. Episode lasts between 30 seconds to 20 minutes and resolves spontaneously and appearing from 1 to 12 episodes per day, although it can arise as a single episode. It happens from the second to the fifth day after birth, and the intensity of the color depends on the severity and varies from neonate to neonate. Just to close this off, globally, there are still knowledge gaps in the epidemiology, clinical manifestations, and outcomes of SARS-CoV-2 infection and the Harlequin phenomenon among neonates. As the number of neonatal cases around the globe continue to arise, there is still need to further fill this gap. There were limited guidelines on treatment approach for COVID-19 in neonates, so few specific interventions were used in this newborn. And there is no literature linking the Harlequin phenomenon to COVID-19. So this is just a pure association. Thank you.
Thank you, Dr. Penel. Thank you so much. And now let's move to our judges to hear the questions from them. And before this, I would love to remind our audience to vote for Dr. Penel by scanning the code and just to vote for her. And let's start with Dr. Minia this time.
Okay, so very interesting case report. Do you have any explanation for the occurrence of this phenomenon in this patient with COVID-19? So how could this virus trigger this clinical phenomenon?
With the current available technology, there is no way to prove that the Harlequin color change was caused by the COVID-19. So this is just a pure association, and it is up to you to draw the conclusions. But as I said, given the low incidence of both entities in isolation and they were found in the same patient, there is a strong possibility of SARS-CoV-2 as the cause of the Harlequin phenomenon. Also, the Harlequin phenomenon has been linked to patients with sepsis and hypoxia. And the Harlequin syndrome, which is different from the Harlequin color change but has some of the same physiopathology, has been linked to some viruses.
Okay, so
Thank you.
Let's take your question, Dr. Muhammad.
Thank you for this very interesting case you presented today, Dr. Ether. And it's not, a question. It's like a comment that that you confirmed upon, and I'd like to confirm upon again that any association doesn't mean causation, and this is just like a hypothesis generator, not a hypothesis proving. Like case reports are quite hypothesis generator for future studies that can prove more of solid association. And I'd like to thank you on the ground facts you explained that could give us kind of hypothesis generation that both of the two entities could be associated together. Thank you again.
Thank you very much.
Okay, any final comments, Dr. Penel?
No comment, thank you.
Okay, thank you so much, Dr. Penel. Thank you so much, Dr. Muhammad, Dr. Mina. And now let's move to our next presenter, Yazan Khairuddin, Japan, Faculty of Medicine, Damascus University, Damascus, Syria, and his presentation will be Assessment, Knowledge, Attitude, and Practice toward Tuberculosis among Syrian People, and an online cross-sectional study. Welcome, Yazan. Are you able to hear us, Doctor? It looks like that our guests from Syria today are facing some technical and internet issues. Maybe we wait till things could be solved. I think we have Dr. Yazan again. Maybe we try only with a mic without a camera. I don't know if we can. No, Dr. Yazan, we are not able to see you. Okay, and to save the time, let's move to another presenter until we have this issue figured out with Dr. Yazan. Our next presenter will be Dr. Khalid Al-Bakri, Faculty of Medicine, the Hashemite University, Jordan, and his presentation will be Safety and Immunogenicity of COVID-19 Vaccines in Patients with Cancer, a network meta-analysis of 11,357 patients. Welcome, Dr. Khalid. You can start.
Hello, Doctor. I try to show the.
Yeah, share your screen if you're able to.
One minute, please.
It's fine. Just, I don't know if you can just be able to press present.
Present the abstract without screen.
No, with the screen. Just press it.
I try to do it.
Click on the present. Try to click it. Okay. So maybe also we wait Dr. Khalid until the issue of the presentation be solved, and maybe we can help him in the presentation. Dr. Khalid is here again.
Is it done?
Yeah, yes. Okay, it's
good.
Perfect.
Good. Sorry for this error.
You can start.
Hello, everyone. My name is Khalid Bakri. I'm fourth year medical student at the Hashemite University in Jordan. This presentation is going to be for the safety and immunogenicity of COVID-19 vaccines in patients with cancers. I want to tell you the story of this project before starting to present the abstract. The aim of the story is to know the aim of this study. This idea was crossed my mind when I noticed that almost all randomized controlled trials and non-randomized clinical trials examining the efficacy of the COVID-19 vaccines were excluding the cancer patients. Then I talked with one of my mentors called Dr. Mahmoud Abbas, who is a consultant in breast cancer, and asked him if there is an evidence regarding giving the vaccines to the cancer patients. Then he told me that there is no any evidence about this up to that time, and the doctors advises their patients to take the vaccines or not based on the history and the prognosis of the patients. Also, he told me that the patients are very hesitant to get the vaccines. Here, the idea was fired in my mind, and I went to search if there are systematic reviews published in this topic or not. And literally, I found nothing. Then I collected the team and we started working on this idea, but we faced some obstacles as there are some members in the team who are still beginners, which delay the progress of the project. Anyway, we were very happy to be accepted in this conference. Thank you. And now let us start to talk about the abstract of the project. Safety and immunogenicity of the COVID-19 vaccines in patients with cancer, a network meta-analysis of 11,357 patients. Here the authors, background and aim. The COVID-19 pandemic has had a devastating impact worldwide, especially among patients with cancer, as they are more likely to experience severe infection and worse outcomes than the general population. Cancer patients have been excluded from the confirmatory clinical trials, as we said before, creating a gap in the clinical data addressing the effectiveness and safety of the vaccines in this group of immunocompromised patients. Therefore, this study aims to evaluate the findings of all relevant individual studies about the serological response to COVID-19 vaccines in cancer patients compared with healthy participants. Actually, we compared cancer patients with healthy participants, as well as we classified or we divided the cancer patients into two groups: cancer patients with solid tumors and cancer patients with hematological tumors, and compared them with each other. We searched for published relevant studies in the following electronic databases: PubMed, Scopus, Cochrane Library, and Web of Science from inception until 1st August 2022. This time is for the last updated search. The first one, I think, was in January or February. Data were extracted from eligible studies and pooled as a risk ratio or mean difference in the meta-analysis model with the corresponding 95% confidence interval. We used the random effect model in case of significant heterogeneity. Otherwise, a fixed effect model was used. We analyzed the data using R and RevMan. We used R for network meta-analysis and RevMan or review manager for conventional or simple meta-analysis. Comparisons: we compared cancer patients with healthy participants, and we compared solid cancer patients with hematological cancer patients, and we compared patients who took complete vaccination with patients who took incomplete vaccination, as well as we compared therapy states with each other: patients who were on active therapy versus patients who were off therapy, and patients who never ever had any therapies, which is called naive therapy. And we compared types of therapies: chemotherapy, hormonal therapy, and immunotherapy with each other. And finally, we compared types of vaccines in terms of their efficacy and side effects: Pfizer, AstraZeneca, and Moderna. Outcomes: seroconversion rate, anti-SARS-CoV-2 titer, T-cell response rate, antibody binding rate, and adverse events. Assessment of bias tools: Newcastle Ottawa scale for observational studies, and we used ROB2 for clinical trials. Results: we included 42 studies, 3 randomized controlled trials, and 39 observational
Less than
studies with
1
a
minute,
total
Dr.
of
Khalid.
11,357 patients. In this meta-analysis, the pooled effect estimates showed that healthy participants were better than patients with hematological cancer in terms of seroconversion rate. Here you can see the statistics. However, the pooled effect estimates showed that there was no difference between healthy participants and cancer patients with solid tumors in terms of COVID-19 antibody titer, T-cell response, and adverse events. Here also you can see the statistics. Additionally, there was no significant difference between the different types of vaccines in terms of COVID-19 antibody titer. The results of seroconversion rate: I chose the seroconversion rate specifically to present its results in details because it's the most common reported outcome in the included studies. Here I present the results of the seroconversion rate in terms of types of our comparisons: cancer patients versus healthy participants. Healthy participants showed better response than hematological cancer patients, but no significant difference was found when compared to solid cancer patients. Solid cancer versus hematological. Solid cancer patients were more likely to be seroconverted compared to patients with hematological cancer. Complete vaccination versus incomplete vaccination. Patients with complete vaccination had higher response than patients with incomplete vaccination, which makes sense. Therapy status: both naive treatment and off-treatment patients had better response than active treatment ones. However, there was no significant difference between naive and off-treatment patients. Types of therapies: patients took hormonal therapy and had better response than those took chemotherapy and immunotherapy, which is interesting result. There was no significant difference between chemo and immunotherapies. Types of vaccines: there was no significant difference between each of them. Conclusion
Thank
and
you, Dr.
conclusion:
Khalid.
I almost finished.
Okay.
In conclusion, the current evidence demonstrated that the seroconversion rate in healthy participants was higher than in patients with hematological cancer. Nevertheless, our meta-analysis revealed no significant difference between healthy participants and solid cancer patients in terms of COVID-19 antibody titer, T cell response, and adverse events. However, the present evidence is not sufficient to confirm the safety and efficacy of COVID-19 vaccines among cancer patients, as our included studies were mainly observation studies, which don't provide a good evidence. Therefore, further RCTs, randomized controlled trials, are recommended. Thank you.
Thank you so much, Dr. Khalid. And now let's move to our judges to hear the questions. And let's remind our audience to vote for Dr. Khalid by scanning the code and just you do the voting. And let's start with Dr. Mina.
Very interesting presentation. I was wondering whether did you perform any subgroup analysis amongst hematological cancer patients to see if there was any difference between patients diagnosed with myeloproliferative versus lymphoproliferative disorders.
This was one of the recommendations for further studies to compare specific hematological tumors in upcoming studies. But in our study, we didn't subgrouping this outcome.
Okay, because it's interesting to see if patients that are on monoclonal antibodies or patients who have hematological cancers that affect B cells and T cells have a lower seroconversion rate.
Actually, I read some studies concerning this idea, so we didn't do that.
Okay, so let's move to Dr. Muhammad, if you have any questions.
Yeah, actually, thank you, Dr. Khalid. Very impressive work and presentation. And I was really interested while you're speaking about the hormonal therapy response and how it's different from other, therapies. And what is your speculation of underlying mechanisms regarding this? Why you expect the difference? And even for subgroups you were comparing, it's interesting that there is some kind of difference.
Actually, we still didn't know why. We still searched for some explanations in the other studies, other primary or original studies, to try to explain how this difference has occurred.
Yeah, nice, perfect.
And we asked the senior doctor, which I told about him in the beginning of the presentation, Dr. Mahmoud Abbas, and he is working on that with us.
Yeah, nice.
Okay, thank you so much, Dr. Khalid. Thank you, Dr. Muhammad. Thank you, Dr. Mina.
Thank you.
And now let's move to our next presenter, Dr. Yazan Al-Zamer, fifth-year medical student from Jordan University of Science and Technology. And his presentation will be Assessment Knowledge, Attitude, and Practice Toward the awareness of clinical doctors and medical students towards monkeypox in Jordan, a national cross-sectional study. I think, yes, now we have the right Dr. Yazan.
Can you guys hear me right now?
Yes, I can hear you, Dr. Yazan. You can start.
Good evening or good morning, where you guys ever at. My name is Yazan Al-Zamer, and I'm a fifth-year medical student at the Jordan University of Science and Technology, a medical school at the Hashemite Kingdom of Jordan. I'll be presenting on behalf of my colleague, Dr. Ahmed Al-Jibali. He couldn't attend. I'll present the abstract for the paper, Awareness of Clinical Doctors and Medical Students Towards Monkeypox in Jordan. It was a national cross-sectional studies conducted by myself and my colleagues to assess the overall knowledge of medical students and practicing physicians throughout the Hashemite Kingdom. As a small background on the aim or the objective of this paper, 4 months ago during our current year, and as we are just getting a small recovery out of the COVID-19 pandemic throughout Jordan, Jordan healthcare authorities have conducted or diagnosed the first monkeypox case coming from outside in Jordan, and this has raised an alarm throughout the kingdom, and particularly throughout the healthcare system, being afraid of a second pandemic, God forbid. So we conducted an early study. The aim of our study was to assess the overall knowledge throughout medical students and physicians, as they represent the first line of defense throughout the kingdom for such emerging cases. And thus, this is why grants our paper a huge opportunity or importance on a national level. Our methods, the way we conducted the paper, was a cross-sectional study assessed through sending out questionnaires both on online platforms and collecting them physically. We conducted a cross-sectional study throughout medical students and physicians throughout different hospitals with all levels of medical practitioners, including residents, interns, and specialists, assessing their knowledge regarding monkeypox virus. Data from the WHO, CDC, and the previous literature on the topic were used to design this questionnaire and its components. The questionnaire consists of 53 questions divided into 3 main subcategories, assessing the socio-demographic status of variables of participants, the work-related characteristic and environment regarding these physicians and medical students, and the general and specific knowledge surrounding the monkeypox virus itself. A snowball sampling was employed since it was convenient to assess such thing, and it was easier to conduct a larger sample size. Data were analyzed using an SPSS, and we conducted a p-value of 0.05 as significance. Our results found that we conducted our study over 423 healthcare professionals and medical students. It was unfortunate that only 31 of the respondents have ever received information about the monkeypox during their studies in medicine. The average overall score, mean and median, was 12, close to 13, ranging from 4 to 25 out of the 53 questions we had. More than half of the participants have heard about the monkeypox, simply hearing about the virus itself. And about 46% of the respondents reported that they have they've heard about the monkeypox virus itself a few days ago for the first time, given that the infection has received a media coverage after the diagnosis of the first case. Most participants had a low level of good knowledge about the monkeypox virus, given the amount of correct answers earlier mentioned, about only 12. Only 2% of the respondents had correctly identified the natural host and incubation period of monkeypox, and this shows that physicians and medical students have a really low amount of diagnostic suspicion for such case, which again grants the importance of our paper. Furthermore, more than half of the participants correctly answered signs and symptoms of the monkeypox. Almost 49% of the respondents believe that monkeypox and smallpox have a similar signs and symptoms of presentation. Respondents aged more than 30 years old have a higher knowledge. We conducted a logistic regression for such thing. Respondents were who are specialists had a higher knowledge of the monkeypox virus itself. Okay, as a conclusion from results of our paper, given that Jordan has a strategic geographical location and surrounding countries showed recently an incremental amount of cases throughout their healthcare system. Monkeypox awareness within medical students in general and physicians, to be specific, is important, and assessing of the defense system throughout these studies on a national level do help us maintain a plan throughout public health awareness for the general population and specific awareness campaigns for medical students and physicians in order to defeat or prevent hopefully an upcoming epidemic or a pandemic, God forbid. Thank you, guys.
Thank you so much, Dr. Yazan. And let's take the questions from our judges, Dr. Muhammad and Dr. Mina. And let me just remind our audience to scan the code and to vote for Dr. Yazan. Go ahead, Dr. Muhammad.
Thank you, Dr. Yazan, for this very interesting presentation about monkeypox. I'd like to ask you to elaborate more about sample size calculation and sampling. Since you are including medical doctors and medical students, I've expected the sample size to be larger than that. So I'd like to know what is your sampling strategy? What is your sample size calculation basis for that?
We conducted a sample. We calculated an appropriate sample size throughout national government numbers on regards of the amount of residents and medical students throughout Jordan, and we've calculated. I think it was throughout a program given by the CDC. I wasn't particularly responsible for the step of the project. Nonetheless, we conducted. The number was concluded to be appropriate given the amount of national number of physicians and medical students throughout Jordan. So it was calculated.
Gotcha.
If this is what you're asking for.
Yeah, gotcha. Thank you.
Dr. Mina, do you have any questions to Dr. Yazan?
I don't have any questions.
Okay. Do we have any questions from the audience? Team? No, it looks like we don't have any questions. So I would like to thank you, Dr. Yazan, for being here and presenting the work. Thank you, Dr. Muhammad. Thank you, Dr. Mina. And let's go back to our presenter from Syria, Dr. Yazan, Japan, Faculty of Medicine, Damascus University, Syria. Welcome back. Can you hear us? You can start. Yes. Dr. Yazan, are you able to hear us? I don't know, team, if we can contact with Dr. Yazan, so we know. Okay, it looks like the internet's still an issue. Okay, so let's move to our next presenter, Dana Sofia Salazar Bermudez. She's a second-year medical student, University of Kunduz, Armenia. And her presentation is Toxoplasmosis-associated lymphadenopathy, description of a series of cases in a reference center. Welcome, doctor, and you can start.
Welcome. Thank you so much for having me. So this is who we are. And the main investigators are Maria Fernanda Ocanegra Valencia and myself. We are, as you said, perfectly second-year medical students, and we're also part of the parasitology and infectious diseases interest group led by Dr. Jorge Enrique Gomez. He is a professor in our university. So the evidence has shown that toxoplasmosis infection is more severe here in South America than in any other continent. So that's why we found so important to share and analyze the outcome of toxoplasmosis in its lymph node form, which have not been reported in Colombia despite its high frequency, and also potential to end in permanent visual damage, as 12% of patients develop chorioretinal scarring, as we can see here from this 2018 study that analyzed 41 patients and found around 10 of them with with chorioretinal scarring, like the one that we can see here in this picture from the right of the eye of a 13-year-old girl who previously had toxoplasmic lymphadenopathy. The methods that we used were that we reviewed 114 medical records with a diagnosis of toxoplasmosis-associated lymphadenopathy that were from the year 2006 from 2022 at the University of Quindío Health Center. And that we only included the cases that met the following criteria. That even though we found a lot of cases, we only included the ones that had positive IgM or IgG test for anti-toxoplasma. We also included the ones that had lymphadenopathies and that were accompanied or not by fever. And we analyzed the clinical presentation, so if they had asthenia or adenomia, also the presence of headaches, but mostly fever and lymphadenopathies. Those were the accompanying symptoms. And we also analyzed laboratory tests as well. In the patients who had a follow-up, the response to treatment was analyzed. Here we can see some of the lymphadenopathies that the patients come to our health center. They're mostly cervical, but we're going to talk about it more in depth in the results. And in the results, we found that of the 114 cases, 99 met the selection criteria. 63% of the patients were male, and also the location was predominantly cervical adenopathies, with 17% of the adenopathies being located there, that we can see here in this pie chart. And most of them were cervical, and the other percentage that we have were cervical accompanied by other location of the adenopathies. Also, the main associated symptom was fever, with 40% of patients saying that they presented fever throughout the course of their infection. The average number of weeks, the weeks of symptoms was 21.24 weeks, and the main treatment received was trimethoprim sulfamethoxazole with a duration of 4 weeks. Other course of treatments used were pyrimethamine, amoxicillin, and clindamycin in patients that had either known reaction to the main treatment or they had Stevens-Johnson's reaction when initially treated with trimethoprim sulfamethoxazole. In the results, we found that most of the patients are younger than 31 years old. Here it says 31, and the median age was 18 years old. We found a lot of young patients, even some of them infants, or between their first year of life, they had toxoplasmosis symptoms. And our most seropositive group were adolescents, but we also found some patients that were older than 60 years old. And
Dr. Dana, 1 minute to go.
Okay, so we also found 11 patients that had over a year of symptoms, and most of the patients had between 2 or 28 weeks of symptoms. And in the practical applications of the results that I really want to highlight, we found only 33 patients who had a follow-up, and all the patients who were follow-up after 1 year presented improvement of symptoms, so reduction in size of adenopathies and disappearance of systemic symptoms. And the other 66 remaining, we know that at least 12 of them could be having chronic ocular lesions, so 8 patients. That's why we want to highlight the importance of early treatment and diagnosis of patients with symptoms of toxoplasmosis, because it is essential to contact and follow up the patients who didn't have that, because it could be having any long-lasting effects. As said before, chorioretinal scarring is the most relevant one of them, because of the impact in the quality of life of the population. Thank you so much.
Thank you, Dr. Dana. And now let's move to our judges to hear their questions to you. But before that, let us remind our audience to vote for you by scanning the code. Let's start with you, Dr. Muhammad.
Yeah, thank you, Dr. Dana, for this very nice presentation, and I liked the photos and outline actually. What is the comparison of your study results to other studies conducted in other countries than Colombia? Just for comparison, how it's different, how it's similar, and so on.
That's the thing. We actually didn't found any other study that had the characteristics that we want to have in ours. And one of the main thing is that we had such a long period of cases that we analyzed, 16 years from 2006 to 2022. From until May of this year, we even want to have the remaining months of the year, because we still have patients coming in every single day. But that's one of the things, the duration of the study, but also all the things that we analyze. We also analyze a lot of symptoms, and we ask and we revise every single clinical record for specifically if the patient said, I am feeling better after the treatment. So that's something that we didn't find in other studies, and also because it's just too few. There's not few studies, so even the existence of our study is something different that we're doing.
Yeah, thank you so much.
Dr. Mina, do you have any questions?
Yeah, very nice talk. So are patients that present to the hospital with lymphadenopathy routinely screened for toxoplasma in your area?
Yes.
Or is it sometimes an incidental finding?
Well, in our health center, they come mostly referred from other doctors, so they go to the hospital or other physicians, and they don't get a diagnosis of toxoplasmosis. But in our health center, we do scan for toxoplasma. We scan for Epstein-Barr virus and cytomegalovirus and other microorganisms that may cause some mononucleosis like presentation, especially with fever and adenopathies. But yes, we are a reference center here in the city, so we do routinely scan for toxoplasma infection.
Thank you.
Thank you so much, Dr. Dana, for your presentation.
Thank you for having me.
You're welcome. We have some announcements for you guys that we are opening our call for the editorial team next week. So please stay tuned. To apply, you have just to send us your CV, letter of motivation, and timetable availability for 2023. And now let's try again with Dr. Yazan from Syria. Maybe he is available to be with us. Dr. Yazan, you are back?
Can you hear me right now?
Yes, very clearly.
Thanks.
You can start. Just share your screen and
Can,
start.
can you see the slides?
Not yet. Now, yes, now I can see them.
Perfect. Sorry for the technical issues before.
It's fine.
Well,
It's fine.
many thanks for taking the time to attend this conference today. Well, my name is Yazan Jabban, a final year medical student at Damascus University, Faculty of Medicine, Syria. Glad to be here today to give you a quick summary of our paper titled Assessment Knowledge, Attitude and Practice Toward Tuberculosis Among Syrian People, a cross-sectional study. So as we all know, tuberculosis is a highly contagious disease that is transmitted through coughing, sneezing, etc. And airborne precautions should be administered whenever someone is suspected to have tuberculosis. Tuberculosis has the highest mortality rate among other infectious diseases worldwide. Syria and other low-income countries have a higher incidence rate of the TB in comparison to high-income countries. Moreover, stigma toward tuberculosis delays patients from seeking healthcare facilities, and this stigma is extremely high in low-income countries like Syria. So we aimed in this study to assess the Syrians' knowledge, attitudes, and practices toward TB and understand their protective and control practices related to this disease. So how we conducted this study? An online questionnaire through Google Forms was distributed by the data collectors in between 15 September and 7th October this year. And they distributed the questionnaire among Syrians to assess their knowledge, attitude, and practices toward TB, as we said before. This questionnaire was adapted from a previously published studies. Two studies used this questionnaire before. And the inclusion criteria were male and female Syrian citizens aged 18 or above. This survey was divided into four sections. Statistics of the participants. The second section assesses their knowledge. The third section assesses their attitudes toward TB. And finally, the last section assesses their control and protective practices toward TB. So we analyzed the data using IBM SPSS version 28 program, and the data were submitted to descriptive and multivariate logistic regression analysis. So moving on to the results section, among all 1,405 participants, only about 38.6% were males. The research participants' knowledge score indicate that 78.1 have excellent knowledge. However, 54.1% of the participants agreed that shaking someone's hand may transmit tuberculosis, which is false. Then regarding the attitude, more than 2/3 of the participants in the survey had an optimistic outlook. Accordingly, most participants had effective TB preventive and control practices. Also, respondents aged from 61 to 70 had more TB knowledge than other groups, as the mean knowledge score was 6.63, and this association was statistically significant. Also, participants with chronic illnesses had a more positive attitude toward tuberculosis than those without chronic illness. Also, this association was statistically significant. Participants with a university degree demonstrated more TB practice than those with lower levels of education, and the practice score mean was 6.17, and standard deviation was 0.85. Also, participants with a university degree were expected to have 4.38 times more tuberculosis knowledge than those without formal education. Finally, participants with a university degree were projected to practice tuberculosis 10.63 times more often than those without education. And also, this association was
Less than
extremely
1 minute, Dr. Yazan.
statistically significant. So in conclusion, our results indicate that there is poor knowledge regarding the route of transmission of TB, as may transmit tuberculosis. Also, the individuals reported poor practices toward TB. For these reasons, more effort should be made to raise awareness about tuberculosis transmission, as understanding these factors is a crucial aspect in mitigating the incidence of tuberculosis. And lastly, educating individuals about good practices toward TB should take priority in Syria in this time, as war has destroyed the infrastructure of the healthcare systems in Syria. Many thanks.
Thank you so much, Dr. Yazan. And now let's move to our judges to hear their questions. And let's remind our audience to vote for Dr. Yazan by scanning the code. Dr. Mohammed, you can start.
Okay, thank you, Dr. Yazan. I highly applaud your contribution despite all those circumstances with the internet. And I like to highlight that I really loved the way you were tackling the stigma thing in our low middle income countries regarding that kind of diseases as tuberculosis. As for my question, I'd ask about, you mentioned that you used questionnaire from two published studies. Have you translated this questionnaire? Was it validated in those two published studies or not? I'd like to know that.
Thank you, Doctor. Of course, these two studies mentioned that this questionnaire was validated, and also we used the Cronbach alpha correlation scale, and it was above 0.7. And also we translated this questionnaire. It was in English, and we translated into Arabic, and that's it.
Yeah, and used it after translation, like Corbach Alpha used it after translation, right?
Of course, we did a pilot study on 50 participants, and after that we.
Yeah, gotcha. Thank you, Dr. Yazan.
We used the Cronbach Alpha. You're welcome, Doctor.
Dr. Mina, do you have any questions?
Yes, so in comparison with other studies conducted in other countries, is tuberculosis awareness higher in Syria or lower? And what is the clinical applicability of your study? Are you going to propose any measures to increase tuberculosis awareness?
Thank you, Doctor. Unfortunately, the awareness in Syria was lower than the previously published studies that uses the same questionnaire. Study raise awareness by making seminars and giving brochures to patients, to patients attending the outpatient clinics to raise awareness about TB and to educate them. As you know, the war in Syria has destroyed the infrastructure of the healthcare system. So I hope it will be better. Thank you.
Thank you.
Thank you, Dr. Yazan. We are glad that we could hear your presentation. Thank you so much. And before we end this session, there's a lot more of announcements that we love to do. First of all, as will be opening our call for editorial team next week. So please stay tuned. All you have to do is to send your CV, motivation letter, timetable availability for 2023, and just send them to our email, editor.n.chef@ijms.info. I think the message will be appear in a moment at our screen. And also, once you are accepted for the position, either student editor, associate editor, or an ambassador for your country, we will ask you to carry out some courses on the Web of Science Academy and the Committee on Publication Ethics. And also, next year conference called, yes, we are planning for the next year conference. And even though we didn't finish this one, but this is the team spirit that we have here. So next year conference call for abstracts will open in July to September 2023. So start preparations and spread the word so your colleagues can participate for sure. And also, our journal, the International Journal of Medical Students, publishes original research and experiences of medical students and recently graduated physicians, like up to 3 years. So all year round. So please remember to donate using the link available, and it will also appear at the screen. Yes, in a couple of seconds, maybe we will show you the link where you can donate for our journal, the International Journal for Medical Students, www.ijms.info. So at the end of this session, I would love to thank our judges, Dr. Muhammad and Dr. Mina, for their time and their insightful questions. Thank you so much for being with us.
Thank you.
Do you like to say anything?
Actually, it was amazing attending this and listening to all presenters. I like their work, and I'm looking forward to the next year version and the success of this current version. And I'd like to thank you for hosting me today. It's an honor for me.
Thank you so much. Dr. Mina, any final words?
Congratulations to all the presenters. Your work was extremely interesting, and your studies were all scientifically sound. Thank you again for inviting me to be part of this team and to judge on this conference. And congratulations to the organizers. A tremendous amount of work has been invested into this project.
Yes, it is. Thank you so much, Doctor. And by the end of this session, I would love to thank you all, the audience, and our team backstage. Now we are going to take a break, which is a lunch break, actually, for 8 minutes. And we will go back with our third session for our conference. See you soon. Welcome back, everyone. And let's start with our third session in our conference. And let's welcome our judges for this session. Dr. Amelia Maria Jaman, Professor of Pathophysiology, Department of Pathophysiology, University of Medicine and Pharmacy of Craiova, Romania, Senior Specialist in Internal Medicine and Hematology, Clinic of Hematology, Philanthropia City Hospital, and Yavan Zolo, Dr. Yavan Zolo, Global Surgery Fellow, 2022 Mandela Rhodes Scholar, and he's working now as a surgery fellow at the Division of Global Surgery, Department of Surgery, Faculty of Health Sciences, University of Cape Town, South Africa. Welcome, Dr. Emilia, and welcome, Dr. Yavan.
Good afternoon or good evening. I'm glad to be here with you in this Saturday. I want to thanks to the organizers for inviting me to judge this presentation, and good luck to the presenters.
Thank you.
Yeah, hello everyone. As Riley said, I'm Ivan Zolo. I'm a GP from Cameroon, and I'm currently doing my Master of Sciences in Global Surgery, University of Cape Town. So it's a pleasure for me to be here, and I am eager to listen to the presentation and enjoy myself. Thank you very much, Professor Amelia, for sharing the panel with me. It's a pleasure and honor for me.
And now let's start with our first presenter, Yotasawi Chotishang from Thailand. And the presentation title is The Prevalence of a Frank Sign and the Diagnostic Accuracy in Coronary Artery Disease Among Chest Pain Patients at Lam Pang Hospital, Thailand. Welcome, doctor. You can start. We are not able to hear you.
Oh, okay. Can you hear me?
Yes.
Okay. I would like to present the study of the prevalence of the Frank size and the diagnostic accuracy in coronary artery disease among the chest pain patient at Lampang Hospital, Thailand. This is the list of the authors of the study. And we would like to special thanks for staff of medical educational centers of Lampang Hospital and Chiang Mai University to contribute the analysis and collected the data. The author declared that they have no any potential conflict of interest. From the background, one of the leading causes of death in Thailand is coronary artery disease. There are several studies that demonstrate a significant correlation between diagonal earlobe cases or Frank sign and CAD, but the data in Thai population still remain unclear. A meta-analysis of 37 studies in USA, Europe, and other countries have completed more than 30,000 people were included. The results supported the hypothesis that Frank sign could be a marker of CAD, and the sensitivity of 0.62 and specificity is 0.67, and the odds ratio of 3.3. The Frank sign is also associated with the presentation of angina and the severities of CID. Because of the Frank sign is easily to see by the medical student and the medical professional and to identify the atherosclerosis risk factor. The objective of the study was to assess the prevalence of Frank sign and evaluate the diagnostic accuracy in CAD among the angina chest pain patient at Lampang Hospital. The study was a cross-sectional observational study. 309 patients with angina chest pain who underwent coronary angiography and follow-up at the coronary clinic at Lampang Hospital were enrolled in this study. We exclude the patient whose earlobe could not be clearly observed, including the keloid ulcers or earlobes or those with no earlobe. The study was approved by Research Ethics Committee. The sample size was calculated by the previous data of the prevalence of the fangci of transient ischemic attack patient is 73%, and 302 patients were included in the study. The data collection includes the recording the presentation of fangci and consent photographer by the patient earlobe. The accuracy of fangci was confirmed by 3 colorists, and the result of choreangiogram from the medical record. Baseline clinical characteristics and medical comorbidities was corrected by the researcher. The statistic analysis, the continuous variable were presented as mean and standard deviation, and categorical variable were presented in numbers of percent. And the comparison by continuous and categorical variable was analyzed by the independent t-test and Fisher exact test, respectively. The diagnostic accuracy property was performed by using the logistic regression and receiving operative curve, and significant is less than 0.05 is statistical significant. The fangci was defined as a fold of the skin and earlobe which start from the tragus to the edge of the earlobe at about 45 degrees. The result of the study: the patient with angina who underwent the choreangiography following inclusion criteria 309 patients, no fangci about the 110 patients, and positive for fangci is about 199 patients. Is 160 patient was the bilateral fangci, and the 38 patient was the unilateral fangci. Analysis of the fangci and CAD. Most of the people, 60% were male gender, and the mean age is 65 years old. The hypertension and dyslipidemia is the most common of the comorbidity, is 70%, and diabetes is about 28%. And 84% of the patients were present with acute Cori syndrome, maybe the non-STEMI, STEMI, or unstable angina. And this the baseline
1 minute,
characteristic.
doctor.
Okay, at the baseline LDL is 105, and 93% of have a coronary artery disease. And we have a bilateral fangci is about 52.1%, and 64% of the angina chest pain were positive for the fangci, and 64% of the persistent fangci have a coronary artery disease. The odds ratio of the fangci to CAD is 1.1 from the study. From the diagnostic accuracy, is the sensitivity is 0.646, and specificity is 0.38, and positive predictive value is 0.93. And this the ROC curve show the area under the curve is 0.513, but not statistically significant. The limitation of study was a cross-sectional study in small numbers of the patient, and single study. We studied the patient, almost the patient have abnormal coronary angiogram. The small number of the patient who have a fangci with normal coronary artery in our study is too small. And the practical application is high prevalence of fangci in
But your
angina
time is
patient,
over.
64%, and high positive predictive value is 93%, and 90% of the patient ACS have a fangci. The fangci was observed in 2/3 of angina chest pain, and mostly the patient have a significant CAD. The result of the study of fangci is simple, non-expensive, and use non-invasive method for medical student and healthcare professional to identify risk of CAD. Thank you very much.
Thank you, doctor. Thank you so much. And let's move to our judges to hear their questions. But before that, let's remind our audience to scan the code and to vote for Dr. Yotasawi. And let's start with you, Dr. Yavan.
No, thank you. Thank you very much for your presentation. It was an amazing presentation and a very interesting study. I don't have a question. Thank you.
Okay, Dr. Emilia.
Do you know if exists a pathophysiological explanation between frank sign and coronary artery disease?
The frank sign is the one marker for the risk of atherosclerosis list, and it will be to progression to the coronary artery disease or the cerebrovascular disease or transient ischemic attack from the study. I mean, it's associated from the atherosclerosis risk factor.
Okay.
Okay, do we have any questions from the audience? As long as it's no, I would love to thank you, Doctor, for your presentation. Thank you, Dr. Yevan. Thank you, Prof. Amelia. And now let's move to our next presenter, Dr. Divyani Patipahador, Somia Medical College, India, and her presentation will be Effects of Anemia on Cognitive Ability in School-Going Adolescents in an Urban Area in India. Welcome, Doctor.
Hello. Hi. Thank you for having me here. Is my screen visible?
Yes, we can see your presentation.
Oh, okay. Hello, everyone. My name is Dr. Devyani Patte Bahadur, and today I'll be presenting our research paper entitled Effects of Anemia on Cognitive Ability in School-Going Adolescents in an Urban Area in India. My co-author for this research paper is Dr. Deepak Patil, Associate Professor from the Department of Preventive and Social Medicine at KJ Somaiya Medical College. So before I begin my presentation, I would like to introduce myself. I am a recent MBBS graduate from KJ Somaiya Medical College in Mumbai, India. I was a member of the undergraduate medical symposium team during my MBBS years, and currently I'm working as a clinical and public health research trainee at the National Institute for Research in Reproductive and Child Health. So cognitive abilities are the skills which are needed in the acquisition of knowledge, manipulation of information, and reasoning. Intelligence is a composite of several functions and not a single unitary ability. However, we can measure intelligence using intelligence quotient or IQ score, which is derived from a set of standardized tests. This score is multifactorial and it is influenced by various genetic as well as environmental factors. Over the years, various scientists have taken an interest in determining the factors that can influence the intelligence of an individual. One of these factors is the nutritional status. For instance, in the past, there have been research studies that found a correlation between hemoglobin level and cognition. For instance, Agaoglu et al. In 2007 concluded in their research paper that iron deficiency anemia in children can affect long-term cognitive function. A 2010 study by Mubarak et al. Found that behavior problems and low intelligence are significantly higher among anemic children. Another study by Uekshin et al. In 2012 found that children with low hemoglobin levels have significantly lower scores in performance IQ. As we know that adolescence is a period of rapid physiological changes, and this is a time when individuals are predisposed to an increased risk of anemia. This led us to the question that could anemia affect the intelligence quotient of adolescents? So the aim of our study was to analyze the effects of anemia on cognitive ability. For this, we set forth with a few objectives. These were to analyze the hemoglobin status in school-going adolescents by a minimally invasive method, to evaluate the intelligence quotient score using the Mallin's intelligence scale in Indian children, and third, to assess the cognitive function using the mini-mental state examination. Finally, we wanted to compare the IQ scores and cognitive functions between the anemic and non-anemic school-going adolescents who would be a part of our study. We used the following materials for this research project, which included proforma, informed assent and parental consent forms, hemoglobin test strips, Mallin's intelligence scale for Indian children, the Addenbrooke's cognitive examination revised, and the mini-mental state examination. So before we undertook this research project, we first sought permission from the school authorities to go ahead with the project at their site. Ethics Committee approval. Once the Institutional Ethics Committee approved our project, we conducted an information session for the participants and their parents to tell them about our study procedure. And this is where we sought informed parental consent and informed assent of the participants. Following this, a basic interview was done to collect the data of the participants. Hemoglobin estimation was then done using the aforementioned hemoglobin test strip. We used 3 different tools to assess the cognitive status of our study participants. As mentioned before, these are the Edinburgh Cognitive Examination Revised, Mini-Mental State Examination, and IQ testing using the Malins Intelligence Scale. After collection of data, we analyzed it using Microsoft Excel 2010 and subjected it to statistical analysis using the unpaired t-test. This was a cross-sectional study with a sample size of 28. We included participants who were in the age group of 12 to 15 years, that is class 6 to class 9 in the Indian education system. We also included only those who had average marks in their school assessments, that is more than 50%. We excluded individuals who were not willing to participate or those who had a prior diagnosis of a medical or psychiatric condition, and also excluded those who had history of repetition of any class. Our findings showed us that 89.3% of our study population was anemic, whereas only 10.7% had normal hemoglobin level as per the WHO cutoff of 11 grams per deciliter. The table here that you can see on the slide shows the maximum, minimum, mean, and standard deviations of the different parameters that we tested. The mean hemoglobin level was 10.83, the mean MMSE score was 26.61, the mean IQ score was 92.4, and the mean ACER score was 84.18. We also subjected the individual components of the Edinburgh Cognitive Examination to analysis.
1 minute, doctor.
As you can see on the slide, that there is a difference between the scores that the anemic individuals had compared to their non-anemic counterparts. However, when we subjected this data to statistical analysis using the unpaired t-test, we found that the difference is not statistically significant. We also subjected the individual components of ACER to statistical analysis, and even here, the anemic individuals had a slightly lower score than their non-anemic counterparts. However, the p-value suggests that these differences are not statistically significant. Our findings suggest that no statistically significant correlation exists between hemoglobin level and cognitive function in this study. As I mentioned before, intelligence or intelligence quotient is a multifactorial variable which is influenced by genetic as well as environmental factors. These often begin from the prenatal period itself. Our study had a very small sample size, and we believe that other environmental factors such as family income, place of residence, parents' occupation might make it difficult to identify the effects of anemia on cognitive abilities in isolation. We believe that more data needs to be collected to determine the influence of environmental factors on cognition and intelligence. Thank you.
Thank you so much, doctor. And let's move to our judges and to hear their questions. But before this, I would love to remind our audience to vote for Dr. Devyani by scanning the code. And now let's move to the questions. Dr. Emilia?
Thank you for this interesting presentation. You say that iron deficiency anemia in children can affect long-term cognitive function. Did you identify the cause of anemia in these children? And did you treat the anemia and then re-evaluated the cognitive function?
Thank you for your question, ma'am. So the school where we collected the data from is a part of our community health department's community initiative. So once we found the results, we did address the anemia. We supplemented it with iron. However, as a part of this study, we did not divide the study population based on the cause of their anemia. So that is a drawback of this study. This is a limitation. As far as the iron deficiency anemia study that I mentioned in my research project, it did suggest that there is a correlation between anemia and intelligence. However, another study that was published in the year 2018, it was conducted in Pakistan. It found that there is no significant difference in the controls and the case in the two groups when you consider iron deficiency alone. So I guess the jury is still out with respect to whether iron deficiency actually contributes to intelligence or not.
Okay, thank you.
Dr. Yervan?
Thank you very much for the brilliant presentation and the amazing research done. My question is, do you think to the principal investigator. Do you think the severity of anemia could affect the cognitive abilities of the children?
Thank you for the question, sir. I do believe, because there have been research in the past. So I did come across a few research papers that were conducted in children with sickle cell anemia. And as I mentioned before, in iron deficiency anemia, the data that I found was a bit new. I would say it's still not very clear whether iron deficiency contributes to intelligence directly or not. But of course, iron deficiency has its own whole array of health problems. So iron deficiency as such should be considered as a public health initiative, no matter what the effect it has on intelligence. But I do believe that there is a relation between anemia that we should try to address by finding out more about it, by dividing the participants according to the cause, and then maybe conducting a randomized controlled trial by supplementing them with anemia, so that we have better data and can comment on this after we have that solid data with us.
Thank you so much. I think we have a question from our audience. Amalish, very nice presentation. What would a future direction for the information from this study be? Are there any initiatives and further study questions you would like to research?
Okay, that's a very good question. So I do believe that this study should encourage other Indian medical students, researchers, to find the cause of the different factors that can affect intelligence, especially in adolescents, because I do believe that this is an age group that hasn't been researched that often. I have always come across research studies that focus on very young children, so like in the age group of 3 to 7 years, or maybe adults. But this is an age where physiological changes have the maximum effect, I would say. So I do believe that there is a scope for further research in this arena, and that would be my take-home message from this presentation.
Thank you so much, Doctor. Thank you for your presentation. Thank you, Prof. Amelia, and thank you, Dr. Yarvan. And now let's move to our next presenter, Dr. Ali Nawaz Khan, third year MPPS student at SN Medical College and HSK Hospital in India. And the presentation is titled Healthcare Seeking Pathways of Psychiatry Patients in North Karnataka of India, a hospital-based exploratory cross-sectional study. Welcome, Doctor. You can start.
Thank you. Is my screen visible, please?
Yes.
Yeah, hi everyone. Thank you. Hi everyone. I'm presenting my studies as already introduced. The title of my study is Healthcare Seeking Pathway of Psychiatric Patients in North Karnataka State of India, which is a hospital-based exploratory cross-sectional study. So as per the protocol of the presentation, a brief introduction about myself. I'm Ali Nawaz Khan, a third year MBBS student studying Karnataka State, and I have 4 undergoing research projects and a number of certain facts, statistical data about my awards and recognitions. I won't be bragging upon them, just brief about that, some state and national awards as well as international awards and competitions. So what is the basis for my study which provoked me to go for this study? The background, it is that it is because of one of the studies that Prince et al. Study states that throughout the world, the 14% of the morbidities are pertaining to the neuropsychiatric disorders. And as per the WHO studies, 197.3 million people are in such a condition in India, which can be categorized into psychological disorders. Moreover, as we already know, the India comprises about 18% of the total global population. But despite of just 18% of population, it contributes 28% of suicides in the world. Moreover, one of the studies, that is a Kishore et al. Study, states that there are just 3,500 psychiatrists in India, and there is an average deficit of 77%. One of the WHO study also estimates there are 2,443 DALYs, that is disability adjusted life years per 1 lakh population in India due to psychiatric problems. So in Indian, one more study suggests that in Indian society, the mental disorders are thought to be either because of God's punishment for the previous sins, or it may be because of sometimes it is considered as due to bad air. The people, mostly those who are in the joint families rather than those in the single families, they consider that the sorrow and unhappiness lead to the mental disorders. And one of the very peculiar thoughts is that the loss of the semen or the vaginal secretion leads to the mental disorders. So therefore, after seeing all this, we can conclude that the psychiatrist, there is the delay behind approaching the psychiatrist in India. It can be categorized as the non-availability of mental health services. As we saw, there is a 77% of deficit. Moreover, the social stigma, which we just enumerated, the superstitions also associated with them, and unwillingness and inability of the families because of different socioeconomic factors may be considered here. So hence, an understanding of the way to seek care for the mental disorder is paramount importance for me while implementing the mental health services, and hence developing the effective referral mechanisms. So the aim of my study would be to determine the healthcare seeking pathway of the psychiatric patients, those who are coming to the hospital based setup of North Karnataka in India, and I would be using the WHO pathway of care performance materials. So the primary objective of my study would be determining the various pathways to the psychiatric care in form of like new patients who are approaching to the psychiatric department for the study of the study hospital. Secondary objective of my study would have been the explore the social and the cultural determinants of the healthcare seeking behavior in them. That may be one of the major factors. So the procedure and the methodology of my study includes the study design is, as already I've explained in my title, it is an exploratory cross-sectional study. And the source of data are the newly diagnosed psychiatric patients according to ICD Indian Classification of Disease 10. Although ICD-11 has come this year, but I have studied on ICD-10 as a previous study. And those who are visiting the psychiatric OPD in the hospital Amalgamated Medical College of Mine, where I have been studying in the North Karnataka state of India. The sample size as calculated is 340 to 350, taking 33% of the pilot study and 5% of the absolute precision at 95% confidence. The inclusion criteria includes all those who are approaching to the psychiatry OPD of the local hospital, as I already discussed, and fulfill the criteria for being a psychiatric disorders according to the ICD-10, and all those who are must to give the written informed consent by either by the patients or their attenders. So the exclusion criteria include all those who are denying to give the informed consent, that to the prior most exclusion criteria. Secondary, the presence of any major illness, those which needs the like intensive or the surgical interventions. In that case, the exclusion criteria would be applied for them. So the procedure of my study includes the ethical permission from the institutes, and this is the entire protocol which I have summarized into a flow chart. So the first of all, I have to take the explain the nature and the outlook to the of the clinical study to my patients or the subjects, and then I have to seek for the informed consent from them. All those who give the consent, then they would be examined by the consultant psychiatrist to confirm the nature of the psychiatric disorders and to confirm whether they are the patients or not. And once it is confirmed, simultaneously I would have taken the socio-demographic details like
1
education.
minute, doctor.
Yeah. Sorry.
Continue. You have less than 1 minute to finish.
Yeah. Sorry. Thank you. So this is the WHO pathway care performer, which I would have used to get the details, and SPSS software version 19 would have been used. So what is the result that I have obtained? The 32% of the patient first approached to the medical practitioner, followed by the psychiatrist and faith healer, and there was a delay of 24 months reaching to the psychiatric services. So scopes are like we can determine the various socio-cultural profile, education, and attitudes which are contributing to this. Moreover, awareness should be given to the regular medical practitioners, because they are the one who are the referral unit for this, and this will help in preventing the delay and the complications. So conclusion is how the different mechanism of the reaching to the psychiatric services after being referred. This is the conclusion for my studies. That there's a need of the hour for conducting the health education in the mental health so as to address the culture, myth, and stigma also. This is the pro forma which I have used and references. Thank you.
Thank you, doctor. Thank you so much for your presentation. And now let's move to our judges and the questions. But before that, let's remind our audience to vote for Dr. Ilanawaz Khan by scanning the code you can see on the screen. Let's start with you, Prof. Amelia.
I have no questions for this presentation.
Thank you. Dr. Yavan?
Thank you very much. Very interesting presentation. And it's so much interesting because most of the times patients suffering from psychiatric issues, their care is not well understood in a way, and few students, it's rare for me to see medical students like really being interested to that. So I have two questions. The first question is to know, like, I don't really have a good idea of how the medical system in India is. In India, do you have like traditional healers legally permitted to care for patients, psychiatric patients in India?
Yeah, thank you for the question, sir. Yeah, that is the biggest issue that we face in our Indian society so far. Like, although the literacy is high, but the problem is like still the people are first referring to the faith healers and the quacks that we use here. So they believe like they are the one who can heal them earlier than they are not aware much. Psychiatry is one of the branch like any other department like gastroenterologist or neurology. So still they have that practice in this 21st century. That is the worst scenario.
Yes, but I wish to know, is it like, is this practice legal? Like, does the government like accept or recognize traditional healers in your medical system, your healthcare system?
No, yeah. Actually, when you will look at the Indian Medical Council, Indian Medical Council regulations, so it is totally illegal to go to those who are not having any registrations. For even when with respect to the regular medical practitioners, they have to renew their registrations every 5 years. So those who are like not having any registrations, they are not at all. They are illegal and they are to be put behind the bar. And those legally also, if they do any harm, as per the Indian Consumer Act section 88 to 92, if they do any harm in this concern, they would their registration would be taken back and they can maybe put behind the bar for a year of 5 or the 10 years.
Thank you. And the next question is, what was your main limitation for your study?
Yeah, the worst limitation that I would say in my study was the study included only those patients who are coming to the hospital. So those who are aware, though, like somehow they got to know about this department, they only came to hospital. What about those who are still staying in their home and not aware of the psychiatry department? And also those, it is a cross-sectional study, so we don't know how long it has been. That is the worst limitation of my study. Thank you.
Thank you very much.
Hope the answer of your question. Thank you. Welcome.
Thank you so much, Doctor. Thank you, Dr. Amelia. Thank you, Dr. Yavan. And now let's move to our next presenter, Dr. Veer Sakara, who's a fourth-year medical student, Faculty of Medicine, University of Colombo, Sri Lanka. And his presentation will be prevalence and associated factors of psychological distress of patients with stroke attending the clinics of the National Institute of Neurology of the National Hospital of Sri Lanka, Colombo. Welcome, doctor. You can start. Can you please unmute yourself?
Good
Go
afternoon,
ahead.
ladies and gentlemen. I'm a fourth year. I'm Pumudu Veerasekara, fourth.
Yes. Start.
Good afternoon, ladies and gentlemen. I'm Pumudu Veerasekara, a fourth year medical student of the Faculty of Medicine, University of Colombo. And we are here to present our research on the prevalence and associated factors of psychological distress of patients with stroke attending the neurology clinics of the National Hospital of Sri Lanka, Colombo. So before actually going into the topic itself, I'd like to dwell a bit on the main points, on the main topics that have been discussed in our research. So first, I'd like to speak about stroke. According to the WHO, it's basically defined as a rapidly developing clinical signs of local or global disturbance of cerebral function with symptoms lasting for at least 24 hours or longer or leading to death. So, and that is associated with a vascular origin and of no other apparent cause. So, with regard to the epidemiology, stroke, as you all know, poses a detrimental effect on socio-economic and health sector, both worldwide and also in the local context. And then Psychological distress, our main other factor point here, is basically defined as a transient modifiable state of anxiety, depression, and other mood disturbances, or could be defined as a negative state of where coping mechanisms and adaptation processes tend to fail. So the reason psychological distress in stroke patients is very scarcely discussed in international and local studies, and even those that are present on this topic have very contrasting and contradicting results with regard to the prevalence overall, as well as with regard to the various factors that influence it on it. So that being the main reason why we chose this topic for our research. On the other hand, psychological distress in addition to stroke itself has an effect on the long-term mortality and morbidity of patients. And then the other thing is there's a relative insensitivity and inadequacy of specific rating scales that are used for depression and anxiety, which I'd like to discuss if the question comes up during our discussion session because of time constraints. So our objective was to assess the prevalence and associated factors of psychological distress among stroke patients. So our study was a descriptive cross-sectional study that was conducted in the National Institute of Neurology or the neurology clinics of the NHSL, ranging from April to December 2021. So the study population involved stroke patients above the age of 18 with a time since diagnosis equal to or greater than 1 month. So our sample size was limited to 120, who were sampled using multi-stage random sampling. The overall sampling is basically could be summarized as such. Our study instrument was a pre-tested interviewer-administered questionnaire, which consists of 3 sections. An investigator-developed questionnaire, which was used to identify the baseline predictors. Section B was a psychological distress scale, which was standardized and validated for Sri Lankan population to measure the outcome. And then Section C, which comprised of 2 parts, a 10-item Barthel index and a modified Rankin scale to assess the level of dependence on activities of daily living and the disability respectively. Ethical clearance was obtained from the ERC of the faculty, and with regard to data analysis, it consists of 2 parts. Mainly, one was the bivariate initial analysis that was used on categorical and continuous variables using chi-square test and simple logistic regression, followed by a multivariate analysis which involved multiple logistic regression. So data was entered and analyzed using SPSS version 26. With regard to the results, we had a response rate of 67.79%, and the mean age was 59.67 years with a predominant presence of males, and most of our patients were ischemic stroke patients, suffered from ischemic stroke, and were of the single ethnicity. So overall psychological distress, there was a prevalence of 23.3% of distress amongst the population. So with regard to the initial bivariate analysis, we found several categorical variables, mainly frequency of engagement of physical and leisure activities, history of psychiatric disorders, and first-degree relatives with psychiatric distress. And then with regard to the continuous variables, we identified mainly 3 times since the last stroke event, level of dependence, and level of disability. So in our final multivariate analysis, we found out 5 main factors: history of presence of history of psychiatric disorders, increasing age, female gender, level of disability identified by
Less
the
than
modified
1
Rankin
minute,
scale,
doctor.
and being the sole source of income to the family. So accordingly, we concluded that there is a 23.3 prevalence of psychological distress among patients, which is considerably high, and there were several factors that was involved with it, which should be identified for directing interventional activities. So we recommend that we establish a standardized protocol for early detection of these patients, and also utilize this final model in order to recognize these patients early, so that they do not progress to the extreme ends of the spectrum, such as PSD and PSA. And also, with regard to the limitations, we had some limitations with regard to sample size, mainly because of pragmatic issues, and there were no temporal associations because of the study design, and extrapolation was limited to the setting itself. The main one that we had was because this was conducted in the height of the pandemic. We had issues in identifying on getting patients limited to those with operational telephone numbers, because face-to-face interactions were limited. So acknowledgements, I like to thank the Department of Community Medicine Prof. Raveen Hangale, Dr. Choudhary Suravira of the Department of Psychiatry, all study participants, my family members, and last but not the least, my friends. Thank you.
Thank you, doctor. Thank you for your presentation. And now let's move to our judges and make a little reminder. Please, audience, don't forget to scan the code and to vote for Dr. Wirisekara. And let's start with Dr. Emilia, if you have questions, doctor.
Yes, so how can you reduce psychological distress in your stroke patients? Do you think? You hear me?
Can you please repeat
How-
the question?
How can you reduce psychological distress in your stroke patients?
Yes, madam. So we can mainly identify using both pharmacological and non-pharmacological interventions. So pharmacology is mainly associated with post-stroke depression and post-stroke anxiety, but mainly counseling and psychological services could be rendered as effective methods of reducing psychological distress in stroke patients, mainly because mainly these patients suffer from a lot because of the disability itself. In addition to that, they have a long-term morbidity and they are impending risk of death added to this psychological distress. So counseling plays a major role in alleviating these symptoms and reducing the level of psychological distress in these patients.
Okay, thank you.
Dr. Yavan.
Yeah, thank you very much for the presentation and the research. Amazing work done. So I wish to know, among the factors associated with psychological distress among these patients, did you find any link between the sex of the patient, for example, the sex of the patient and the occupation of the patient and the occurrence of psychological distress?
Actually speaking, gender itself was not associated with psychological distress in our initial bivariate analysis, but from our literature review, mainly with regard to systematic review that is done by Hackett and Anderson, we identified that most researchers have exempted these factors like age and gender in their initial analysis that could have had detrimental effects in their final results. So they have recommended that they use them in as essential factors in their final multivariate analysis. So when we use that as such in our multivariate analysis, we did find out that it was significant. So even though in the initial bivariate analysis it was not significant, we found out that at the end in the multivariate analysis, after assessing for all the confounders, it did become significant.
Okay, and what about the occupation of the patient?
Occupation as such, the type of occupation was not really associated with psychological distress, but the fact that the patient becomes the sole source of income to the family was considered to be a significant factor in the multivariate analysis, especially in this sort of in this region where we have a patriarchal society with single breadwinners to the family. So if that patient becomes influenced, the entire family breaks down, the entire family system breaks down. So that can have an added psychological distress effect on the patient itself. So we did find out the being the sole source of income to be significant in the analysis, final analysis.
Thank you very much.
Thank you very much.
Thank you, Dr. Wirisekara. Thank you, Dr. Yavan. Thank you, Dr. Emilia. And now let's move to our next speaker, Dr. Osei-Junior Mitchell, a recent graduate from King's College London, and his presentation will be the role and impact of dyslexia awareness workshops in the medical curriculum. Welcome, doctor. You can start.
Thank you very much for the introduction. So my name is Mitch. I'm a recent graduate from King's College and a junior doctor. So I'll be presenting on the role and impact of dyslexia awareness workshops in the medical curriculum. And I'll be presenting it in the standard research format. Before that, we'll talk about the backgrounds in Ijms, and I'll give you a short, very short 5 seconds to think to yourself, what is dyslexia? Okay, so that's the 5 seconds done, and I will now introduce what dyslexia is. So using statistics from where this research was based on in the UK, 10% in the UK have dyslexia, so that's 6.5 million people alone, and 1.7% of the UK medical students have dyslexia. In terms of difficulties, dyslexia involves difficulties with reading speed, comprehension, spelling, grammar, and note-taking. And the strengths include conceptualized thinking, which is good for systems-based thinking, such as physiology and endocrinology in medical school, as well as contextual memorization, which is useful for remembering key stories that you may hear from important cases of patients. In terms of how this can affect the medical school experience for a student with dyslexia, they could be affected by difficulty of the essay-based assessments, which is especially more common in the preclinical years of their degrees. It also could have difficulty in terms of adapting to the study format of the medical school because it's very different to that of different degrees and also pre-learning in high school as well. This in turn may lead to higher rates of lower self-esteem, which could impact on them disclosing their dyslexia diagnosis to their clinical supervisor on placements, which in turn will make them feel unwanted and struggle emotionally during their clinical placements as well. This can be alleviated through the process of reasonable adjustments and near-peer mentoring. So in terms of generally what research has shown in terms of the benefits of near-peer mentoring in medicine, it's shown generally academically it can help you with feeling more prepared, develop the academic skills you need and transition to university much more effectively. And psychosocially, it helps with emotional well-being as well. And this is very crucial in terms of the gaps in literature, because at the moment we don't have any research looking at what medical students' current knowledge and beliefs in dyslexia and their confidence in supporting their peers are. And we have to think that medical students may have a role in mentoring fellow junior medical students in terms of the content of medicine. And as doctors, one of our main responsibilities is teaching medical students as well. And how can we do that if we're not very aware ourselves in terms of dyslexia? So this study aimed to see what medical students' current perceptions on dyslexia are at a baseline level and their confidence at a baseline level, and see if a workshop can make a difference 1 month later on. So in terms of our methods, we recruited 36 first-year medical students through our Medical Student Association through online means. The majority of our sample was indeed female, which is a limitation of our study. In terms of the study itself, it was a pre-post intervention study. So 2 weeks before the workshop, participants were given 2 questionnaires, one being a scale of knowledge and beliefs about developmental dyslexia, which in itself is a 36-item true, false, don't know questionnaire, which is scored in terms of accuracy of knowledge, and also a confidence in supporting peers with dyslexia questionnaire, which was designed by ourselves. So in terms of the confidence, it was a Likert scale questionnaire going from strongly disagree to strongly agree in 3 different domains, one being academic, one being psychological, and the other in terms of signposting to other services that may be of support to peers with dyslexia. So afterwards, we conducted a workshop, which was 1 hour, semi-structured, which covered the diagnostic criteria of dyslexia and the impact on the medical education experience, the reasonable adjustments in services available, and interactive activities, including some simulations and offering advice to fellow peers in terms of academic and psychological challenges. 1 month later, we followed up with the very same questionnaires to see if there was any significant difference made on a more longitudinal level. So in terms of the results, we used a 2-tailed dependent t-test to measure the accuracy in terms of knowledge. And in pre-intervention, we found that the accuracy was less than 50%, so 15 out of 36 items on average in terms of knowledge on dyslexia questionnaire. This improved to a mean of 66%, so 24 items out of 36 in terms of knowledge about dyslexia. And the t-test showed the value to be less than 0.001, meaning that it was statistically significant. Thank you. So in terms of confidence questionnaire, we found on a pre-intervention level that participants generally felt less confident in terms of academic and signposting support for peers with dyslexia, but this improved in all domains after the research, focusing on agree and strongly agree. So in terms of what this means in terms of our conclusion, we have to appreciate that this is the very first study to ever measure medical students' knowledge of dyslexia and their confidence with supporting peers with dyslexia. And at baseline level, we saw that they have less than precise accuracy in terms of knowledge and beliefs in supporting peers with dyslexia. And afterwards, the workshop has shown after a month that it's increased knowledge and provides confidence in terms of supporting dyslexia. Similar findings have been found with university lecturers, where they generally have a lack of knowledge of dyslexia. And dyslexia awareness training has been shown in 3,200 teachers to increase knowledge and confidence, which is beneficial for us as doctors, as clinicians. And with that, that ends my presentation. Thank you, and here are my references. And I'm looking forward to any questions. Thank you.
Thank you, doctor. Thank you so much. And I would remind our audience to scan the code and to vote for Dr. Osei-Junior. And now let's move to questions. Dr. Emilia.
No, I have no questions.
Thank you. Dr. Yervan.
Thank you very much for the presentation and the research. The question I have, you said a workshop was done for the students. I wish to know who developed the content of the workshop. Was it a standard content, or it was like, how was the content of the workshop developed?
So the content of the workshop was developed by our researchers, so myself and my fellow peer, Dr. Mayam, and also our supervisor, Dr. Shangi Lee from King's College as well, who is in charge of the cultural competency component at King's. And so essentially it was designed to be a semi-structured workshop. So the content was essentially, apart from what is gathered from the simulation in terms of advice, it was pretty much the same content that they were getting amongst the participants in the small group workshops.
All right, and is like any of you who developed the content of the workshop, is any of you like an expert in the field of simulation studies and simulation studies?
Yes. So our facilitator, Dr. Shangi Lee, he generally runs simulation workshops at King's College London and has done numerous research with other students on other projects on like racial diversity and other diversity projects himself. So yes, we've had the pleasure of his support in terms of the development.
Okay, thank you very much.
Thank you.
Thank you so much. Do we have questions from the audience? As long as we don't have any questions, I would love to thank you, Dr. Osei-Junior. Thank you, Dr. Yervan. Thank you, Dr. Emilia. And let's move to our next speaker, Miss Lydia Levitt. She is fourth-year medical student at University of Illinois, and she will be presenting the following titled Determining the Ability of the Vision, Aphasia, and Neglect Stroke Scale to Identify Large Vessel Occlusion Strokes within the Pre-Hospital Setting, a Prospective Cohort Study. Welcome, Doctor. You can start.
Hi, everyone. So a bit of background. Strokes are one of the leading causes of death and long-term disability in the world, and 40% of strokes are large vessel occlusions. Large vessel occlusions are occlusion of any of the primary vessels that you see on the screen. So the internal carotid, the middle cerebral, the anterior cerebral, the basilar artery, and the posterior cerebral. And there are 4 levels of stroke certification here in the US. The top highest certification is the Comprehensive Stroke Center, and then we have the thrombectomy capable. So both of those are able to offer endovascular treatment to stroke patients with large vessel occlusions. Then you have the Primary Stroke Center, which is able to provide thrombolysis, and then the Acute Stroke Ready Hospital, which isn't able to provide either thrombolysis or endovascular treatment. So depending on where the patient is first transferred to when picked up by EMS, if there's a suspected stroke, there may be delay in treatment if that patient has an LVO, because they would have to eventually end up at this thrombectomy capable center, either the Comprehensive Stroke Center or the thrombectomy capable stroke center. So if we could identify LVOs in the field, we could reduce this transfer time by transferring these patients directly to these centers, with the caveat that it may be beneficial in some instances if these centers are too far away to transfer them to the thrombolysis center first. This is called the drip and ship method. Additionally, if we're able to identify LVOs in the field, we could also reduce the door to groin puncture time. This is just hypothetical schematic of what may occur and when the patient arrives at the hospital. If we don't know if they have an LVO or not, and that could take 120 minutes for that groin puncture time. But if we could identify LVOs in the field, we may be able to cut that time in half, down to 60 minutes. So our research question, first, there are several stroke assessment scales designed to identify large vessel occlusions. Some of the more popular ones are the ones shown on the screen. And we focus on the vision, aphasia, and neglect, or the VAN scale, because that showed promise in the literature in previous studies. So our research question was, how sensitive and specific is the VAN scale in identifying LVOs in the pre-hospital setting when administered by emergency medical services personnel? So what is the VAN assessment? It's looking at four things. So weakness, visual disturbance, aphasia, and neglect. And so if you have weakness and any one of the following, visual, aphasia, or neglect, then that is considered a VAN assessment, and the patient is thought to have a high likelihood of having an LVO. And so for our research method, any patient that had a suspected stroke, first the EMS personnel would do the Cincinnati Pre-Hospital Stroke Scale, which is the screening scale for stroke. And if that was positive, they would then do the VAN Severity Stroke Scale. All patients, regardless of if they were thought to have a stroke or not, were transferred to the hospital, and we collected their hospital diagnosis. So in total, 324 patients were suspected of having stroke by EMS. Of those, 213 screened positive on the CPSS, and 185 went on to do the VAN scale. For some reason or another, 28 of those patients, of the CPS positive patients, were not able to complete VAN. But no matter what, we got the hospital diagnosis for all patients that were suspected of having stroke and transferred by EMS from the hospital diagnosis. And as you can see, in total, 162 were stroke positive and 27 were hospital confirmed stroke. So again, we compared our VAN stroke scale results collected by EMS personnel to the hospital diagnosis, and we found that LVO was hospital confirmed in 15% of all VAN assessed patients, so 27 patients out of the 185 patients assessed with VAN. And VAN correctly predicted LVO in 81% of patients, so the true positive rate was 22 out of 27. So our sensitivity was then 81, specificity of 56, positive predictive value 24, and negative predictive value of 95. And these were all consistent with previous studies reporting on VAN. And so what we found was that VAN sensitivity indicates that it performs relatively well at correctly identifying patients not suffering from LVO, but its specificity is quite low, and it's actually lower than other LVO scales. And this suggests that if VAN were to be implemented, there may be significant over-triage to comprehensive stroke centers or thrombectomy-capable centers. And this could have major implications in terms of economic cost or resource availability. And so in conclusion, VAN may serve as a quick and straightforward pre-hospital screening tool for LVO prediction. However, a considerable number of false positives and over-triage to the comprehensive stroke centers may result. There were some limitations to the study. First, EMS applied screening tools only when a stroke was suspected. Also, the study design required patients to screen positive for SPSS before VAN was administered, and this caused 10 hospital-confirmed LVO patients not being evaluated by VAN because they screened negative on the SPSS. Also, we had a small number of LVOs, so this can limit statistical analysis, and we captured data from a single EMS system, and so which only served a limited geographical range in northern Illinois, which is a relatively low diverse population. And so in future research, it may be beneficial to have EMS administer VAN to all patients suspected of having stroke, regardless of CPSS results. Also to directly compare several of the LVO prediction scales, ideally using a prospective study such as this, but probably more feasible to do a retrospective chart review. And then another additional research would be to recruit several EMS departments so you can have a much larger diverse patient population. These are my references.
Thank you, doctor. Thank you.
Yes.
And now let's move to our judges and to hear their questions. But before that, let's remind the audience to vote for Lydia through the scanning the code you can see in the screen right now. And let's start with Dr. Yavan.
Thank you very much for the question. Very interesting presentation. Thank you for your presentation. Very interesting presentation. Very interesting research. My question has to do with your exclusion, because you said that some patients were excluded. What was what was the main exclusion criteria that you used? The second one is what was your sampling method? And the last question has to do with compared to the other methods that you listed earlier, how sensitive, you can put it like that, is VAN compared to the other methods based on what is available in the literature?
Sure. So there wasn't really any exclusion criteria. There were 25 patients that weren't able to complete VAN for some reason. They weren't able to just do the test. And so we couldn't really include them in the study, but there wasn't any major exclusion criteria. It could be any patient. And then the VAN is comparable in sensitivity compared to other scales, and actually even more sensitive than some of them. And I forget, you had one other question. I forget what that was.
You had to do the sampling. How did you do your sampling?
Oh, it was just any patient that the EMS were called to. So they went out into the field, and any patient that was suspected of having stroke.
Thank you. Thank you very much.
Dr. Emilia?
It's a very interesting presentations. No, I have no questions.
Thank you. I think we have a question from our audience. Thank you for such a great research presentation. Based on the results, is it worth to keep doing research on the use of that screening tool, or where the research should focus now?
Yeah, that's a great question. I think the research should focus on directly comparing the different scales, because we can't identify one that's more sensitive or more specific just because there hasn't been a study done that directly compares them.
Thank you so much, Doctor. Thank you, Lydia. Thank you, Dr. Yavan. Thank you, Dr. Emilia. And now let's move to our next presenter, Rohi Koliti. Who is a 6th year MPPS student, Bogomolets National Medical University, Ukraine. And their presentation will be a case report of rare type of chorea with hypoxic-ischemic insult. Welcome, doctor. You can start.
Good afternoon, everyone. Let me introduce myself. I'm Ruhi Kolte. I'm currently pursuing my 6th year of MBBS degree from Bogomolets National Medical University, Ukraine. I'm glad to be here with you all today. The title of my case presentation is Case Report of Rare Type of Chorea with Hypoxic Ischemic Insult. My guide, Dr. Gana, she is Associate Professor of Medical Department of Pediatric. She gave her valuable time and constructive and suggestions during the preparation of this case report. We are very grateful to be to the patient and the patient's parents who provide consent for case report. Let's begin. What is chorea? Chorea is derived from the Greek word means dancing. Chorea is an involuntary movement that flows from one body part to another. Such symptoms can be result of autoimmune, hereditary, vascular, metabolic, drug-induced, and psychological causes. It is important to determine the main disease. This will help to prescribe etiologically specific methods of treatment or effective treatment of the causes of chorea. According to the international experts, the following directions of chorea treatment are determined by stopping or changing the effect of causative agent or the treatment of chorea and aimed or eliminated the main etiology. The purpose of my study was to present the diagnosis of chorea with the disclosure of clinical symptoms and discussion of preventive measures and current treatment of chorea with hypoxic ischemic insult. Let's talk about the case description. The 10-year-old male child came with complaints of involuntary movements of right upper and lower limb and slurred speech for about 2 days. There was no fever, no lethargy, or no altered sodium, no convulsions, no vomiting, loose motions, and nor joint pain. The history of similar complaints and hospitalization before was absent. No family history, and immunization history was completed as per the age. BP was normal, pulse rate was normal, respiratory rate was normal, SpO2 normal, temperature was little bit high. BMI, it was underweight. Motor examination and neurological examination was performed and they were normal. Laboratory tests, CBC, CRP, ESR, solubility test, ASO titer, INR, LFT, KFT, TSH, T3, T4, serum ionics calcium, serum celuroplasmin, PTH were normal. ANA solubility test was negative. AA pattern was seen. Fundus examination, right and left fundus normal with no KF ring found. USG abdomen were normal within the limits. MRI of brain was performed. There was seen mild atrophy of right caudate nucleus and suggested the sequel of hypoxic-ischemic insult, where we can see the bilateral dorsal thalamus, which was deep white matter of bilateral perilonetic cortex. They appear hypointensive on the T1 W1 enhancement. The treatment received by the patient was first injection phenobarbital 440 mg in 20 ml with IV stat, tablet haloperidol 0.25 mg, syrup multivitamin 5 ml, syrup calcium 5 ml, tablet folic acid 5 mg. He was admitted for the 10 days, and after 10 days, there was no complaint of involuntary movements and slurred speech. Advice on discharge was given to the patient, that's to continue the tablet of haloperidol of 0.25 mg, one tablet twice a day, syrup multivitamin 5 ml twice a day, syrup calcium 5 ml, and tablet folic acid twice a day. Capsule vitamin D3 was suggested once in a week till 6 weeks, and follow up of the patient should be done every week. Conclusion: according to the literature, patients with vascular chorea usually have an acute or subacute onset of chorea on one side of body, that is hemichorea, contralateral to the lesion. In this case study, the patient has an acute onset with lesions of the right arm and leg. During the differential diagnosis, possible causes of chorea was excluded. Movement disorders have been associated with hypoperfusion and hypofunction in the caudate nucleus, which was determined by cerebral imaging. According to the experts, despite the fact that the prognosis of hemichorea can be benign, the long-term prognosis is determined not by hemichorea specifically. The treatment received was antichoric drugs,
1
which is
minute, doctor.
thank you, is recommended in the acute phase. So the patient was immediately treated when he was went to the hospital. The patient should be under the observation of neurologist to prevent complications. The references I used. Thank you for your attention.
Thank you, doctor. And now let's move to our judges to hear their questions. And before that, let's remind our audience to vote for Dr. Ruhi through scanning the code you can see in the screen. Let's start with you, Dr. Emilia, if you have any questions. You are mute, doctor.
Think which was the cause of the hypoxic ischemic insult which led to the development of chorea?
Sorry, I can't hear you.
Which was the cause of the hypoxic ischemic insult which led to the development of chorea? Do you think in this?
We found vascular chorea because of the MRI, which was showing the mild atrophy of caudate nucleus. The patient is under the observation up till now by the neurologist.
Okay. Do you check it for thrombophilia, for example?
Sorry, I think
Do you
it's not.
check it? Do you check it for thrombophilia?
No,
Okay.
we didn't.
Okay. Thank you.
Thank you.
Dr. Yavan?
Thank you very much for the presentation and the case. So I wish to know what is the rationale? You said in the treatment of the patient you gave multivitamins syrup. What is the rationale for these multivitamins?
Actually, the BMI was low. He was underweight. That's why we provided multivitamins. And at that age, it's necessary to have multivitamins. So that's why.
So it did not have to do with the treatment of the chorea per se.
I think no.
Okay, thank you.
Thank you so much.
Thank you, Dr. Rohi. Thank you, Dr. Yavan. Thank you, Dr. Emilia. And now let's move to our next speaker, Rumia Rafiq, who's a second-year medical student at Wayne State University School of Medicine in Detroit, Michigan, USA. Welcome, Rumia. You can start.
Hello, thank you so much. Are you guys all able to hear me okay?
Yes.
Wonderful, wonderful. Well, thank you so much. Hello, everyone. My name is Rumaya Rafiq. I have my bachelor's in public health from Wayne State, and I've been very privileged to continue my education at Wayne State School of Medicine as a second-year student currently, and I'm here to present some of the research my colleagues and I have been conducting in relation to the outcomes of vascular intervention in diabetic patients with peripheral arterial disease. Specifically, we are looking at Detroit, Michigan. And to begin, I want to take a second to introduce the great team of individuals that I've been working with. And just to allow you to put a face to the name, I've included some images of their lovely faces. We have Mahfoujul Haq, who's a second-year medical student at Michigan State University College of Human Medicine. Shaheen and I, again, are both second years at Wayne State. Arif Hussein has completed his Bachelor's of Science, and we also have our physician mentors, Dr. Mashkoor Hussein and Dr. Saida Risha, who are both MD cardiologists. Throughout this presentation, I will be using a few abbreviations to explain our study, so I've included a list of relevant terms. Peripheral arterial disease, or PAD, is a condition characterized by the narrowing of arteries. It's generally seen to affect the lower extremities, but it can happen anywhere. Usually, atherosclerosis is the underlying mechanism of disease in which deposits of fat plaques occlude the arterial lumen. DM, or diabetes mellitus, I'm sure you all know, is a group of disease conditions characterized by hyperglycemia. And then we also have peripheral vascular interventions, which are minimally invasive procedures that aim to revascularize. And finally, QOH, which is quality of health, a variable of interest for us. And to provide some background on PAD and PVI, in the US, over 12 million patients are affected by PAD, and over 200 million patients worldwide are affected by it. Risk factors include hyperlipidemia, hypertension, smoking, and diabetes. Obviously, if the underlying cause is atherosclerosis, all of these start to make sense. Many studies also suggest that PAD is more prevalent and severe among DM patients compared to their non-DM counterparts. And although it can be asymptomatic, symptoms ranging from exertional leg heaviness to some more significant presentations, including limb loss, are not uncommon. And furthermore, diabetics are at increased risk for these complications, including lower extremity amputation, which is very scary for a patient. Additionally, DM patients with PAD undergoing some more conservative therapies, including lifestyle changes or a heart-healthy diet, are reported to have worse quality of life than those with PAD alone. And given this background, our group is asking, what are the associations that there may be between PVI use in DM PAD patients? And our aims are to understand clinical outcomes of PVI in DM and non-DM patients, as well as to examine changes in PAD-related QOH. And the study was approved by the Institutional Review Board at St. John's Hospital in Detroit, Michigan. Moving on to our methods, of course, you can also use the slide to learn how to test your blood glucose, but I digress. Our study is an observational study. It uses the BMC2 VIC dataset, which is a quality improvement registry that collects data on a continual basis. And it has the participation of actually 47 hospitals here in Michigan. We then instituted an inclusion criteria in which PAD patients who underwent lower extremity PVI in the year of 2012 at St. John Hospital in particular were included. We define lower extremity PVI As any endovascular intervention on an artery in 3 specific areas that included the aortoiliac, the femoropopliteal, and below the knee arterial trees. These patients had their QOH prior to and after treatment assessed by PAQ, which is the Peripheral Arterial Questionnaire. And the status of 502 patients in this hospital were collected, but 115 were excluded due to progression to acute limb ischemia. And we decided to do this because it might not be a fair comparison when we're looking at quality of health when someone has had an amputation or something up to that degree. We then use SPSS to extrapolate median PAQ scores. Okay, I just want to touch a little bit more on PAQ questionnaire and why we found this as the best way to assess quality of health. PAQ was designed to globally evaluate and monitor the health status of PAD patients. And it does so by looking at 6 domains: symptoms, symptom stability, so how your symptomology has changed with time, treatment satisfaction, physical limitation, social function, and finally, quality of life. Scores are going to range from 0 to 100, and higher scores indicate better quality of health and functional status. And to your right is a sample of some of the questions that are included. So things like, how limited are you walking around your home? How much are you able to walk 2 to 3 blocks? Those were asked of our patients. And for results, just highlighting a few points here, after exclusion, we had 386 patients that were included in the final study, and 52% were diabetic. So there was a good representation of both DM and non-DM patients. And then the Rutherford classification and assessment of the severity of PAD did not significantly differ between these 2 groups, and that indicated a similar level of disease severity. But over 99% of participants, thank you, over 99% of participants had at least severe claudication. There were also a lot of comorbid conditions that were higher, significantly higher in diabetic patients, and the prevalence of a previous vascular procedure was 1.5 times higher in DM patients. DM patients did have a significantly lower observed physical function and summary score at baseline, but we did see that in both groups that there was a very similar change in that PAQ score when comparing baseline to 6 months after treatment. And here are just 2 tables. I'm not going to read them all because I know we're low on time, but you can see that for almost every PAQ domain, there was an increase in score, and summary scores showed an improvement in both groups. And then there are many future applications to this research, but specifically some groups of interest are older patients, African-American patients, or patients with prior surgical interventions because they had less improvement following PVI. In DM patients, we saw that increased improvement, so we may more strongly consider PVI instead of some of those conservative treatment managements. And then we also saw that in renal failure patients who had DM. And then there are some limitations, as with all studies, with our observational study. We also didn't consider some of the other symptomology that DM patients might have that can affect their PAQ score. And then for future research, looking at those vulnerable patient groups and doing more large-scale studies would probably be of interest. And then this is just a short conclusion. Obviously, we kind of went over this. I know that we're running low on time, but I do want to thank everyone for giving me the chance to present today, and I'm more than happy to take a couple of questions.
Thank you, doctor. Thank you so much. Now let's move to our judges and to hear their questions. But before that, let me remind our audience to scan the code and vote for Rumia. So, Dr. Yavan, do you have any questions?
Thank you very much. Amazing presentation, great research. I wish to know your findings. Are your findings different from how different are your findings different from what is found in literature concerning this topic?
Yeah, for sure.
Okay, what are the differences?
Yeah, I would say that a lot of studies do look at because with diabetes and peripheral vascular disease, it's the leading cause of non-traumatic amputations in diabetic patients. So there is a lot of studies that are looking at the symptomology, but there's not a lot of literature that we found that's looking specifically at PVI and the outcomes of diabetic patients. So this is a gap in research that we kind of saw, and we were thinking that is why we wanted to particularly look at PVI and patient outcomes in that way. So I'm not sure if that particularly answers if it's different in terms of like what other studies say, but that's kind of what we found through our review of the literature.
Dr. Emilia, do you have any questions? You are muted, doctor.
You hear me?
Yes, now I can hear you.
Did the duration of diabetes influence your results? Did the duration of diabetes influence your results?
That's a great question. So the duration of diabetes influence the result. So that's actually not something that we looked into in our data set, but I think that that's a wonderful way to expand our research to see if maybe long-term diabetics are having more difficult outcomes in relation to PVI. One thing that we did see is that diabetics were more likely to have a prior vascular intervention in comparison to non-diabetic patients. And I'm assuming that with longer disease progression, that likelihood does go up. And that was one thing that did indicate a lower QOH score at the end. So that, that is indicative that maybe there is a sort of relationship there. But I would say that that is something that we would definitely need to consider moving forward.
Okay. Thank you.
Yeah, thank you so much for your question.
Thank you. I think we have another question from our audience. Praise asking, you said one of the exclusion criteria was if their progression to acute limb ischemia. Please, can you elaborate more on this point?
Yeah, for sure. Thank you so much for that question. So with acute limb ischemia, oftentimes it gets to the point where amputation is required and more difficult procedures are required for the patient. And when you get to that point, a lot of the PAQ questionnaire asks about your ability to walk a certain distance, your ability to engage in physical activity, and those types of things. So we felt that it was just not a fair comparison. It would take away from looking at particularly DM versus non-DM groups if we included the acute limb ischemia patients, because they would obviously have to answer the PAQ a lot differently than a patient that was still had some vascularization there.
Thank you so much, doctor. Thank you for your presentation. Thank you, Dr. Emilia. Thank you, Dr. Yavan. And now let's move to our next presenter, Wilson Sebastian Palares, who is a medical student from Ecuador. And his presentation is hypercoagulability and cavernous sinus thrombosis due to protein C deficiency, a case report. Welcome, doctor. You can start.
Thank you for having me. If you can confirm if you're seeing my slides and you can hear me well.
Yes, I can see them. I can hear you.
Okay, good afternoon, everybody. My name is Sebastian Peñafiel. Welcome to the presentation of the case report, hypercoagulability and cavernous sinus thrombosis due to protein C deficiency. We have divided these presentations into 4 main parts. First of all, I'd like to talk about the authors. Second, we'll look at some important definitions and their clinical importance. And finally, I'll tell you about some relevant takeaway messages. About us, we are 5th-year medical students from Quito, Ecuador at Universidad de las Americas, and we have developed this investigation with the help and supervision of Jaime David Acosta. Let's start by explaining cavernous sinus thrombosis. This is a rare subtype or cerebral venous thrombosis, typically septic, that is associated with cavernous sinus syndrome. As you can see in this figure, cavernous sinus contain very important vascular and nerve structures. Right next to the cavernous sinus, we can find the phenotype sinus. This proximity has a clinical importance because infections in the phenotype sinus could affect the cavernous sinus. Anything that compresses the cavernous sinus, like for example, a thrombus, could develop cavernous sinus syndrome. Now, cavernous sinus syndrome is a set of clinical manifestations like proptosis, sensory loss of the cheek and forehead, Horner syndrome, and ophthalmoplegia. This is because these structures, respectively, control the movements of the eye, the levatopalpebral superior muscle, sensations of the cheek and forehead, and some autonomic functions as well. In this slide, you can see the graphic of the classic coagulation cascade. That is a nightmare for so many med students, right? But my objective is not to explain all of it. For purpose of this presentation, all I want you to know is that in order to activate factor 10, we need factor 8. Activating factor 10 with activating factor 5 will form a complex that will transform thrombin into thrombin, leading to a solid clot. Protein C is a natural anticoagulant our liver produces that blocks activating factor 5 and activating factor 8, preventing blood from clotting all the time. So if we have a deficiency of protein C, there's nothing that could prevent the formation of thrombin. And that covers everything I want to say about general definitions. Moving on to the case, we present a 51-year-old woman that arrived at the ER complaining about severe headaches. She did not have any important past medical history and was taking no medication at the time. The physical examination was unremarkable. Her vital signs were not altered. A complete blood count and basic metabolic panel were normal. Finally, a computer tomography scan was only compatible with sphenoidal sinusitis. Because of that, the patient was diagnosed with migraine and treated with analgesics and discharged the next day. It's important to mention that no treatment for sphenoidal sinusitis was prescribed. Over the next 2 weeks following discharge, she slowly started to deteriorate. The headaches worsened and diplopia and swelling of her left eye appeared. The family of the patient brought her again to the emergency room. This time, her condition was severe and she was disorientated. Physical examination showed left preorbital edema, restrictive extraocular movements, diminished sensation to light touch and at the cheeks and forehead, papilledema in fundoscopy. If you can remember, this relates to what I was saying earlier about the cavernous sinus syndrome's manifestations. The patient was admitted, and blood analysis revealed neutrophilia, elevated D-dimer, elevated procalcitonin, and thrombophilia analysis revealed reduced plasmatic concentrations of protein C. Then empirical antibiotic treatment was initiated with ceftriaxone, vancomycin, and metronidazole, in addition to enoxaparin. Magnetic resonance imaging and magnetic resonance venography with contrast were done, confirming the diagnosis of a cavernous sinus thrombosis. After 7 days of hospitalization, the patient had a good outcome and was sent home on dabigatran. This illustration represents all the events experienced by the patient. First, an undiagnosed protein C deficiency promoted the formation of a blood clot in the cavernous sinus. This increased the pressure of the left retinal vein, leading to proptosis and papilledema. After that, an infection arose from the untreated sphenoidal sinusitis, infecting the cavernous sinus. Patient resonance venography and 3D reconstruction showed a decreased diameter, signal intensity, and filling defects of the left transverse sinus, as you can see in this illustration, highlighted by the green arrows.
Less than 1 minute, doctor.
Okay, thank you very much. To conclude, I'd like to say that the diagnosis of a cavernous sinus thrombosis can be done mainly based on clinic. Broad-spectrum antibiotics plus early anticoagulation followed by the dabigatran treatment was associated with no recurrence after 1 year of the treatment with this particular patient. Undiagnosed thrombophilia can be completely asymptomatic for a lot of years. And before we finish, I'd like to leave you with one final thought. When you hear hoofbeats, think horses, but do not dismiss zebras. Thank you very much, and I'm open to any questions at the time.
Thank you so much, doctor. And now let's see the questions from our judges. But before that, let me remind our audience to scan the code and to vote for Dr. Sebastian. And let's start with you, Dr. Yavan. You have questions.
Yeah, thank you very much. A very interesting case. I wish to know what is the, how can I put it? How recurrent, like what is the rate of recurrence of cavernous sinus thrombosis among patients in your area?
Okay, so thank you for your question. That's a really interesting question. When we were developing the investigation, we only found literature saying the current prevalence in talking about world population. It's around 3 to 4 cases per million, talking about general population in the world. However, there have been some publications, unfortunately, saying that there is an undiagnosed of cavernous sinus thrombosis in the area because of the deficiency of sometimes patients don't have the money to access these kind of hospitals or tests to confirm the diagnosis. So there have been some undiagnosed. Unfortunately, in our country, we don't have that technology such as tomography or scans or resonance radiography, so that we can confirm the diagnosis. But worldwide, we are speaking about 3 to 4 cases per million.
Thank you. So, do you think you will more like advise your colleagues or seniors or whatever to like think about cavernous sinus thrombosis when having patient presenting with maybe not all of the signs and symptoms, but once they have, if they have a little, I mean, a certain number, they should think about it.
Correct. I will advise my colleagues to think mainly on clinic. So if we don't have access to imaging studies, I will recommend them to look at the history of the patient. If they have thrombophilia history on her past medical history, I will strongly consider that mainly based on clinic, as you said, ophthalmoplegia or headaches mostly. So yeah, that's what I wanted to highlight in this case. That is like very important, the clinic of the patient.
Thank you very much.
Thank you for your question.
Dr. Emilia, do you have any questions? I think Dr. Emilia have some internet issues. Or can you hear us now? Dr. Emilia. Okay, so if we have a question, yes. Thank you for such a great presentation. It calls my attention, the periorbital edema. Can you discuss some of the differentials and how were they handled in this case? What do you think, Dr. Sebastian?
Great. Yeah, thank you for your question. That's a great question. One of the first differential and most important diagnosis was periorbital cellulitis, arising from a previous trauma or a previous surgery, for example. In this patient specifically, she did not tell us about any specific trauma or procedure done around the eye area. So in that case, what we should do is start with antibiotic treatment due to the possibility of this periorbital cellulitis to cause a cavernous sinus thrombosis. In this case, the cavernous sinus thrombosis per se was the reason for the periorbital edema, but we should always consider periorbital cellulitis first because it's a really dangerous condition. Other than that, we can find also probably giant cell arteritis, but given the patient clinic, we discard this diagnosis because she is not tell us about any specific symptoms or clinic.
Thank you so much. I think the time is over, but Dr. Emily, if you are able to hear us and if you have any question, please write it down in the chat. Okay, so thank you so much, Dr. Sebastian. Thank you, Dr. Yavan. Thank you, Dr. Emilia. And now let's move to our next presenter, Haidar Al-Ibrahimi, Faculty of Medicine, Aleppo, University, Aleppo, Syria. And his presentation is a cross-sectional of Syrians' knowledge of diabetes mellitus and hypertension management. Welcome, Haidar, again. Can you hear us? Haider?
Greeting. I'm so happy to meet you another time. I'm so sorry about the previous presentation, but as I said, the connection here is very bad. However, I hope I can present this abstract better than previous. Let's to start, please. Uh, Here we have a cross-sectional of Syrian's knowledge of diabetes mellitus and hypertension management. Let's to start background. Diabetes and hypertension are the two most common types of non-communicable disease impacting people globally. There is no prior research on the Syrian population knowledge and treatment of hypertension and diabetes, so it's crucial to assess how the Syrian population acknowledges and perceives this illness. This research it intends to assess the level of hypertension and diabetes-related awarenesses, knowledge, attitude, and practice among Syrian individuals. About the methods of our research, we can say a cross-sectional study was conducted between 1 and 25 August 2022 to assess adult awarenesses, knowledge, attitude, and behavior about hypertension and diabetes. The questionnaire for the study was developed based on previous research, and the inclusion criteria for the sample were Syrian residents older than 18 who presently live in Syria. On the questionnaire, there were 4 sections. First of all, socio-demographic information, WHO STEEPS survey statement on knowledge and lifestyles determinants for hypertension and diabetes. Response knowledge of and comparison of hypertension and diabetes, or response awareness of these disorders. Regarding the results, among 976 participants, 65.8% were females. Participants reported hypertension caused by 19 about stress, 78.2 old age, 69 about anxiety, and 38.6% drug usage. Regarding the risk factors of hypertension, the participants reported 97% about high salad consumption, 89 genetics, and 78% obesity. In addition, preventive measures of hypertension considered by participants as say 92 about minimizing salad consumption, 87.2% regular exercise, and 85% about avoiding anxiety. However, participants' answers to hypertension consequences were 75.8% food ulcer and 74% a sight loss. Primary and middle school education status participants had a greater hypertension knowledge than other education levels. Alcohol use was linked to hypertension knowledge, as participants whose lifestyle didn't include alcohol use had a higher hypertension knowledge level. Participants with a family history of diabetes have a greater knowledge of hypertension than those without. Almost all age groups have shown good knowledge of diabetes, especially participants aged above 55. However, most individuals have examined blood pressure, whereas more than half had screened for blood sugar. 92.2% of individuals check their blood pressure frequently, whereas monitor their blood sugar. Men have a higher hypertension knowledge than female, and knowledge of hypertension among participants was shown to be higher among those in good income status than other economic level. Participants between the ages of 40 and 55 showed better knowledge of diabetes compared to other age groups, with men of 11 and standard deviation 2.5. As well, men demonstrated greater knowledge of diabetes than females. To conclude our abstract, we can say our results demonstrated that the Syrian population had a good to moderate understanding of hypertension and diabetes.
Less than
However,
1 minute, doctor.
okay, thanks. However, there is still a shortage of standardized regular screening practice. Since individuals remain involved in unhealthy lifestyles habits, it's vital to provide accurate information about hypertension and diabetes. Thanks for your listening. That's all.
Thank you, doctor. Thank you. And now let's move to our judges to hear their questions. But before that, let me remind our audience to scan the code and vote for Haidar Al-Ibrahimi from Syria. So, Dr. Emilia, do you have any questions?
Now I have none.
Thank you.
I
Dr.
have.
Yavan. Yes, please, doctor. Okay. Dr. Yavan?
Yes, thank you very much for the presentation, and the research question is an interesting one, and I think it's going to really help to provide more data on the topic at hand. So my question has to do with what was the main challenge that you faced during this study? Because I mean, you were trying to tackle or understand a very important problem, and what was the main challenge that you faced while doing this study? Dr. Ibrahim, are you there?
Please, can you repeat? I cannot hear all the
Yes.
details.
What was the main challenge you had during this study? What was your main challenge?
Dr. Haidar.
Oh, about the main challenges. In fact, the main challenge was about poor awareness poor awareness about hypertension and diabetes mellitus risk factors among Syrian population, as well as some people didn't want to participate in this study because he said I don't like this questionnaire or this like studies or like studies.
All right, thank you.
I think we have a couple of questions from our audience to you, Dr. Haidar. Maybe we have the questions on the screen. Thank you for this presentation. Can you elaborate on, first of all, the methods used to develop the questionnaire? Was it validated? And second, what was the sampling method to collect the data?
I cannot hear.
Okay, so I will repeat it. Can you elaborate on the methods used to develop the questionnaire? Was it validated? And what was the sampling method to
Okay,
collect the data?
we used a pilot study where we selected the 15 individuals, and we tested Cronbach alpha, where it was more than 0.7. That's all. About the questionnaire, we used we depended on the WHO database.
Okay.
Can you hear me?
Yes, yes. Do you want to add something? Doctor? Okay. So thank you so much, Dr. Haidar. Thank you, Dr. Ivan and Dr. Emilia. And let me do some announcement that we are opening our call for the editorial team next week. So stay tuned. To apply, just send your CV, letter of motivation, timetable, availability for 2023. Just email these documents to the email you can see on the screen. And once you are accepted for the position, either you are applying for a student editor, being associate editor, or an ambassador for your country, we will ask you to carry out some courses on Web of Science Academy and the Committee of Publication Ethics. And next year conference call for abstract will open in July to September. So start preparations from now and spread the word so you and your colleagues can participate with us next year. And as you know, the International Journal of Medical Students, it's a journal who publishes original research and experience of medical students all over the world, and of course, recently graduated physicians all year round. So please remember to donate using the link available at www.ijms.info. And I would like to thank our judges for the third session, Prof. Emilia and Dr. Yavan. Thank you so much for being with us in this session. Do you want to say anything?
Congratulations, all presenters, for their interesting research work, and also congratulations to the organizers for this interesting conference.
Thank you, Prof. Dr. Irvan.
Yeah, thank you very much for the opportunity given. And yeah, as Prof said, congratulations to the organizers of the event and to all those who presented and those who are following us on YouTube and all the platforms.
Thank you so much. Thank you for being here with us today. I would thank all the presenters in this session and of course our team in the backstage. And now let's move to another break. We will be back in 20 minutes with another round with the new presenters. So see you soon.
Welcome back, everyone. And let's continue our conference with the last session. And our judges for this session will be Dr. Amy DiPlacido, board certified in family and geriatric medicine, affiliated with UPMC, Presbyterian and UPMC Margate, and Dr. Madeleine Cox, University of New South Wales, Sydney, Australia. Welcome, doctors. And let's start our session with our first presenter, Jayatorimoy Biswas, who's a third-year medical student, College of Medicine and Sagora Dota Hospital in India. and his presentation is Authorship Diversity in General Surgery Related Cochrane Systematic Reviews. You can start.
Thank you so much, ma'am. Is my screen visible?
Yes.
Okay. Hello, everyone, and welcome to my presentation. My name is Jyotirmoy Biswas, and I'm a third-year medical student in College of Medicine and Shagor Datta Hospital, which is a medical college in India. Today, I'll be presenting my research findings on authorship diversity in general surgery-related Cochrane Systematic Review. Let's begin with background. So, Cochrane Systematic Review is considered as one of the highest level of evidences in the field of evidence-based medicine. This study aims to determine the gender and country diversity in authorship representation in the authorship of Cochrane Systematic Reviews related to general surgery. Moving on to methods, we searched and extracted data from Cochrane Library on 3rd September 2022 using the keyword general surgery and included published reviews, protocols, and withdrawn publications. We extracted authors' details and searched online to determine their gender, attempting to capture at least one web page demonstrating it. Authors whose gender could not be ascertained were excluded from the gender-based analysis. For graphical representation, we used a choropleth style map. We treated a collaborative author group belonging to a single country, as example, MRC Clinical Trials Unit, which is from UK, as a single author. A second author independently cross-verified the extracted data. Moving on to results, 250 publications with a total of 1,420 authors were included in the current study. 4 authors had affiliation to 2 countries. The leading 5 represented nations in authorship were United Kingdom with 562 authors and 39.4% of the whole representation, followed by China, Italy, Canada, and USA. Syria is the only country among all the low-income countries which had authorship representation and constituted 0.34% of all the authors. India with 8 authors and Nigeria with 2 authors were the only countries from low-middle income groups who had representation. So this image is clearly demonstrating the authorship diversity across countries in a choropleth style map. Again, coming back to result, a male to female ratio in this study was 2.11:1, and there were total 957 male and 453 female authors. Sex data for 10 authors could not be retrieved and were categorized as unknown group. There were 169 male and 82 female first authors with a sex ratio of 2.06:1. One study has designated 2 authors as co-first authors. Women constituted 32.4% of all the corresponding authors. Here again, the sex ratio is 2.06:1. One article did not have any designated corresponding author. 150 studies did not have any female representation in any lead author position. 58 studies did not have any female authors at all, whereas in contrast, there were only 8 studies which did not have any male authors. So this graph clearly shows the gender distribution in authorship, where the total number of authors along with total number of first authors and corresponding authors have been shown. To conclude, I would like to say authors from high-income countries continue to be the largest contributors to Cochrane Systematic Review in general surgery, source of one of the highest quality evidences. There is extremely poor representation of female authors and authors from low and low-middle income countries. Active capacity building efforts are needed in several countries for advancing authorship diversity. So that brings me to the end of my discussion. Thank you very much for your attention.
Thank you, Doctor. And let's move to the questions from our judges. But let me welcome our third judge today, Abi Sheikh Halgar Ashok, NIHR Academic Clinical Fellow, Department of Radiology, Adenoprox Hospital, Cambridge University Hospitals, NHS Foundation Trust, UK. Welcome, Doctor.
Thank you.
Let me remind our audience to vote for you, Dr. Biswas, by scanning the code you can see on the screen. And now let's move to the questions from our judges. Let's start with you, Dr. Amy.
Yes, thank you for presenting. Did any of these results surprise you?
Thank you very much, ma'am, for these questions. Actually, ma'am, it was very much evident because there is already very much a low number of female surgeons in a private practice. And when it comes to any academic institution, there is furthermore less representation of female authors because they have multiple obstacles to overcome and come in front of everyone and presenting any kind of publication. So I don't think it was very much surprising.
Thank you.
Dr. Cox, do you have any questions?
So you just talked about some obstacles that female surgeons experience. Could you expand on what some of those obstacles may be?
Yes, ma'am. Thank you. Ma'am, according to our research, the obstacles were because in case of female representation, females have to face discrimination in parental leave policies, and moreover in societal and cultural discouragement, and there is lack of mentors to guide them for presenting any kind of articles. So that kind of discrimination, I think, present in this situation.
And would there be anything you would do to encourage authorship diversity? Could you comment on that, please?
Yes, ma'am. If we can build various organizations who can help females, like there is already an organization named Association of Women Surgeons, which was established in 1981, and they help women surgeons in case of community and leadership and various other experiences. So if that can possible in furthermore some more organizations can be founded, then it will be very much easier for them.
Great, thank you.
Thank you, ma'am.
Dr. Ashok, do you have any questions?
Yeah, so what do you think is future direction of your work, and what were the main limitations, how it can be mitigated?
Okay, sir. Thank you so much for your question. I would like to say there is already various publications regarding authorship diversity of Cochrane systematic review. You can see in PubMed there is already articles on gastroenterology, hematology, cardiology, but there is no representation in general surgery. So this will help furthermore and encourage more researchers to work on this kind of articles.
Thank you.
Thank you, sir.
Thank you so much, Dr. Biswas. Thank you, judges. And now let's move to our next presenter, Bassam Rajahi, junior medical student, King Saud bin Abdulaziz University for Health Sciences, Saudi Arabia, and his presentation is medical students' attitudes and influential factor towards conducting medical research. Welcome, Doctor.
Sound clear?
Yes.
Yes. Okay. Thank you. Should I start?
Yes.
Okay. Greetings, everyone. My name is Bassam Rajahi. I'm a junior medical student from King Saud bin Abdulaziz University for Health Sciences in Jeddah, Saudi Arabia. Today, I'll be presenting a study titled Medical Students' Attitudes and Influential Factors Towards Conducting Medical Research. I'd like to start by asking the audience a rhetorical question. Have you ever felt the need to conduct and/or publish a research project in order to increase your chances of getting accepted into a residency program? The most likely answer is yes, because medical research is becoming an essential part of medical education around the globe. Previous studies have showed that the earlier med students are exposed to research, the more that they will understand how to conduct it in the future. Due to this, several medical colleges in Saudi Arabia have made have made conducting a research project a prerequisite for graduation. Up to our knowledge, there were no available local multi-campus studies regarding this topic. So the aim of our study was to assess medical students' attitudes towards conducting medical research and to identify their motives. For the methods, this was a cross-sectional study that was conducted in the College of Medicine in King Saud bin Abdulaziz University for Health Sciences in both Jeddah and Riyadh campuses in Saudi Arabia. For the inclusion criteria, we included 3rd to 6th year medical students. The rationale behind this, that 3rd year medical students are the equivalent of freshmen in the United States or international medical education programs. For exclusion criteria, we excluded foundational and pre-medical students and as well as interns. The reason for our exclusion was that foundational and pre-medical students in our university study a different curriculum and they don't have a grasp of the concept of research. We also excluded interns since they were more likely have studied research during their years in medical school and have already conducted 1 to 2 projects and published them before they apply for residency. In our study, we utilized 2 questionnaires, the student's attitude toward research and the student perceived influential factors. We obtained permission from the 2 developers of these validated questionnaires. The survey included 4 sections. The first was regarding research activity, and the second regarding faculty involvement in mentoring the student, the third regarding the infrastructure facilities such as laboratories and libraries, and the fourth was regarding students' motives to why they conduct research. The survey was distributed among the students between December 2021 and April 2022. This study was approved by the Institutional Review Board, and we analyzed the data using the JUMP software. For our results, 500 students completed the survey in both campuses. The majority were 4th year students, male students from the Riyadh campus with a GPA that ranged between 4.5 and 5. The GPA in our institution is out of 5. Surprisingly, only a few of the students have had a prior research publication. However, over 60% have showed an interest that they want to participate in medical research. 56.6% have been exposed to the necessary tool to help them prepare a research project. Most of the students agreed that research is essential, whether in medical education or in clinical practice. There was a significant difference regarding getting the chance to discuss academic research, which might be due to the fact that not all the students are encouraged or even interested to conduct research. Significant difference was also found regarding the faculty members if they use their research findings as part of their teaching materials or not. Less than half of the students reported that the faculty don't have sufficient time to mentor them when they start their own projects. Also, the majority of the students agreed that their college has the adequate infrastructure to organize research programs. However, only 53% of the participants were satisfied with the research training program offered at their college. For the students' motive, the most common motive among the students to pursue research was to increase getting accepted into a residency or a competitive residency program. The second was to explore a specific research field or a medical topic. You can refer to Figure 1 for the rest of the motives. For future recommendation, future studies should investigate if those students who get accepted into those competitive residency programs, do they pursue research activity after college during residency, fellowship, and after when they become consultants? Also, how they acquired these research skills, whether through experience, training program, or research fellowship. There were some limitations to our study. First, it was conducted in one university, so the results might not be generalizable to all other universities in Saudi Arabia. However, we tried to minimize this limitation by including 2 campuses in 2 different cities. It was also a web-based survey, which might be a limitation. However, we tried to minimize any selection bias by collecting the data through email, social media platforms, as well as on-site. For the conclusion, medical students show a positive attitude towards conducting research, but they need supportive mentors and helpful resources to help them excel at their research career. Most students pursue research to gain a competitive edge, as well as to explore their specialty of interest before they choose them and pursue them for the rest of their lives. I'd like to acknowledge some people, Dr. Ahmed Al-Kuwaiti and Dr. Ahmed Abu Zaid, for giving us the permission to use their questionnaires, as well as my fellow co-authors, Ibrahim Omar, Rima Abu Najam, Faisal Al-Qahtani, and our amazing research supervisor, Dr. Al-Qasim Al-Hakimi. I'd also like to acknowledge all the data collectors, participants, and the students of my university who have attended the conference today to see all the amazing research that are being done by the students. These are the references for the presentation. If you have any questions, please don't go ahead.
Thank you so much, Dr. Bassam. And now let's move to our judges. But before that, let me remind our audience to vote for Bassam by scanning the code you can see on the screen. And let's start with the questions. Dr. Amy?
Yes, thank you for your presentation. Did any of these results surprise you?
We were surprised that not all of the students agreed, or not most of them agreed, that faculty involvement wasn't an obstacle. However, half of them did agree, and previous studies always reported that one of the main barriers that students face when they start their research career is that they don't have anyone to mentor them. That was surprising for us.
Okay, thank you.
Yes, thank you for asking.
Dr. Cox?
So thank you for your presentation. What's your opinion on the finding that residency is a key cause to do research? Do you think it's a valid reason?
Well, first, I think there's multiple layers to this question. So I do think that this might be a factor. However, I think the students should try to pursue other things, or that direct residency program directors should consider placing other factors, such as providing primary care, help volunteering, that will help the community. Because there has been recent studies where most students conduct research and they have some results, and sometimes it doesn't add much to the literature, and we end up with a lot of replicated study. And I don't think the students should be peer pressured to pursue research, but they should be encouraged, and they should have enough resources and mentors to help them during their career. Yeah.
Thank you.
Thank you.
Dr. Ashak?
Yeah, a good presentation. Thank you. So,
thank you so
I was
much.
just wondering, how does it compare to literature in the same geographic setting over time? And if you compare your results to the rest of the world, what do you make of your results and results from elsewhere?
I see. So for local studies, most of them have reported similar results, that the students are encouraged to do research to compete in when they apply for residency. And also most of them showed a positive attitude. But when you go abroad to different countries, they show that the same result. They do conduct it to get accepted, but not all of them have a positive attitude to a certain degree. So I think we should try to help the students without pressuring them. It shouldn't be a requirement to get accepted into residency.
Do we have any questions from the audience? Okay, so as long as we don't have any questions from our audience, I would like to thank you, Dr. Bassam, for your presentation, and I would love to thank the judges for their questions. And now
Thank
let's
you so much
move.
for having me.
And you're welcome. And now let's move to our next presenter, Ms. Nagham Jawish, Faculty of Medicine, Damascus University, Damascus, Syria. And her presentation will be Syrian health providers' knowledge of palliative care, an online cross-sectional study in Syria. Welcome, Dr. Nagham. You can start. Can you hear us? Okay. So it could be internet issues. Okay, so it looks like that the internet is bad. And let's move to our next speaker, Okanzi Kinchuko Franklin. I hope I'm pronouncing the name right. Mr. College Research Innovation Hub, University of Ibadan, Nigeria. And his presentation will be Gender Differences in Attitude and Barriers to Research by Medical Undergraduate students in Nigeria. Welcome, doctor. You can start.
Hello, good evening.
Good evening.
All right. I am Okunze Kenechukwu. I am a final year medical student from the College of Medicine, University of Ibadan, Nigeria, and I'll be presenting gender differences in attitude and barriers to research by medical undergraduate students in Nigeria. So I have no conflicts of interest to declare, and these are the members of my research team. So this will be the contents that I'll be following throughout the presentation. So overall, medical research has continued to expand at an unprecedented pace, and its benefits cannot be quantified. Advancements in medical research have led to improved quality of healthcare, and active involvement of physicians in research has been key because it creates an avenue for critical thinking, and it allows the rapid advancement of medicine. Also, when physicians are involved in research, it helps bridge the gap between the bench and the bedside. So we could easily translate research that goes on in the laboratory to allow it to influence patient care. So also, it's been noted that early involvement of medical students in research is very pivotal because it enhances interest of students in research, and students who have an earlier involvement in research are likelier to opt for a research-oriented career. And the early involvement of students in research also allows a robust pipeline of physician scientists. So while in most of Europe and in North America, students have a lot of medical scientist training pathways, that including the MD PhD or MD MPH, that could allow medical students to gain clinical training and a research degree. The situation is not so in Nigeria and in most of Africa. So overall, the picture in Nigeria, right, is the most research affiliated positions are within universities, and there are over 170 universities in Nigeria, and there's a skewed gender composition of university staff. A recent survey showed that less than 1/4 of university academic employees are female. So our study aimed to examine the gender differences in the attitude towards research, in the willingness to undertake research, and the barriers to research reported by undergraduate clinical students in Nigeria. So this is a map of Nigeria, and there are about 43 medical schools in Nigeria, but we only took responses from 7 medical schools in red. So, give me a moment, please. It only took responses from the medical schools in red here in the location. So we only sampled medical and dental students who were in their clinical years of training. We mean the 4th to 6th year. And we calculated our sample size, and we were expecting to receive responses from at least 629 students. So the data collection tool we used, because this is a descriptive cross-sectional study, so the data collection tool we used was arrived at following consultation with medical students, and it was also adapted from tools that have been used in other studies that addressed a similar scope. So for the final questionnaire, we had 56 items divided in 5 sections, and these are the sections. So this is a picture of the on the left side is a picture of the tool we use. This is the opening page that collects socio-demographic data, and the survey was hosted on RedCap, and it was distributed in August 2022 via WhatsApp and the Telegram group chats of eligible students. We obtained ethics approval from the local institution here, and all respondents participated in the research voluntarily, and their responses were anonymous. So overall, we collected them. And so all our variables were summarized using descriptive statistics, and we collected data on attitude to research, willingness to participate in research, and then facilitators and barriers that hinder research participation. So we used chi-square testing to examine associations, and then we adapted the p-value of 0.05 as the threshold for statistical significance. So our results, so overall, 829 medical students across 7 medical schools in Nigeria submitted responses, but only 687 students submitted complete responses. So we had more than half of our respondents were male students, and majority of our respondents of our participants
Just down 1 minute, doctor.
Were between 21 and 25 years old. So when we dichotomized the data based on gender, we realized that some things were statistically significant. For instance, we found that male students were likely to report that they found research exciting and enjoyable, while female students were likely to report that they found research complicated. We also realized that when we asked about barriers, female students expressed they were likely to agree that they lacked personal interest in research and they did not have enough time to participate in research, and these were all statistically significant. So our notable findings, although equal proportion of male and female students report voluntary involvement in research, and we have more female students expressing barriers to research than the male students. And male students were overall more willing to spend more than 3 months on a research project and pursue a research-oriented career. So in conclusion, for full-time research roles currently, a gender imbalance exists, and there's a need for us to address the inequality and halt the trend. Knowledge from this study can assist stakeholders to develop tailored approaches that will improve the perception of female students to research and address the peculiar barriers that female students highlighted. We also had some limitations from this study, and our findings might not be generalizable because we only sampled less than 20% of the medical schools in Nigeria. So these are our acknowledgements.
Thank you, doctor.
Thank you very much.
Thank you. And now let's move to our judges, but let me remind our audience to vote for you, Dr. Okonzi. So please scan the code and vote for our presenter. Let's get the questions from the judges, and let's start with you, Dr. Amy.
Thank you for your presentation. Did any of these results surprise you, and why?
Okay. Yes. Some of these results surprised me because I felt that overall, since male and female students are exposed to roughly the same training here in medical school, and they have equal exposure to teachings and to research lectures, I felt that they would express similar perceptions to research. But I was surprised that female students were likelier to find research complicated, while male students found it exciting and enjoyable. So then, yeah, so this was one finding that surprised me.
Thank you.
Dr. Cox.
Looking forward, how would you remove some of the barriers that exist for female students to do research?
All right. Okay. Thank you very much for your question. The lack of personal interest in research and the insufficient training in research methodology that female students reported, we can have targeted approaches to address these barriers. So it is likely that maybe female students perhaps are a little reluctant to approach lecturers following a research teaching to gain more knowledge about the subject that was covered. So we aim to establish an initiative for just female medical students where they could meet on a monthly basis, and they could discuss things that are pertaining to research. And we could also create a safe space for them to carry out research, and they can receive adequate support from both the faculty and from their colleagues.
Great, thank you.
Dr. Ashok, do you have questions?
Yeah. How does it compare to literature in the rest of the literature in general?
Okay. What we found here was in line to some of the studies we found from Uganda, where they also reported that lesser number of females had reported research scholarly output. So they had they had a disparity in the number of females that reported maybe either a presentation at a scientific conference or a publication. So I think it is widespread, especially here in Africa, where there is a large disparity in the workforce and even in the schools, even in the universities for male and female students. So I think there's a trend here, and I think there's a need for us to establish initiatives that can address these barriers.
Okay, thank you so much, Doctor, for your presentation. And I would love to thank the judges for their questions. And now let's go back to our previous presenter, Nagam Jawish from Syria. Okay, let's move to our next presenter, Dr. Sadiq Lawal, medical doctor, Obafemi Awolowo University from Nigeria, and his presentation will be assessment of work practices and health problems among filling station attendants in Ilifi in Nigeria. So welcome, doctor, and you can start.
Good day, everyone. Can you hear me, please?
Yes.
Okay, thank you very much. So my name is Sadiq Olatubosun-Lawal, and I'll be presenting the abstract of my research work titled Assessment of Work Practices and Health Problems Among Filling Station Attendants in Ile-Ife, Nigeria. So these are the names of my co-authors.
We are not able to see your presentation. Guys, we are seeing the main screen.
Okay. Can you see now?
No.
Can you see now?
I think we should stop. Okay. Sadiq, now present your presentation, please.
Okay, can you see my screen now?
No. Are you sharing the PowerPoint?
Yes.
Yeah, try please to share it.
Can you see it now?
For me, no, I'm not
Hello?
able. Yes, I can hear you, but I'm not able to see your presentation.
Sorry, let me.
It's fine.
Okay. 1 minute, please. Thank you.
Okay.
Can you see it now?
I can see the main screen, and now I can see a white screen.
Okay. Is it better? Can you see now?
Unfortunately, no.
Oh my God. I don't know what's wrong.
Okay, can you please
Let me try
stop
again.
sharing and open your PowerPoint and choose to present your PowerPoint, if you could please, not the main screen. So, okay, tell Dr. Sadiq has his
internet issue solved, or the problem with the presentation. Let's move to another presenter, Kate Zuki Wang, resident physician, UBC Family Medicine, Vancouver Coastal Health. And the presentation title is Mild Traumatic Brain Injury, What We Can Learn from a Qualitative Study of Patient Perceptions Following Emergency Department Discharge. Welcome, doctor. You can start.
Oh, hi. Well, this is a little earlier than expected, but hello. My name is Dr. Kate Wang, and I'll be presenting on behalf of Dr. Ward and Dr. McFarlane, who are part of the rehabilitation team for the traumatic brain injury of Cork University Hospital in Ireland. And our presentation is called Mild Traumatic Brain Injury, What We Can Learn from a Qualitative Study of Patient Perceptions Following Emergency Department Discharge. So, first side, a little bit about me. I completed my undergraduate in medical sciences at Western University, and then I was lucky enough to receive my medical degree from the University College Cork in Cork, Ireland, where I had this research study, and I'm currently a family medicine resident at the University of British Columbia in Vancouver. On that note, I do want to acknowledge that I'm coming from Vancouver on the unceded ancestral territory of the Musqueam, Squamish, and Tsleil-Waututh people. I have an interest in sports medicine, and that's a little bit about why I decided to study mild traumatic brain injuries, better known as concussions, during my medical studies. So MTBIs are very common, but patients often fall into this gray zone of care following their acute treatment. And while most patients will recover in a few days and sometimes a few weeks, sometimes people will have persisting symptoms for months, and after the 3-month point would qualify for chronic diagnosis that would be of post-concussion syndrome. And while this was thought to be more rare in the past, research is increasingly showing that patients present with both physical and psychological symptoms, sometimes even years afterwards. And she's in the literature pointing to maybe lack of standardized care and supports. In Ireland specifically, there is very little support available until patients reach this level of chronic diagnosis, which presents a large gap in care after emergency department discharge, the emergency department being where most patients first present with their head injury, and then when they're able to receive these supports. So the aim of the study was to investigate the experiences of patients with mild traumatic brain injury to identify barriers and suggest clinically relevant areas of improvement in the current Irish system of care. So what do we do? Well, 16 patients with a clinical diagnosis of MTBI, or more commonly written as concussion, were recruited from Cork University Hospital Emergency Department for participation. They were approached and conducted semi-structured phone interviews at the 2.5 to about 3-month point post-discharge. This time period was chosen as this is typically when most patients will have recovered from concussion or would qualify for that chronic diagnosis and therefore supports. So Braun and Clark's reflective thematic analysis with an inductive and realist approach was used to code and analyze the data. The most frequently occurring themes and their relationships to sub-themes are reported. So of our 16 patients, we had a good age range going from 18 to 85, but this did cluster into the older age group as our mean age was 50.5. The major themes identified in the experience of MTBI patients were lack of clarity in diagnosis and treatment, poor access to information, and ongoing symptoms. The vast majority of our participants reported being quite uncertain about their diagnosis of MTBI or concussion. And most of them as well didn't seek any further information regarding their head injury. And this would mean after discharge from emergency department. Approximately half of our participants reported prolonged recovery, which we defined as more than 2 weeks of symptoms, and 2 participants were reporting ongoing symptoms, therefore qualifying them for that chronic diagnosis. Of the predominant symptoms that were reported, headache, photophobia, and difficulty with thinking and memory were the most common. I do want to acknowledge that while percentages are reported here, they are meant for transparency purposes and aren't meant to be significant alone. So here in table 1, which might be a little difficult to see, I did want to highlight some quotes from patients that I feel really exemplify some of these themes and sub-themes. So in the sub-theme of lack of information seeking, Participant 7 here says, if I had looked up Mr. Google, I would have everything that was ever threatened. Well, this is very wise from participant 7, and it's something that we encounter a lot among our participants. Other participants are often just said they just didn't look for any information past the emergency department or what was given to them in the ED. Lack of available information was often split into 2 when we spoke with participants. There was a group of people like participant 12 who never received anything about a head injury, well, nothing that they recalled. She had a head wound and she said, yeah, she had received something for the wound, but they didn't actually give me anything about a head injury. And in other cases with participant 4, she'd received some form of information, a sheet, but was confused about it. And when asked if anybody had
1 minute, doctor.
Thank you. And when asked if anybody had walked her through this, she said no. And I really think they should. I think there should be more of a song and dance made about concussions, because if I had realized I was concussed earlier, I probably would have made some other decisions. I would have possibly had a better opportunity of coming out unscathed. And finally, with regards to unclear diagnosis, a surprising amount of our participants had never heard of any diagnosis at all. Participant 1 here says, I didn't receive any diagnosis. No, it was an injury. I had a good bang. And participant 10 reports, well, my understanding was just go home and get on with it. It was really interesting to see that many participants had never heard of the words concussion and even less mild traumatic brain injury throughout their time being treated for their head injury. So in conclusion, there were several overarching themes that were identified. Participants reported persisting symptoms, lack of clarity, and a lack of access to information regarding their MTBI diagnosis and treatment. Suggested areas of recommendation for future practice would include adding psychoeducational resources, most importantly, increasing awareness and training among staff in order to provide timely patient education. That means both a timely diagnosis as well as timely management. And that concludes my presentation. Thank you so much for giving me this time and this platform. Any questions?
Thank you so much, doctor. And now let's move to our judges. But before that, let me remind everybody to vote for Dr. Kate by using the code you can see on the screen. And let's start with Dr. Amy. Do you have any questions?
I do. Thank you for this presentation. What of the results or sub-themes surprised you the most and why?
I think the fact that there was this huge unclarity with the diagnosis of the fact of what is this head injury, what that meant, was really interesting to me, especially combined with the finding that most people did not search for more information. And initially among discussions, we thought, did they not look for more information because of general low literacy in terms of patient health literacy? Or is it the fact that if patients don't know what their diagnosis is, how can they look for more information? Would they know what they're looking for? And these are things that are largely part of the discussion, part of this paper. But I found that really interesting.
Thank you.
Yes, Dr. Cox.
Can you comment on what are some of the future directions for your work?
Absolutely. So thank you, Dr. Cox, for that question. So I was very lucky to have been a part of a larger team working at Cork University Hospital. And right now they've already begun to implement and create some of these psychoeducational resources. I hadn't explained this prior, but Dr. Ward is a neuropsychologist and Dr. McFarlane is a consultant in physical medicine and rehabilitation with a focus on brain injuries. So they're in the midst of creating better resources, whether that's in the form of videos and sheets and using QR codes like we're using right now in order to give patients hopefully something more comprehensive from that point of diagnosis in the emergency department to take home. So that's really exciting and is definitely something that is ongoing right now.
Great, thank you.
Dr. Ashok.
Yeah, so interesting study. So would you plan to do a quantitative study or to assess this further? Or how would you plan to do any further study in this regard with a more quantitative approach than
Absolutely. Well, thank you, Dr. Ashok, for that question. I would love to have repeated this with a much larger study population. And I think now that we have some some data from the smaller study and from that qualitative side of things, we can hopefully create maybe like a larger survey that can be distributed to more patients. And the more people that we get a part of this, the better quality of information, the better information we'll have. So hopefully that's something that we could do in the future. But research is often slow, but I think there are bright things ahead.
Thank you so much, Dr. Kate. Thank you for your presentation. And I would like to thank our judges. Thank you. And let's move to our previous, one of our previous presenter, Dr. Sodiq. Are you with us now? Yes, and we can see your
Yes, I
presentation.
am.
Good. You can start.
Okay, thank you very much. Can you see my slide now?
Yes.
Okay, thank you very much. So, good day, everyone. My name is Sodiq Lawa, and I'll be presenting the abstract of my research work titled Assessments of Work Practices and Health Problems Among Filling Station Attendants in Ile-Ife, Nigeria. These are the names of my co-authors. So for the background statement, filling station attendants are exposed to occupational hazards and health problems in their workplaces. And incidence is on the rise in low-income countries like Nigeria. And also because they are highly educated and because they are educated and with little remunerations, they are predisposed to having this. So the study was conducted to determine the work practices, occupational hazards, and health problems among filling station attendants in Ile-Ife, Nigeria. Next slide. Thank you. So the study location is Ile-Ife, which is an ancient university in southwestern Nigeria. It is about 280 kilometers northeast of, with a population of about 650,000. There are 64 filling stations in Ile-Ife, Nigeria. This is just the map of specifically Abuja and Ile-Ife that is our study location. So for methodology now, next slide, please. The study design, we use a descriptive listing attendants in Ile-Ife were our study population. So the inclusion criteria include filling station attendants that has worked for at least 3 months, and the exclusion criteria include filling station attendants that are sick, have obvious structural abnormality of musculoskeletal consent to our study. And the total sampling technique was used, and from there we obtained a sample size of 200. Data was collected via interview-administered questionnaire and observational checklist. Our data was analyzed using IBM version of statistical package of social sciences version 25, and a p-value of 0.05 was found to be statistically significant. Also, descriptive statistics such as frequency percentages were used to summarize the data. Also, we cross-tab using and we use chi-square to know some association between some socio-demographic factors and health problems. So this is next slide, please. This is a chart showing the results we got from our study. So a total number of 200 participants consented to participate, and the majority of the filling station attendants, that is about 74% of them, were not aware of workplace safety practices. And of those that were aware, 78% were aware of personal protective equipment, that is the PPE, and the commonest available PPE was face mask, which accounts for 41.5%. Also, 56% indicated that personal protective equipment available for them were not adequate. And concerning training, 62.5% had prior safety training, and only 66% and 56% of them use fire extinguisher and split it very well, respectively. Also, regarding occupational hazards, 74.5% of the attendants were aware of the various hazards, and the commonest being fire outbreak, which accounts for 69.5%. The commonest work-related problem was musculoskeletal disorders, and which accounts for 60.5%, while the least common was gastrointestinal tract problem, which accounts for 8%. Also, there was a significant association between age, work durations of the respondents and skin problems with p-values of 0.021 and 0.035 respectively. Also, there was a significant association between the body mass index of the respondents and the respiratory problem. So next slide, please. Thank you. So from our study, we found out that the awareness of safety practices among the respondents was 25%, which is very low compared to what Afolabi et al. In 2011 got from a study, and that was 92.6%. Also, we found out that the availability of personal protective equipment accounts for 78%, and which is closely related to what Afolabi et al. Also got in a study in 2011 to be 70%. Also, we found out that the commonest available PPE was face mask.
Doctor, less than 1 minute.
Okay, thank you. Which is in contrast with what Ogukwanya et al. Got in 2020. And it was boots, and it accounts for 34.9%. Also, this is just the most common health problems from our study were musculoskeletal disorders, neurological disorders, and eye problems, and which is also similar to what Isaac et al. Got in 2015, and which were musculoskeletal disorders, headaches, and low back pain. So this is just another table showing the connection between the health problems and some socio-demographic factors. So in conclusion, this study assessed work practices and health problems among physician attendants, and there was poor availability of personal protective equipment, inadequate use of this PPE, as well as poor work safety practices. And regarding health problems, the most common include musculoskeletal disorders, neurological disorders, and eye problems. So from our study, we recommend that interventions to improve availability, adequacy of use of personal protective equipment, and safety practices should be created. Also, provision of occupational health services to these vulnerable workers should be done. And we also recommend that a qualitative study to further assess the factors associated with health problems should be carried out. Thank you very much. And these are my selected references.
Thank you so much, Doctor. And now let's move to our judges. But before that, let me remind our audience to scan the code if they want to vote for Dr. Sadiq. And now let's start with Dr. Emi.
Thank you for your presentation. Did anything in the results surprise you, and why?
Thank you very much. Nothing surprised me from our study, because from what when we did our literature review, we found out that our results were similar to what similar studies in the past have done, and also we found out that it's majority of the problem is because of lack of knowledge of these attendants, and if they are properly educated, they will be able to do what is appropriate. Thank you very much.
Dr. Cox.
You commented that your own research is similar to prior research. Could you describe some of the similarities, and importantly, what are some of the differences in your research to prior studies?
Okay, thank you very much. According to Afolabi et al. In 2001, he also carried out research on the awareness of safety practices among these attendants in the Ile-Ife. And from a study, he found out that 92.6% of the attendants were aware of the safety practices, and which is actually in contrast with what we got from our study. From our study, we got awareness and safety practices to be 25%. However, the availability of personal protective equipment we got from our study was 78%, and that is similar to what Afolabi et al. Also got, and it was from a study it was 70%.
Great.
Also, we found. You're welcome.
Dr. Ashok.
So what do you think is the main limitation of your study, and how would you overcome in the future studies?
Okay. Thank you very much, sir. Because we use a total sampling method, and From there, we had to meet the chairman of the Association of Filling Stations in Ile-Ife, and from there, we were able to get our the names of the filling stations. However, we actually wanted to use a larger population size for our study. However, because of lack of there is limited amount of filling stations in Ile-Ife, and so we have to reduce our sample size to 200, using Arauye to reduce the amount of sample size. Also, it was because of the total sampling method, we had to be going to different filling stations, and sometimes they were busy and it was difficult for them to answer us, so we had to persuade them, and even some didn't give consent. And
thank you, doctor. And thank you for your presentation. And I would love to thank the judges. And now let's move to our next presenter, Andrew. Our next presenter, Andrew Gauger, second-year medical student at Indiana University, USA, and his presentation is a cholecystocolonic fistula, demonstrating the need for further imaging assessment following an abnormal ultrasound exam. Welcome, doctor. You can start.
Hello, can you hear me?
Yes.
And can you see the PowerPoint slides? Can you see the slides? I'm sorry.
Yes, we can see it.
Great. Yeah, today I'm excited to be here. I'm just going to give a quick presentation of a case report about the use of point-of-care ultrasound at a U.S. medical institution. So who's presenting? My name's Andrew. I'm a second-year student at Indiana University Medical School. And the attending physician who helped me put this case together and oversaw the patient I'm going to talk about is Dr. James Wilcox. He's faculty at this same medical school. The patient was seen at this hospital on the top right corner, Eskenazi. So what is point-of-care ultrasound? Well, it's an imaging modality that has become very popular in the US over the past years due to its portable nature and cost effectiveness. It relies on a handheld ultrasound probe that's used at the bedside. Because it's so portable and efficient, it can provide rapid answers to many clinical situations in very different contexts. You can scan different anatomical regions, and for that reason, it's very helpful in confirming or ruling out the presence of suspected.
So sorry, but can you please press on got it? Because this orange window. Yeah, thank you.
Is that better?
For sure.
So,
continue.
Okay. So yeah, point-of-care ultrasound can help rule out or confirm the presence of many different classic complications in patients, like a DVT, an abdominal aortic aneurysm, gallstones, among many other things. And it's best suited when the scope of the question is small, so it can give a binary and targeted answer to a rather limited question. This diagram kind of illustrates an ideal question for point-of-care ultrasound. So after the clinician consults with the patient and gets their chief complaint, they could suspect a gallstone, for instance. And then the clinician would then use the point-of-care ultrasound to provide a very targeted answer. Either yes, there is a gallstone, which would warrant further imaging in our patient, or no, which means you should reevaluate and consider a different complication. Now, the case in our patient, she was an older female with a history of COVID pneumonia. Her chief complaint was worsening dyspnea and peripheral edema, and her past medical history was significant for COPD, coronary artery disease, and heart failure. Now, upon using ultrasound on this patient, the clinician found worsening pulmonary edema, so he increased the dose of Lasix. Incidentally, during this evaluation, the patient also complained of right upper quadrant pain. So the clinician had the ultrasound probe ready, and he just decided to scan her in that moment to evaluate the gallbladder. On the left, we see a reference ultrasound picture of the gallbladder and liver. Here's the liver in red, gallbladder in green, and the IVC is below. On the right, we can appreciate in our patient scan a hyperechoic ring where the gallbladder should be, which includes a broad differential of cholecystitis, porcelain gallbladder, among several other things. But importantly, there was no gallstones in this patient as suspected. So this caused the clinician to order up a formal ultrasound exam, but unfortunately the patient wasn't able to see that in time, and she actually presented to the emergency department the next week with worsening abdominal pain. The radiologist noted an ill-defined gallbladder mass with inflammation, which was suspected to be a fistula with the colon. MRI was later conducted, and we can appreciate the same inflammation with the gallbladder and fistula with the colon. And eventually, interventional radiology was consulted to try to put in a drain for this patient. This was unsuccessful, but they did demonstrate the fistulization between the gallbladder and the cecum.
1 minute, doctor.
So this patient was found to have a poorly differentiated adenocarcinoma, and they were not a good candidate for surgery or oncology, and they passed from cardiopulmonary compromise before this could be started, which was very unfortunate. So going back to my previous question, we see that this patient in this case did not fit the classical treatment pathway. It wasn't a binary yes/no answer. Instead, there was incidental and abnormal findings that were picked up. And what's really, really important is that we emphasize the need to pursue further imaging once incidental or abnormal findings are found on an ultrasound exam. As noted with this patient, this was not her chief complaint at the time, the right upper quadrant pain, but the incidental finding of the gallbladder fistulization really required further high-resolution imaging in this patient. So in conclusion, incidental findings do not fit the traditional pathway when using point-of-care ultrasound. Although it's great for targeted questions, it's equally important to pursue follow-up imaging when you have incidental findings on such an exam. Thank you.
Thank you so much, Doctor, for your presentation. And now let's move to our judges. And before that, let me remind our audience to vote for Dr. Andrew by scanning the code you can see on the screen. And let's start with Dr. Amy.
Thank you for this presentation. What surprised you the most from this case?
Yeah, so I think, just the start of the case with the patient presenting with the chief complaint of shortness of breath and peripheral edema, so more cardiopulmonary symptoms. But then within the same clinic visit, she also brought up just right upper quadrant pain, kind of as a lesser complaint. And as I showed through the images, this turned out to be a very significant finding that was picked up on the ultrasound. So the fistulization was just something I totally did not expect considering how the patient presented. So it really opened my eyes to try to suspect or be prepared for anything upon evaluating a patient like this.
Thank you.
Yeah.
Dr. Cox.
Thank you for your presentation and case. Very interesting. Do you think there is a risk of delay in further imaging or treatment if we were to use point-of-care testing at the bedside?
Yeah, so I think there is a risk of delayed imaging. So point-of-care ultrasound is very handy to use, and it's good in real time. But as you point out, it's important to order follow-up imaging that's more in depth. And as shown in this patient, she received the bedside ultrasound, but wasn't able to be scheduled for a formal ultrasound examination within an entire week. So I guess it demonstrates a kind kind of a gap in the US healthcare institution, and at times how long it can take to get patients in for proper imaging, which I guess at the same time illustrates the need for point of care ultrasound in certain situations when we can quickly evaluate a patient.
Great, thank you.
Okay, my question is about ultrasound is in general is operator dependent. So what's your view on the focus and in terms of training, how much people should be trained to sort of be competent and make decisions?
Yeah, it's definitely user dependent, as you point out, and it requires a lot of training. At my medical school, they just implemented a new training program, which tries to get us around 20 hours of scanning per year. But the attending physician who oversaw this case has undergone many hours of training. And I think it's one of those skills where the more you use it, the more helpful and useful it will be. And it's definitely necessary for properly trained individuals to use it. So I think there definitely needs to be a system in place to establish the amount of hours required for such training. So, yeah.
Thank you so much, Dr. Andrew, for your presentation, and I would love to thank the judges for their questions. And now, let's move to our next presenter, Dr. Ana Karen Trevino Morales from Mexico, and her presentation is Comparison of Risk Factors for Developing Liver Fibrosis in Subjects with and Without Metabolic Syndrome, a cohort study. Welcome, doctor. You can start.
Thank you. Can you hear me?
Yes.
Okay. Good afternoon. I am Ana Karen Trevino Morales, a last year medical student, and today I'll be presenting the work entitled Comparison of Risk Factors for Developing Liver Fibrosis in Subjects with and Without Metabolic Syndrome, a cohort study. This is my team of work, and this is our workplace, the Facultad de Medicina and Hospital Universitario Dr. José Eleuterio González, and we are a team from Monterrey, Mexico. To start, I'll talk about metabolic syndrome. Metabolic syndrome is a disease that arises with a combination of others, such as diabetes, high blood pressure, and obesity. And it is the most common risk factor for developing non-alcoholic fatty liver disease, which is a condition that causes liver damage ranging from inflammation to fibrosis, cirrhosis, and culminates in hepatocellular carcinoma. Liver fibrosis itself is characterized by excessive deposition of collagen and other extracellular matrix proteins in the liver. Despite this, subjects without metabolic syndrome may also develop liver fibrosis. This is why we asked ourselves, what are the factors directly influencing its development and progression? And that's why the objective of our project was to compare anthropometric, genetic, and biochemical parameters in subjects with or without metabolic syndrome and at risk for developing liver fibrosis. So from a 2015 state health survey of the state of Nuevo León, anthropometric data and blood samples were taken and analyzed, obtaining from them biochemical parameters and liver function tests. And after this, the blood samples were stored. From the database created at that time, we took a randomized sample of 200 individuals. Our inclusion criteria were having a previously stored blood sample and being 18 or more years old. Then we classify the individuals according to the NAFLD fibrosis score, which is a non-invasive method used to determine the risk of fibrosis and uses data such as age, body mass index, albumin, platelet count, and the AST-ALT ratio for its calculus. We also classify them according to the presence or absence of metabolic syndrome based on the International Diabetes Federation criteria. Four study groups resulted: high risk with metabolic syndrome, high risk without metabolic syndrome, low risk with metabolic syndrome, and low risk without metabolic syndrome. Finally, we performed a genotyping study to the previously stored blood samples using the qPCR technique and according to two variants in 4 genes related to adipocyte differentiation, liver, and glucose metabolism. Comparison between groups were made, first to see if the polymorphisms were related to the risk of fibrosis, next to evaluate if the biochemical parameters were influenced by the presence of the polymorphisms in subjects at high or low risk of fibrosis, and finally, to evaluate whether there was a relation between the anthropometric and biochemical data in subjects at high or low risk of fibrosis with or without metabolic syndrome. Our statistical analysis was performed with the SPSS Volume 22 platform, and a p-value of less than 0.05 was taken as the level of significance. A total of 134 subjects were included and divided into 4 groups already mentioned. First of all, we found out there was no association between the variants and the risk of fibrosis. We also found statistical significance for high cholesterol blood levels in subjects at high risk of fibrosis that were also carriers of the T allele with the variant RS780094 of the glucokinase regulator gene. And finally, we found out that a higher age, a decreased platelet count, and an increased AST-ALT ratio were significantly different in high-risk subjects independently of the presence of metabolic syndrome. And this last finding can be shown in table number 1. I'd like to make emphasis and apply this knowledge by providing adults with prevention methods aimed at eliminating relevant risk factors for developing liver fibrosis, and also on running screening tests once a year throughout blood samples, specifically making emphasis on calculating the AST-ALT ratio, because in early stages of the disease, the transaminases might be within normal values, while the ratio might be altered. And also, it is important to, thank you. It is important to calculate the platelet count, because thrombocytopenia, I'll tell this in my conclusion, aging, thrombocytopenia, and increased transaminase ratio were found important risk factors for fibrosis in subjects without metabolic syndrome. Also, that the previously mentioned variant of the glucokinase regulated gene was found related with hypercholesterolemia, even though this lipidemia was not found associated with risk of fibrosis in our study. And finally, that none of the genetic variants analyzed resulted associated with the risk of fibrosis. Thank you.
Thank you so much, Dr. Anna. And now let's move to our judges to hear their questions to you. And let me remind our audience to vote for you, Dr. Anna, by scanning the code you can see on the screen. And let's start with Dr. Cox.
Thank you for your presentation. Could you comment how your paper or your investigation will impact in the real world or in the clinic?
Yes, since we found out that the variant in the glucokinase regulator gene was associated to hypercholesterolemia, and this variant has also been shown to be related with has shown to be associated with an increase in lipids and with insulin resistance, increase in AST-ALT ratio, and also other metabolites. This is important because with our findings, we can take and apply this information by using this information when we are evaluating once a year our patients and running blood samples, specifically taking into account to make a hematic biometry and biochemical parameters to calculate the AST-ALT ratio, and the platelet count, because as I mentioned during my presentation, thrombocytopenia is one of the most common complications of advanced liver fibrosis, and it is shown it tends to occur even before the clinical manifestations of liver dysfunction associated with decompensation occur. So to how can I say it? To conclude, I'd like to say that it is important to carry out this analysis in our patients to evaluate them, and not wait until the clinical manifestations of the fibrosis or the liver dysfunction show.
Great, excellent job. Thank you.
Thank you.
To you now, Dr. Ashok.
Yeah, good study. And I was trying to get understanding of how it relates to previous literature and what other genes would you look at in polymorphism we would look at in future.
Okay. We decided to evaluate these genes because they are mainly influencing lipid metabolism, glucose metabolism, and adipocyte differentiation. And our study relates with previous studies because in these genes, these have shown to be associated with liver fibrosis in Hispanic population, even though our study didn't find that.
Dr.
Thank you for your presentation. Did any of the results surprise you, and why?
Yeah, actually, the result that mostly surprised me was something that we didn't find, and I thought we were going to find association with the PNPLA3 gene and the risk of fibrosis, because it is the most studied gene in Hispanic population associated to liver fibrosis. But we didn't find association of this gene with our individuals. And from what we did find, what surprised me was that the glucokinase regulator gene was associated with hypercholesterolemia, even though in subjects at high risk of fibrosis, independently of the metabolic status of the subjects.
Thank you.
Thank you, Dr. Anna, for your presentation, and I would love to thank our judges for their questions. And now let's move out to our next presenter, Alexa Misisi, Faculty of Medicine, University of Belgrade, Serbia, Department of Peripheral Nerve Surgery, Functional Neurosurgery, and Pain Management Surgery, Clinical for Neurosurgery, University Clinical Center of Serbia, Belgrade, Serbia. And his presentation is peroneal nerve injury due to hip surgery located at the knee level, a case report. Welcome, doctor. You can start.
Thank you. Thank you very much. Dear audience, my name is Alexa Micic, and it is my pleasure to be with you today and present you a case of peroneal nerve injury due to hip surgery located at the knee level. I have nothing to disclose. About me, I've always wanted to be a surgeon. Most of my high school days I spent in Petnica Science Center, where I fell in love with neuroscience. Last 2 years of my studies at the faculty I spent on clinic for neurosurgery at the Clinical Center of Serbia, where I met Professor Lukas Rasulic and his team. I graduated from the university 2 months ago, and now I am a PhD student in neuroscience and intern at the Clinic for Neurosurgery. Together with Professor and his team, I worked on multiple projects and cases, among which is the one that I'm presenting you today. Peroneal nerve palsy associated with the hip surgery is already described in the literature. The patient recovery is usually poor and it often requires additional surgery. It may be ipsilateral due to direct injury of sciatic nerve by the orthopedic surgeons or the nerve compression due to postoperative fibrosis. It may also be contralateral due to peroneal nerve compression by the operating table, which is not specific to the hip surgery because it can develop during other types of surgeries. However, there is no data about ipsilateral palsy due to peroneal nerve compression, and I aim to present you such a case. A 30-year-old female patient was admitted to our department due to left-sided peroneal nerve palsy. She was injured in a traffic accident 8 months earlier and acquired left hip dislocation and acetabular fracture. Following open reduction of the acetabular fracture, the left peroneal nerve palsy developed. The medical research Castle muscle scale was used to evaluate muscle strength, and the score was 2. The visual analog pain scale was used to evaluate pain, and the score was 3. Electromyoneuropathy was used to verify peroneal nerve lesion, while ultrasound indicated that the nerve was compressed at the knee level. The surgery was planned to regain nerve function. After skin incision and dissection of the soft tissue, the first step in every nerve exploration is to identify the nerve of interest. Following the identification, a continued nerve exploration is performed in order to identify terminal and side branches. The third step is to provide external neurolysis, decompression, and complete the liberation of the nerve and its branches. At this slide, we can, if it goes well, at this slide, we can see completely deliberated peroneal nerve with its branches, deep branch, sensory branch, superficial branch, and articular branch. The patient reported immediate relief following surgery. 2 months after, there were signs of motor recovery, improved foot elevation, and improved gait performance. 3 months after, there was a significant motor recovery, foot elevation almost completely restored, and insignificant gait disturbance, mostly due to pain. 8 months after, complete motor recovery was achieved. MRC score was 5. Foot elevation completely restored, and visual analog pain scale was 0. No gait disturbances. What is the mechanism of injury in this particular case? We assume that it may be peroneal nerve compression under the head of fibula due to leg crossing during urgent hip surgery. This is different compared to nerve compression by the operating table because in this case, nerve compression is ipsilateral, and leg crossing such as this is unique for urgent surgery. To conclude, the cause of peroneal nerve injury, the cause of peroneal nerve palsy after hip surgery may not always be located at the hip region. Proper anamnesis, physical examination, and diagnostic evaluation are necessary for proper treatment of these patients. Orthopedic surgeons and anesthesiologists should be more educated about this type of injury. And thank you for your attention with some beautiful pictures of our beautiful country.
Thank you so much, Doctor. And now let's take the questions from the judges. But before that, let me remind our audience to vote for you, Doctor, through scanning the code and just to vote. Let's start with you, Dr. Amy.
Thank you for your presentation. I really enjoyed the videos that you had included. What about this case was the most surprising or interesting for you?
The surprising was the fact that we couldn't realize what's the etiology of the injury, how it developed. So this is, as we know, the first time described case like this in the literature. So it took us a lot of time to realize where was the problem, and in talks with our orthopedic colleagues, we realized that when they told us how they do the urgent hip surgery, then we realized that where the problem may be. So that it was the whole case is interesting. And there's nothing special interesting. The whole case is interesting.
Thank you very much. Looking back and reflecting on the case, would there be anything that the team would have done differently, particularly any imaging or other investigations that would have been useful for this patient to get a faster diagnosis?
Not exactly. The problem in this patient is because they are orthopedic patients, and there is a long time needed after the recovery from the orthopedic surgeries so that we can perform peripheral nerve surgery. And we knew by using IMNG and ultrasound, we know where the nerve is problem, where is the problem with the nerve, and we can operate it immediately. But just we couldn't realize how it developed, which is not very important for us for treatment in this particular case.
Great. Is there anything you would have suggested your team have done differently?
No, I think we've done everything excellent.
Great. Voila. Thank you.
Thank you too. I just wanted to ask you if my slides were going as I talked, because I was looking on the other screen and it looked to me like it's late to my talk. Were the slides?
No, perfect. Thank you.
Thank you. Thank you.
Dr. Ashok?
Yeah, you mentioned it's first case you're aware of in the knee, or similar phenomena. Has it been described elsewhere, or is it completely new sort of finding?
As we know, it's new because peripheral nerve surgery in these amounts are performed rarely where in the world. So we perform a lot of peripheral nerve surgeries, and in 20 years of practice, we had about 65 peroneal nerve injuries, out of which I say about 20 were associated with hip surgery. Out of these 20, 2 to 3 were associated, 2 to 3 were located at the knee level. So we have a series of cases, and we plan to publish a series of cases, but this is like first time we publish it as a case report.
Okay. Thank you.
Thank you so much, Dr. Alexa. Thank you, judges.
Thank you.
And maybe we do some announcements here. Just to remind you that next week, our call for editorial team will be open, so stay tuned. Just to apply, all you have to do is sending us your CV, motivation letter, and your availability during 2023 to the email you can see on the screen. And once you're accepted, either you have applied for a student editor, associate editor, and even an ambassador for your country, you will be asked to carry out some courses on the Web of Science Academy and Cook Committee of Publication Ethics. And of course, next year conference call for abstracts will be open in July to September. So start preparations and spread the word so your colleagues can participate. And remember that the International Journal of Medical Students publishes original research and experiences of medical students and recently graduated physicians all year round. So please donate donate at www.ijms.info. And as you know, IJMS is a non-profit organization registered in the US, and that we do not charge for publishing articles, authors, nor the readers to access the publications. So our resources all come from donations. And don't forget to follow our social media, Instagram, Facebook, Twitter, LinkedIn, and subscribe to our YouTube channel. So now we are going to take a really small break before we have our last presenter for this session. So please, judges, stay with us. We still have one more. And yeah, see you soon. Welcome back again. And we still have another presenter, but now we will hear Nagam Jawish. We tried to listen to her earlier this session, but unfortunately, because of the internet, we couldn't. Nagam, can you hear us now? Nagam? Guys, are we able to hear her? Maybe we wait. Nagam?
Hello, can you hear me?
Yes, yes.
Are you hearing me?
Yes. We can hear you.
Is that okay? Can I start?
Yes, for sure. Go ahead.
Yeah. I'm Nagam Jawish. I'm Nagam Jawish from Syria, and I'm studying at Faculty of Medicine, Damascus University. And today I'm going to talk about palliative care and our research that evaluate knowledge of health providers about palliative care. Palliative care is a method to alleviate pain and enhance the quality of life for patients suffering from the consequences of a life-threatening illness. According to studies, 40 million people worldwide need palliative care as part of their treatment regimen. Around 34% of these patients have cancer, and the majority live in low and middle income countries. It is thought that palliative care is offered for only 14% of cancer patients who need it. Palliative care aims to reduce pain and other symptoms, make patients as comfortable as possible in their last days, satisfy the needs of patients and their families via the collaborative efforts of a multidisciplinary team. The knowledge of palliative care among healthcare professionals is poor. Therefore, training programs are needed to offer patients appropriate treatment and improve their health. In Syria, as palliative care programs are rarely applied, we aim to evaluate the knowledge regarding palliative care among healthcare workers. If we take a look at the methodology of the research, as you can see, this is an online cross-sectional study conducted between July 24 and August 28, 2022 to measure palliative care knowledge and its applications among Syrian healthcare workers. The questionnaire for the study was designed in light of the previous study, and the inclusion criteria were Syrian healthcare workers, including physicians and nurses, as well as medical and nursing students. Participants from outside the medical field and those of non-Syrian nationality were excluded from this study. The items in this questionnaire were based on previous reviews and expert discussions, and they were used as an assessment tool to assess healthcare providers' knowledge of palliative care. The 4 sections of the questionnaire included socio-demographic information such as age, gender, and marital status in the first part, while the second, third, and fourth parts assessed experience, knowledge, and attitude toward palliative care among healthcare workers, respectively. The Syrian Ethical Society for Scientific Research approved the project on ethical grounds. Data were analyzed in IPM SPSS version 28 using descriptive and multivariate logistic regression analysis. So, moving on to the results, among 602 participants, 66.2% of participants were females. Most respondents were medical students, 72.9%, while residents and nurses or nursing students represented 18.8% and 8.3% respectively. The majority of participants, 84%, answered the question about pain treatment goals correctly, while a small percentage, 5.3%, answered the question about whether or not long-term opioid use is addictive correctly. No significant difference in the overall knowledge score was shown among geographical areas, genders, and different specialties. Regarding the knowledge questions related to palliative care, only 14% of participants were considered knowledgeable. The 3 most responses that received agreement regarding the attitudes toward palliative care were pain relievers should be given as needed to terminally ill patients, 89.7%. Spiritual care must include counseling for the terminally ill patients,
Less than 1 minute, doctor.
84.3%. Patients have the right to determine their own degree of psychosocial intervention, 81%. A significant difference existed between urban and rural residents in terms of the attitude score. When comparing first-year students to those in their 5th year, students in their 5th year were 8.06 times more likely to have a positive attitude. I want to conclude that our results demonstrated that healthcare professionals have inadequate knowledge about palliative care. There is an urgent
Hopefully
need
you are
to
doing well.
introduce palliative care to the health system in Syria in order to improve the quality of life of these patients in their terminal stages of illness and to provide care for patients who need it. Thank you for your attention, and I wanted to thank the International Journal of Medical Students for this amazing opportunity. I'm working on more research, and I'm looking for achieving more progress in the future.
Thank you, Dr. Nagam. And now let's move to the judges to hear their questions. And before
I'm
that,
listening to you, Judge.
Perfect. And I'm just asking the audience to vote to you by scanning the code that we can see on the screen. And let's start with Dr. Amy.
Thank you for this presentation. What surprised you the most?
I tried to share my photo, but actually the internet is so bad, so...
It's fine, Nagam. Did you hear the question of Dr. Amy? Guys, can we write to Nagam so she would be able to answer the questions? I feel that she is not listening.
I'm trying to share you the slides. Is that clear?
It's downloading, but now we are in the part of judges asking you questions, and Dr. Amy asked you, what about the study surprised you the most? Can you hear us?
Actually, the knowledge score was too poor. Only 14 participants answered the full question about knowledge, and the knowledge score was too low. So the knowledge and the attitude about palliative care among healthcare workers was too poor. We aim to raise the level of knowledge among healthcare providers.
Okay. Maybe we move to Dr. Cox. Dr. Cox, her question to you and Nagam.
Maybe I
how
didn't.
Yeah. Okay. Yes, you want to
through
say something?
campaigns and other plans, maybe to introduce palliative care in educational programs. We have to make medical students more knowledgeable about and the knowledge gap by any way needs to be rapidly addressed, and knowledge can be improved through simple logical and correct decisions.
Okay. Yes, there is a technical difficulty actually.
Maybe
Yes,
you can repeat the question, please. Maybe I didn't understand it. I'm sorry. You can
What
repeat the question for me, please?
What a question. You have Dr. Cox asked you, you can look at the chat and see the questions. Dr. Amy sent you a question and Dr. Cox sent you a question. Dr. Ashok doesn't have any question for you. Nagam, can you hear us?
For the first question about Dr. Amy, what about the study surprised you the most? I think the low level of knowledge, because only among 602 participants take part in this study, only 14 participants were able to correctly answer all questions related to palliative care knowledge. And so surprised, this percentage was so surprised. It's not 14%, it's 14 participants among 602 participants. And this percentage is too surprised. And concerning the second questions for Dr. Cox, who do you increase the awareness of palliative care specialty advantage? Actually, palliative care knowledge can be improved through simple, logical, and correct decisions. First and foremost, its inclusion in early medical and nursing education and undergraduate studies ensure its mastery following graduation. We should learn medical students about palliative care.
Okay, Nagam, thank you so much.
This knowledge gap needs to be rapidly addressed in, not only because it's one of the issues that Syria Medical School must work on, but also because the use of palliative care in
Nagam, thank you so much. The time has already
hoping that was good.
Yes, it was. Thank you so much, dear. Thank you for your presentation, and I can understand the struggles.
Thank you for your time.
Thank you for the. I would also love to thank the judges, and now we will see a registration, a video registered by our previous presenters, also from Syria, Mr. Haider Ibrahim. Can we have the video?
Haider Bohsas, a fifth-year undergraduate medical student at the Faculty of Medicine, Aleppo University, Aleppo, Syria. I'm going to introduce my second abstract entitled Assessment of Syrian Obstetrics Care Providers, Knowledge, Attitude, and Practice Toward Preconception Care and Associated Factor, and online cross-sectional study. Now, for the background, preconception care was instituted in 2013 by the World Health Organization to promote more attention to pregnant women by medical staff. Preconception care attempts to optimize pregnancy outcomes and promote health by managing and treating variables that influence it. Obstetric care providers in low and middle income countries have been reported to have low levels of preconception care awareness. So in Syria, there is no previous research about this topic. So this study aims to investigate the knowledge, attitude, and practice related features of obstetric care providers in Syria's public health institutions about preconception care. Now, in the method section, a cross-sectional study was conducted in Syria between September to 7 of October 2022 to evaluate obstetric care providers' knowledge, attitude, and practice at public health institutions regarding preconception care and related concerns. The questionnaire was designed using a validated scale from a prior research conducted in Ethiopia. The inclusion criteria for study participants were obstetricians and gynecologists, midwives and residents, and nurse of obstetrics and gynecology. There were 6 sections in the questionnaire: socio-demographic information, including age, gender, place of residency, economic situation, knowledge section, practice and attitude section, additional factors associated with preconception practice, and related actual and potential access to resources. The data for this research was analyzed using IBM SPSS version 28 software, and we performed a descriptive and multivariate logistic regression analysis. Now, for the results, there were 499 participants involved in this study, and the average age for participants were 31.8 with a standard deviation of 9.7. Most of the participants were female, accounting for 81.8%, and more than half of the participants were physicians, accounting for 60%. 91.4% of respondents have a good knowledge about preconception care. The most identified question by the participants was women intending pregnancy should be encouraged to defer pregnancy until they have reduced their drug, alcohol, and cigarette usage, which account for 96.2% by the participants. 24.8% of participants regularly inquired their patients about their reproductive life plans, with women aged 18 to 49 being the most open question group. Only 18.6% of physicians routinely inform their patients about the environmental danger and contaminants, and that's an important thing because infections during pregnancy can affect the pregnant woman and its baby very bad. So physicians should be aware about this topic. In addition to 53.5% of respondents inquired about the patient's surgical and medical history. Now that's very important because approximately half of the respondents, only half of the respondents inquire about the patient's surgical and medical history because some surgical procedures may affect the way of delivery, and previous disease may be important or during the pregnancy, so the doctors should seek about the past surgical and medical histories for their pregnancy patients. 29.7% of participants strongly agree that preconception care provides an opportunity to improve the health of couples, particularly women, whereas 80.2% are certain that preconception care does not belong to their scope of duties. Knowledge was more likely to be poor among participants who had never seen a doctor practicing preconception care than among those who had, with an odds ratio of 2.8, and participants who did not get training on reproductive life plans examination throughout their practice time were less knowledgeable than those who did, with an odds ratio of 2.9. Now, to conclude our abstract, we can say our results have shown that obstetrics care providers in Syria have a good knowledge of preconception care, but low to moderate practice and attitude towards this topic. Now, that could be explained by the fact that they have a high knowledge because preconception care concept maybe existed in their curriculum during their residency time, but there's no actual practicing for the preconception care during their residency. So that's an important thing. Improving access to training, career development, internet, and library services is vital to improve the preconception care training. Now, it's recommended that extra platforms to be made accessible to obstetrics care providers during their training to assist them in becoming preconception carers and in raising awareness about the significance of the preconception care. Thank you very much for your listening. Hopefully it was good information. Thank you.
Thank you so much, Dr. Haider, for this registration. And I think the judges giving you their questions. Dr. Amy already asked you what about this study surprised you the most?
Yes, first of all, my name is Haider Bohsas, not Haider Al-Ibrahim. And for the question about what about the study surprised me the most is that preconception care in Syria is not practiced the well during their the residency program of the OBGYN
Doctor, can you hear us? Dr. Haider? Okay, so it looks like that the internet is still not working very well. And now, thank you. I would love to thank the judges for being with us this whole session. Thank you for your insightful questions and your for time. Thank you, Dr. Amy. Thank you, Dr. Cox. Thank you, Dr. Ashok. I don't know if you want to say any final words before you leave us.
Thank you for having me here. I think it's really important for all the medical students and junior doctors to appreciate what they've done, and congratulations to them. But also to always remember that it's about what your research provides and looking at the future directions of it. And that's probably the most important thing when it comes to research. So thank you.
Thank you. Dr. Ashok?
Yeah, thank you for having me. It was good set of presentations. So general tip is always do a thorough literature search, mention it in a statement or two, and then also in the discussion, just critically think and highlight the limitations of your study and how you try to overcome it. And as Dr. Cox mentioned, future research direction. So it has to be some of the presentation covered it, but these are some of the points which are quite important. But well done on all the hard work, and nicely done.
Thank you. Dr. Amy?
Congratulations to all the presenters today. I would encourage you to stay curious and to be open to the opportunities that are around you, because there's always something to learn.
Thank you so much. I would love to thank you, all of you, for your time. And now, before we announce the awards, we will have a little break and we will see you after it. So stay tuned. What? Can you hear me? Welcome back, everyone. And now let's welcome Dr. Francisco Pinella Escobar again. Welcome, doctor.
Thank you very much. Can you hear me? Yeah.
Yes, we can hear you very well. And now the moment you've been all waiting for to announce the winners. We will be having 5 categories to announce the winners for. And I will start with the first one, if you allow me, Dr. Francisco.
Yes, I would like first to start thanking everybody for joining us today for this amazing effort, and to the organizing committee for all the work that they put together. Thank you very much, Dr. Duha Shela, for being an amazing host. You have exceeded all of our expectations. Thank you very much. We are really thankful with you. We're going to have several categories of awards. The first one is going to be the most liked by the public. The second one is going to be the higher score during the abstract revision process for original research. The third category is going to be higher score during the abstract revision process for case reports. The fourth one is going to be the first and second places for base case reports presentations at the World Conference of Medical Students Research based on the judge scores. And finally, last but not least, the first, second, and third awards for best research presentation at the World Conference of Medical Student Research, original research based on judge scores. So without further ado, Duha, please begin with the first category.
Thank you so much. And I will start with the first category, which is most liked by public. And we have one winner, and the most liked by public: medical students' attitudes and influential factors towards conducting medical research, by Bassam Al-Rajahi, junior medical student, King Saud bin Abdulaziz University for Health Sciences, Jeddah, Saudi Arabia. Congratulations.
Congratulations, yes. Without further ado, the higher score during the abstract revision process for original research, the third place is going to be for the study entitled Healthcare Seeking Pathways of Physiatry Patients in North Karnataka of India, a hospital-based exploratory cross-sectional study. We got a tie on this category, so we have 2 third places here. The first third place is for Dr. Alinas Khan and his team. They were third-year medical students from SN Medical College and ASSK Hospital, Bangalore, Karnataka, India. This abstract scored 65 out of 70 points in average in the revision part. The tie third place goes for gender differences in attitude and barriers to research by medical undergraduate students in Nigeria by Dr. Okunse Kenechukwu, Franklin, Minster College Research Innovation Hub, University of Ibadan, Nigeria, with, again, an average score of 65 out of 70 points. The second place for the highest score during the abstract revision process for original research goes to the study entitled The Impact of COVID-19 on People's Access to Healthcare and Health Behavior in a Sample of Indian Population, a cross-sectional study by Dr. Manisha Kanumuri et al., an intern for the Medicity Institute of Medical Sciences in India, with an average score of 67 out of 70. Last but not least, the first place for the higher score during the abstract revision process for original research goes to the study entitled Correlation between Placental Histomorphology and Umbilical Cord Coiling Index in Preeclampsia, Cyrus Kimanthi, a 4-year medical student, BSIC in Anatomy, Department of Human Anatomy, University of Nairobi in Kenya. The average score for this study was 68 out of 70. Almost a perfect score. Congratulations to all the winners.
Congratulations to all the winners in this category. And now let's move to the third category, which is the higher scores during the abstract for case reports. And we have 2 top places. The second place goes to
Herald Queen, color change in a neonate positive to COVID-19, a case report was presented by Dr. Benel. She is a fifth-year medical student from Honduras, and she got an average score of 60. And the first place goes to peroneal nerve injury due to hip surgery located at the knee level. A case report was presented by Dr. Alexa Misisi from Belgrade, Serbia. And you got an average score of 63. Congratulations, both. You did amazing.
Congratulations. Now we're moving into the fourth category of awards. Duha, this is very exciting. This is with the results of the judges scoring the presentations. It's been a long day, I know, and we have been waiting for this. These are the second and first awards for best case report presentation at the World Conference of Medical Student Research based on judge scores. The second place goes to the study title, A Case Report of Rare Type of Chorea with Hypoxic-ischemic Insult by Rohi Kolte, a 6-year medical student of Bogomolets National Medical University in Kiev, Ukraine. Congratulations. And the first place for the best case report presentation at the World Conference of Medical Students Research based on the judge score goes to the study title, Hypercoagulability and Cavernous Sinus Thrombosis due to Protein C Deficiency, a case report by Drs. Wilson Sebastian Peñafiel Pellares and his team of researchers. They are from the University of Americas, Quito, Ecuador. Congratulations all.
Congratulations all. And now let's move to our last category. We have the first, second, and third awards for best original research presentations based on judges' scores. And let's start with the third place. And the third place goes to determining the ability of the vision, aphasia, and neglect stroke scale to identify large vessel occlusion strokes within the pre-hospital setting, a prospective cohort study, which was presented by Lydia Leviate, fourth-year medical student at University of Illinois, USA. Congratulations. And the second place goes to efficacy of rectal misoprostol versus oxytocin on reducing blood loss during cesarean section. A meta-analysis of randomized clinical trials was presented by Dr. Ahmed Soliman, Faculty of Medicine, Mansoura University, Egypt. And the first place goes to morphometry of placenta of anemia and non-anemic preeclamptic patients, presented by Dr. Muhammad Onyenagwa, Human Anatomy, PS from Kenya. Congratulations all. You did amazing.
Congratulations, everybody. This is such an honor to have you here presenting in our conference. We hope to see you next year. Thank you again, everybody, for joining us. We will be sending the certificates. The abstract book is going to be published next week. It was an honor to host this conference. We hope to see you next year. Don't forget all the announcements. We have our call for editors open next week. We are a nonprofit registered in the US, so don't forget to donate. You can send articles all year round, right, Duha?
Yes.
Any original research, reviews, case reports, experiences that you have. Don't forget to subscribe to our YouTube channel. Follow up in our social media. Like our presence is 20,000 people right now, but we know that there are more than that in numbers of medical students. And our aim is to reach you guys all. So thank you again for this effort, everybody, for joining us today. Duha, please.
Thank you so much, Dr. Francisco. Final words. I want to thank everybody who contributed to make this a big success for the whole team of IJMS, for you, Dr. Francisco, for Cesar Porva, for Camelia, for everybody who is working backstage, for all the presenters, the judges, and everybody who just helped us and contributed to this amazing conference. Hope to see you next year. And as Dr. Francisco said, we will be sending you the certificates and we will be contacting the winners, absolutely. And we will feel so sorry for those who couldn't present with us today and had some struggles with the internet and issues and so on. So thank you, everybody. And I think now we have to say goodbye after these 9 crazy hours of hosting an online conference. Thank you so much. I am your host, Dr. Duha Shilla from Nablus, Palestine. See you next year.
Yeah, thank you.
Bye-bye.